ঠিক বললো কি সিবি কনসেপ্ট
A very warm welcome and good morning to all. Myself, Dr. Swati, would like to welcome chairpersons for today's session, Dr. Joseph Montero, consultant neuroanesthesiologist, PD Hinduja Hospital and Medical Research Center, Mumbai, Dr. Sukhwinder Jeet, Professor and Head Anesthesiology, Intensive Care, Gian Sagar Medical College and Hospital, Banur, Patiala. Dr. Kusum Agarwal, Consultant Anesthesiologist and Intensivist, Vasundhara Hospital, Ma Khadija Hospital. Welcome to all my learned chairpersons. Over to you, sir.
Yeah. So, good morning and welcome to this the first session, that is neurosurgery and trauma and airway management. After seeing yesterday's talks, we look forward to today's academic feast. And I invite the first speaker, Dr. Sadiq Mohammed, who's an associate professor of anesthesiology and critical care at AIIMS Jodhpur. He will be speaking on airway management in neurosurgical procedures. Over to Dr. Sadiq.
Hello and a very good morning to all of you. On behalf of the National and Local Organizing Committee of the Pratt National Airway Conference 2021, I would like to welcome all of you on the day 2 of the scientific program. The first session of the day 2 scientific program is dedicated to the neurosurgical and trauma patients. My topic of presentation is airway management during neurosurgical procedures. This is the disclaimer of my presentation. In the next 15 minutes, I am going to speak on the problems related to the airway management, which includes the logistical, physiological, and anatomical concerns, the various clinical scenarios of the anti-severe difficult airway in the neuroanesthesia practice and the respective management, and the potential post-operative airway-related risk due to the neurosurgical procedures itself. Although the airway management during the neurosurgical procedures does not differ much from the standard airway management during general anesthesia recommended by the various international guidelines. However, there are few unique features which are related to the nature of the neurosurgical procedures and to the clinical implication of the various neurological diseases that present specific challenges to maintain the airway patency throughout the perioperative period. So the anesthesiologists involved in the care of the patients during the neurosurgical procedures must be aware of the risk and be skilled in different techniques to maintain the airway in efficient and safe manner. The airway and the neurological diseases, they are basically reciprocally related. The neurological conditions which are commonly seen in this subset of populations, such as the reduced level of consciousness, a certain degree of myopathy, neurological deficit, they all directly impacts the patency, airway patency, protective reflexes, and ventilation control, decreasing the safety margin during the airway management. On the other hand, the response to the aggressive airway manipulation and failure to deliver the adequate oxygenation and ventilation during the procedures may have a devastating impact on the neurological outcome, particularly in patients with cervical spine injury and the patients with increased intracranial hypertension. Coming to the logistical concerns, the various positions during the neurosurgical procedures like lateral position, park-lying position, sitting position, prone position, they all present challenge to the anesthesiologist. In addition, a great number of surgeries. In a great number of surgeries, the patient head is fixed to the surgical table with a Mavid keys, skull pin head frame, making neck manipulation and mouth opening very difficult. Even more, the head is covered with a sterile surgical traps, and the table containing the surgical instrument is placed over the patient's chest. And additional bulky equipments like microscope may be around, which obstructs the access to the airway. The physiological challenges are the intracranial dynamics during the airway management. During the airway management in the face of intracranial hypertension presents challenge to the anesthesiologist. During the process of achieving and maintaining or rescuing the difficult surgical airway, there is need to balance and maintain the central nervous system hemodynamics like cerebral blood flow, cerebral blood volume, cerebral metabolic rate of oxygen, the cerebrospinal fluid dynamics. One has to avoid the increase in the intracranial pressure and to maintain the cerebral and spinal perfusion throughout the airway management procedures. So the physiological effects are that airway obstruction and difficult bag mask ventilations may quickly lead to the hypercarbia, hypoxemia and increased cerebral blood flow, which aggravates the intracranial hypertension. Moreover, laryngoscopy and intubation results in acute increase in the intracranial pressures and mean arterial pressures. So the primary goal during the airway management in neurosurgical patients are to avoid the further increase in the intracranial pressure and further aggravates the neurological. Coming to the airway assessment in this subset of population, the history and physical examination requires a similar concentration as we follow during the airway management or airway assessment of the patients scheduled for other type of surgeries. Apart from that, the patients with signs and symptoms of the intracranial vascular insufficiency, they should receive the special attention to the neck position not only during the tracheal intubation and surgery but also in the perioperative period. These patients include patients with Buty-Pater stroke syndrome, patients with TIA, history of TIA, patients with stroke and presence of carotid fluid. One can follow the MOUTS acronym during the airway assessment in this subset of population, where M stands for mandible, and O stands for mouth opening, U stands for the Malampati class, T stands for the dentition, teeth, H stands for the head movement, and S stands for the cardiac shutdown to identify the potential impact of the airway on the airway controlled by the large breast, buffalo horns, kyphosates, short turned large neck circumference, etc. In addition to the history and physical examination, the preoperative plain radiograph, computed tomography, MRI, and angiography may give valuable information to the patient's intracranial status regarding the signs of increased intracranial pressure, regarding the presence of hemorrhage and infarct spasm. The additional tool during the airway assessment in patients who are scheduled for the elective craniofacial procedures includes the preoperative endoscopic examination and the airway ultrasound. They has been proven as an important airway assessment adjunctive tool, and they may be valuable in the airway approach decision making. So the routine measures which one have to follow during the airway management of the neurosurgical patients is to achieve the optimal airway control and smooth intubation. And these measures includes the proper head positioning throughout the airway management procedures, proper pre-oxygenation, and the appropriate dosing of the induction agents and relaxants. The techniques which are currently being employed to blend the sympathetic responses to laryngoscopy and intubation includes the additional doses of the thiopentone or the propofol or opioids, use of the beta blocker or the other antihypertensive agents, and use of the intravenous lidocaine just prior. So the general principles during the anesthetic management to avoid the increased intracranial pressures includes avoid marked fluctuation in the blood pressure, avoid hypoxia, hypercapnia, severe neck rotation, avoid jugular compression, keep the head of the bed elevated, decrease the blood viscosity and intracerebral blood volume, avoid sustained increase in the interfacial pressure, and avoid the cerebral vaginator. Although rapid sequence induction intubation is considered to be the technique of choice during the airway management in neurosurgical patients, but one has to keep in mind that the RSI regimen with paralysis produced threefold increase in the peak intracranial pressure changes compared with the sedation only regimen. The pre-treatment agents did not affect the ICP changes. Coming to the most important and the second part of my presentation, that is the various clinical scenarios of the anticipated difficult airway during the neurosurgical anesthesia practice. These conditions includes the traumatic brain injury and patients posted for avicraniectomies. These two topics will be dealt separately by a different speaker, and I will be covering the various clinical scenarios like patients with cervical spine problem, either acute or chronic, patients with head and neck fixation devices, patients with acromegaly or Cushing disease, and pediatric patients with congenital hydrocephalus, craniofacial dysmorphism syndrome, or craniospinal dysraphism. So, coming to the acute traumatic cervical spine injury, the epidemiology, the incidence of these spinal injuries in polytrauma patients is approximately 13 to 30%. And the cervical spine injury represents about 0.9 to 3% of all these spinal injuries. If a cervical spinal injury is missed or its detection is delayed, the incidence of secondary neurological deficit increases from 1.4 to 10.5%. And almost one third of the patients may develop permanent neurological deficits. And the relative risk of having the concomitant cervical spine injury is increased in the presence of the severe head injury by a factor of greater than 8. If a patient is having a GCS of 13 to 15, the incidence of cervical spine injury is 1.4%. And if the GCS has dropped to less than 8, the incidence has increased to 10.2%. So the detection of the cervical spine injury requires a variety of modalities that vary in their sensitivity and specificity. And these modalities include the clinical evaluation, plain radiography, computed tomography, magnetic resonance imaging, and dynamic fluoroscopy. In patients with the acute cervical spine injury or the unstable cervical spine, the airway techniques includes the awake flexible fiber optic intubation, which is considered to be the gold standard technique. The nasal intubation, if the base of the skull fracture or sinus fracture has been ruled out, and one can go for the indirect rigid laryngoscopy using the Bullard scope, VU scope, Upsell scope, TrueView laryngoscope, etc. Video laryngoscopy is another potential options for these patients, and it has been shown that use of video laryngoscopy has avoided the neck movement significantly. Direct laryngoscopy with inline stabilization can be used in setups where these high-end gadgets are not available. Fiber optic intubation using the appropriate supralunar airway devices as a conduits, light vents, fiber optic optical stylettes, and the retrograde intubation and percutaneous or surgical airway like leucothyrotomy and tracheostomy. When the head is immobilized in an emergency situation, video laryngoscopy is considered to be the technique of choice for securing the airway. Other options are the indirect rigid laryngoscope, supraglottic airway as conduits for fiber optic intubations, and fiber optic stylettes and invasive. So in patients with the acute cervical spine injury, the neck has to be immobilized during the airway management. And the immobilization options include manual inline immobilization or immobilization of the head between the two sandbags, or application of the rigid cervical collar or the spinal groove. However, one has to keep in mind that the increase in the difficult, these techniques increases the difficulty in intubation and may compromise the airway. There are chances of risk of aspiration, and these techniques does not necessarily protect against the movement of the occipital cervical or the cervicothoracic junction. This image shows the practice of the manual inline immobilization using the operator at the head end or at the side of the patients. This table includes the VD studies which have done to find out the role of the VD laryngoscopy during the intubation in patients with acute cervical spine injury, or patients in whom the manual inline stabilization has been practiced. And the major finding of all these studies includes that the use of video laryngoscopy in this subset of patients leads to faster intubation and avoids the number of and reduce the number of intubation attempts and reduce the head neck movement. So to summarize, the airway management in patients with the cervical spine injury. One has to keep in mind that the techniques which are normally employed to secure the airway have the potential to cause the movement at the cervical spine and thereby increases the risk by causing the secondary neurological injuries. One has to keep also in mind that the direct laryngoscopy in use of direct laryngoscopy in these patients causes a multiple types of movement at the cervical spine. The chin lift to open the airway in these patients causes greater movement on the neck compared to intubation, and the cricoid pressures can be safely applied as it does not lead to significant cervical. So during the airway management in these patients, one has to proceed in the most expedient manner with the techniques in which he is familiar and proficient with. Coming to the chronic cervical spine injuries with myelopathy, the concerns are the difficult intubation is a well recognized and more common in patients with the cervical spine diseases like ankylosing spondylitis, rheumatoid arthritis, and Klippel-Feil syndromes. There is reduced mobility of the atlantooccipital and atlantoaxial joints or fusure of the cervical vertebrae, resulting in the inability to assume the stiff position. Rheumatoid arthritis it has been shown that it has affects the airway and the cervical spines. It causes the cricoid arthritis, temporomandibular joint arthritis, and atlantoaxial instability. In addition, the laryngeal movement, TMJ involvement, and atlantocervical instability may further aggravate the difficulty in this subset of patients. So, in patients with the chronic cervical myelopathy, careful airway management to avoid the further injury should be exercised. Intubation techniques similar to the acute cervical spine injury patients are appropriate and best performed with experienced practitioner. So coming to the next subset of patients, that is patients with head and neck fixation devices, they present challenges during their airway management if there are halo frames which prevents the proper positioning of the laryngoscopy and restrict the atlantooccipital extension. While dealing with these patients in non-emergent settings, awake intubation is the technique of choice, while in the emergency setting, video laryngoscopy of the invasive techniques can be practiced. In patients with the acromegaly of the Cushing syndrome, we have to keep in mind that the patients with Cushing syndrome are morbidly obese and they may present with the difficult bag mass ventilation, while the patients with acromegaly they are present with there is a risk of intubation failure. So compared with the non-acromegalic population, the acromegalic population have a higher incidence of difficult intubation, unpredictable difficult airway, problematic mass ventilation, upper airway obstruction, and sleep apnea. In patients with the acromegaly, one can see the prognatic jaw, macroglacia, osteophytes formation in the cervical spine, thickening of the pharyngeal and laryngeal soft tissues, thickening of the vocal cords, recurrent laryngeal paralysis, decreases in width of cricoid arch, hypertrophy of the arytenoepiglottic fold, hypertrophy of the ventricular folds, and central sleep apnea. These all factors leads to the difficulty in airway management. So airway management consideration in this subset of patients, away from aortic intubation remains the standard technique of choice. Other options includes the supraaortic airway devices in case of rescue ventilation failure. And for intubation, the video laryngoscopy, optical steroid intubation, supraaortic airway devices is a conduit for aortic intubation, and intubating element can be used. Coming to the last subset of patients, that is the pediatric patients with the congenital hydrocephalus craniofacial dysmorphic syndrome or the craniospinal dysaphasia. These patients also had difficult airways in view of the hydrocephalus, in view of their mandibles, face, TMJ, mouth and tongue, dental or cervical spine abnormalities. In these patients, there may be difficulty in bag mass ventilation or tracheal intubation due to the abnormal approach to the lower airway anatomy and physiology. There may be atlantooccipital joint instability, there may be coexisting congenital condition like cardiopulmonary, renal or the metabolic. There may be neurological dysfunction and increased intracranial pressure. These patients usually present for these surgeries like ventricular peritoneal shunt, craniomaxillofacial remodeling, release of the TMJ ankylosis and occipital cervical lesions. Airway management in these patients, the preoperative endoscopic airway evaluation may be essential in this subset of patients. If with difficult face mask ventilation, supraortic airway devices, and then the direct atmospheric intubation. If patients with a difficult laryngoscopy, then optically sterile visualoscopy can be used. Early tracheostomy may be unavoidable in this subset of population. To obviate the need for an early mid-phase advancement for the airway control and reduce the risk of post-operative problems such as the aspiration. So these patients may also present the challenge during the induction. These images shows the various positioning problems in these subsets of population. Coming to the last section of my presentation, that is the post-operative consideration. The post-operative condition which may be present in these patients may jeopardize the ability to maintain the airway due to the intraoperative neurological events like seizure, herniation, hypoperfusion of ischemic penumbral brain area. There may be infarct, bleed or rebleed in the edema, which causes the obtundation in the immediate post-operative period and threatening the airway. The anesthesia management related problem like residual effect of the anesthetic drugs, hypoxia and hypercarbia, acid-base imbalance, fluid-related imbalance, etc. And the surgery-related airway injuries or the position-related airway complications may cause the requirement of may require the securing the airway in the post-operative period. So I would like to end my talk with a famous quote that good decisions come from the experience. However, the experience comes from the bad decision only. So the experience matter while managing the airway in neurosurgical patients. Thank you very much.
Thank you very much, Dr. Sadiq, for that excellent and comprehensive cover of the topic. And I welcome the next speaker, Dr. Zulfikar Ali from Sher Kashmir Institute of Medical Sciences. He will be speaking on awake craniotomy. Over to you, Zulfikar.
Thank you, sir. Thank you, sir. Good morning, everybody. Sir, am I audible?
Yes, you're audible.
Yeah, fine. Good morning, everybody. I'll be briefly speaking on the awake craniotomy, and we'll try to focus on the airway issues related to the awake craniotomy in the next 15 minutes. Awake craniotomy, basically in the medieval age, in the 17th and in the 17th century particularly, what the people believed that once the patient, they had head injury, and once they were disoriented, the people at that time felt that this disorientation was due to the evil air. And historically, they are probably, they were the first awake craniotomies that were done by the people at that time, just with the thing in mind that the craniotomy was done that it removes the evil air. However, a scientific basis was probably for the first time practiced by Horsley for the treatment of seizures. These days, awake craniotomy, it's performed by a group of experts, mainly consisting of the neurosurgeons, neuroanesthesiologists, and the neurophysiologists. And commonly what we do, the awake craniotomies in the present era, they are mainly performed for lesions around the eloquent areas of the brain, particularly the motor cortex and the speech area. And then in the last decade, there has been an increasing number of patients which have been helped for their tremor, muscular dystonias, and Parkinsonism by doing various maneuvers, various interventions under awake craniotomy. It has again become the gold standard for various epileptic procedures. These are a group of patients where we are usually cautious once we deal with these groups of patients. If we have children, it's very difficult to do awake craniotomy in children. Again, if we have mentally impaired patients or patients with behavioral problems. If we have a lesion around the dura with a major dural involvement. Dura is one of the portions of the brain which is very sensitive to the pain, and there we try to avoid awake craniotomy. Or if we have patients where there is involvement of the occipital cortex, because these patients may have to be positioned in a prone position that makes them uncomfortable. The main thing while we manage an airway with awake craniotomy is that we have to maintain an adequate level of sedation and analgesia, and at the same time, we have to ensure that the patient does not have a respiratory collapse or he does not develop hypercarbia or hypoxia. And maintaining this balance in an awake and a cooperative patient in which whom we have to go for a regular, precise neurological testing. That is the main aim of the anesthesiologist. It consists of several steps which mainly involve the application of a head frame followed by a scalp block once we do a craniotomy, and then we position the patient on the table. Usually we avoid arterial, central venous and urinary catheter placements in patients with awake craniotomy as they make a patient uncomfortable. Then it's followed by a dural opening. Once we reach the surgical lesion and during testing of the surgical lesion, we go for a neurological examination, and the last stage is the closure. So once we start, the first thing that we do in an awake craniotomy is the application of a scalp block where we give blocks of around 10 nerves, which are very superficial in a ring-shaped manner. Mainly, we block the supraorbital, supratrochlear, zygomaticotemporal, auriculotemporal, greater auricular, and lesser auricular nerves. So once we block the supraorbital nerve, we block the supraorbital nerve just at the orbital fissure, and once we go for the supratrochlear, it's adjacent to the supraauricular, supraorbital nerve. Once we go to the outer canthus of the eye, it's around this region, around the zygomatic area of where we block the zygomaticotemporal nerve, and then auriculotemporal nerve we just block in front of the external acoustic meatus. The lesser and the greater occipital nerves, they are blocked around the nuchal line in the posterior part of the cranium. After these nerves are blocked, the patient is placed comfortably. And while we place the patient, we have to ensure that we maintain a wide area of contact once we are doing the neurological testing of the patient. We have to ensure that we are having a clear vision of the patient's face. This is the setup from my place where we take help of a C-arm. We take the C-arm, apply a sterile polythene cover that creates the barrier between the surgical field and the attending anesthesiologist and the neurophysiologist. And we have a clear vision, a clear contact with the patient in whom we keep on having a constant interaction. There are two main techniques that we use for awake craniotomy: the monitored anesthesia care with conscious sedation, and we follow the asleep, awake, asleep technique. So in monitored anesthesia care, we mainly supplement the oxygen and we go for intervention and as and when required. And at the same time, we have to have a clear-cut vision on the carbon dioxide levels that are in the body. Previously, we used to, it has gone out of disrepute, the neurolept analgesia. It has been droperidol. Fentanyl has been now replaced by better drugs in the form of dexmedetomidine, fentanyl, and propofol. There are some issues once we go for a deep sedation technique. They cause an airway obstruction, hypoventilation, and unfortunately, if we develop a hypoventilation or airway crisis, the airway in such situations is inaccessible because the patient is draped in the surgical drapes. But if we maintain a delicate balance between with the judicious use of the anesthetic drugs, the patient is able to endure long periods of surgery and is able to tolerate the procedure, particularly the pinning and the application of the local anesthetic during the initial stages. So how do we manage airway in such situations? The basic technique that's practiced at many centers across the world is a simple placement of a soft nasopharyngeal airway. And once we place this nasopharyngeal airway, it maintains the airway patency and it reduces the risk of apnea. However, once we are sedating the airway and using this technique, we should always keep the emergency airway equipment, particularly the fiber optic bronchoscope, standby in case we have to go for a rescue airway. The second thing that we can use for a sleep technique is the insertion of a laryngeal mask airway. During the initial stage of the sleep technique, we sedate the patient, put in an LMA. Once we have to go for a neurological testing, we stop the anesthetic agents, remove the airway, and once again we go for closure. At that point of time, we reinsert the airway. This becomes somewhat uncomfortable and has been replaced by better techniques, which we will discuss. A modified endotracheal tube is also used at some centers. A simple endotracheal tube is attached to a suction catheter in which multiple holes are made. The patient is intubated. He undergoes through the sleep stage. Once we have to go for a neurological testing, we remove the endotracheal tube, keep it above the vocal cords under fiber optic guidance, and at the same time, to increase the tolerance of the patient, we instill lidocaine. And once the procedure of the neurological testing is over, the endotracheal tube is inserted back under the awake, under the general anesthesia. Within last 5 to 10 years, this device is helpful. We have also procured this simple airway device at our center. So this is a simple catheter that is inserted into the esophagus. We have two cuffs, the proximal cuff and the distal cuff. This is inserted into the esophagus. The proximal cuff forms a seal around the base of the tongue and the palatine tonsils, and the distal cuff, it inflates the lower esophagus. There are multiple holes in this device, and once we insert this, this is inserted into the esophagus, and once we have to once we want to do a neurological testing of the patient and the anesthetics are totally stopped, we just ventilate the patient, and in case the patient develops hypercapnia, and that helps to correct the excessive carbon dioxide levels in the body. The advantage of this technique is that once we place this in the esophagus, the patient can speak. So as the tongue is free, we are able to use this device in patients where we are operating around the Wernicke's and the Broca's area. Another device that has been used is the cuffed oropharyngeal airway. This is a simple airway in which a cuff has been devised, and once it's placed in the oral cavity, it's attached to an anesthesia machine, and again during periods of hypoxia or hypercapnia, it's useful for positive pressure ventilation to eliminate the deleterious effects that can be encountered because of excessive sedation. Another simple tailor-made device that we can use at our centers is two nasopharyngeal airways. And once we take these two nasopharyngeal airways, they are attached to a double lumen tube connector, which is attached to an anesthesia circuit. And once we use this device, again, it may help to prevent the excessive accumulation of the carbon dioxide, and it can help in the elimination and correction of the various blood gas abnormalities. With the advent of the high flow nasal cannula devices, they are also being now increasingly used across many centers in the globe for awake craniotomies, and it has been seen that they decrease the nasopharyngeal resistance and they wash out the nasopharyngeal dead space gases and have been found to be very helpful in the awake craniotomy. There are some airway complications that we can encounter during awake craniotomy. It has been seen by some authors that the incidence of airway obstruction varies from 7% to 18%. And then there has been a conversion from monitored anesthesia care or sedation to general anesthesia in around 0.6% of the patients. And we have had various neurological complications in the form of seizures, a very tense brain, or the development of pneumocephalus. This is our experience over a period of around 18 to 19 years. At my center, we have operated around 100 patients of awake craniotomy with the age group ranging from around 17 years to 72 years. And the duration of the surgery has varied. It has been from around 165 to 310 minutes. And the patients mainly have been operated using the asleep, awake, asleep technique. We have encountered some complications in the form of airway obstruction and seizures. Thank you. Thanks a lot.
Thank you for that, Dr. Zulfikar. The next speaker is Dr. Kajal Jain, who's a professor from PGI Chandigarh. She will be speaking on airway and trauma, the challenges encountered, the threatened airway. Over to you, Dr. Kajal.
Just a second, sir.
Will you be sharing a video?
Yes, sir. Just a second.
A very good morning to all the delegates attending NAC for the second day today. A very happy Sunday morning to you all, and I bring you greetings from Postgraduate Institute of Medical Education and Research, Chandigarh. I am Dr. Kajal, Professor, Anesthesia and Intensive Care, also Academic Program Director of Trauma Anesthesia and Acute Care. And today we shall be talking about threatened airway trauma, enhancing safety. We all need to understand that handling airways in trauma is far different than handling airways in the operation theater. Because in trauma settings, there are many factors which puts the life of patient at jeopardy, as we shall be seeing in our slides ahead. So major trauma killers happen to be hemodynamics, oxygenation, and low pH. Here we are going to talk about low oxygenation only. Although ATLS says that do CCAB, like first look at the catastrophic hemorrhage, circulation, then airway and breathing. And this was modified and resequenced because it was seen that if you take care of hemodynamics, sometimes patients do not need intubation. So if you stress too much on intubating, you increase the mortality as well. Therefore, this was resequenced in a subsequent literature that do CCAB, because we don't wish to do any harm, and therefore this new order comes into existence, and also remembered as a mnemonic MARCH. Intubation practices and adverse peri-intubation event was elaborately studied in JAMA, and the literature was collected from 29 countries. And here the authors found that major cardiovascular adverse event increased the need for vasopressors and also fluid bolus. Along with that, patients also experience severe hypoxia, like saturations dropping below 80%. And this all calls in for attention how to intubate these patients without causing harm to the patient. So when we go to triage settings, we must always assess the airway as we do in our operation theater. However, there is a mnemonic to remember this, because in high cognitive load, it is quite frequent that residents forget to evaluate airway, which has been given level 2 recommendation by the East guidelines. So basically, you look externally, evaluate 332, do your Malam patti, look for any obstruction, and also look for neck mobility if patient is not suffering C-spine fractures. Anatomical markers, however, do not, guarantee that patient's intubation will not be difficult, as we have seen that 90% of intubations are unanticipated difficult intubation, even when the Malam patti is 1 or 2. Along with that, if the patient has sustained trauma, there adds another layer, and which I'm going to just share it with you, a little graphic. So these are images from my own institute, and you can see how badly there are facial fractures, which can cause not only difficulty in mouth opening due to trismus, but they can also have soiled airways. You can see a potentially soiled airway here, and here we can see a severely head injured patient with large midline shift. This patient can cone anytime if you are not careful about your intubation. Similarly, all trauma patients have, unless they are cleared for the spine, have to be intubated with application of mills. Here I've put another collar around the patient. I've shown you this image because not very many times in our settings we see ill-equipped equipments fitted to short children, short babies, small babies, and this limits our access to their airway. This is also one C-spine which is very dangerously, traumatized, and you can see how badly the fracture has dislocated due to a horse rider being pulled by the horse. So all these patients are physiologically difficult airway as opposed to our operation theater. Along with that, we have unique issues in trauma bay. You can see how overcrowded it is. Then there is hardly any limited space. And then patients may be sustaining multiple injuries, and there is complex positioning. Also, multiple procedures are happening at the same time, like centerline insertions. Off hours and skills of airway manager are also very detrimental to the management of trauma in trauma bay. And then return to awake state is very, very unlikely in these patients. So taking patient history is extremely detrimental, because all these patients are brought about by the layman. There is a space crunch. You cannot move around the patient for 360 degrees. And when you intubate, your stretchers are also fixed. You cannot pull them up or pull them down or do an Trendelenburg position. So due to resource crunch, your airway gadgets may not be available to you. So along with the patient factors, there are some provider factors, human factors, which put together pose a lot of problem for the airway manager. So talking about what could be the predictors of difficult airway and how should we prepare our gadgetry, we should know that difficult laryngoscopy, like as happens in limited mouth opening or jaw displacement or inability to position or having blood or vomitus, can cause a lot of difficulty due to trauma. Similarly, if your patient is like having limited jaw thrust due to mandibular fractures, it may be difficult to do a bag mask ventilation for them, and formation of seal may be poor in such patient. Further, blood and vomitus also adds, difficulty levels to our airway. Subglottic use also becomes slightly difficult because of the presence of blood and vomitus and this distorted upper airway anatomy. And then there is a score calculation sheet, which is called Mekocha scale, which gives us some patient factors and some operators, performers factors. And this can be also scored bedside due to higher cognitive load. We can easily remember this. The higher the score, the more is the difficulty, and it calls to action. So basically, you should go with a checklist in your mind, like a SOAP mean mnemonic, which says prepare yourself for a good working suction, oxygen, airway equipment, your drugs, monitors, especially end-tidal carbon dioxide. And then you must also have an airway checklist, which is conducive to your own atmosphere. Like I have made one for my center. Along with that, you should have provision for an intubation bag, which contains all the intubation gadgetry. And this is one which I devised for my own center. So what are the techniques of airway management? We all are very acquainted with rapid sequence induction, but what remains important is to know the 7 P's of prep, pre-oxygenation, pre-treatment, paralysis induction, positioning, placement with proof. Like if there is no trace, that means it's in wrong place, and then post-intubation management. So what about the blood pressure? Like the blood pressure targets should also be kept more than 65 with a push dose of pressor, which is typically 5 to 6 micrograms of norepi. So this is very important because patients, they crash due to their high sympathetic drive soon after giving induction agents, and then positive pressure ventilation also causes a drop in blood pressure. Pre-oxygenation before tracheal intubation is extremely important because if your patient is at 90% saturation, then they are at risk of precipitous desaturation as demonstrated by the shape of the ODC curve. So it's a good idea to keep them between 90 to 100% of saturation by giving by giving oxygenation. So the best source of giving oxygenation would be our vein circuit with the properly forming seal mask. However, you must also see what is the saturation level of your patient. So if your patient is extremely hypoxemic, you may need to add a little bit of CPAP using a bag valve mask device. Otherwise, a simple non-rebreather mask can also do the job. So some positions and maneuvers during apneic period also help to maintain oxygenation, like jaw thrust. Jaw thrust is extremely beneficial in patient with C-spine, where you can, lift the floppy epiglottis, which is closing the glottic aperture, by just a jaw thrust. So it just keeps the posterior pharyngeal structures from collapsing backwards. So this is a good maneuver to be done. Along with that, supine position is not ideal to achieve optimal oxygenation. And this study saw that if you oxygenate these patients in 20-degree head up versus supine, you can increase the apnea time to 386 minutes. This is because more of the posterior lung, which becomes prone to atelectasis, now improves. So good idea would be to put a shoulder under the pillow, put a pillow under the shoulder, or two under the head and give a ramped up position, or you can even elevate the head of bed if patient's pathology allows. This will create external meatus level with the sternal notch in a straight line and align your oropharyngeal axis. Apneic oxygenation and extending sake apnea can also be done by increasing your oxygen through nasal cannula at 15 liters and continuing to use it during apneic period. Do not remove the nasal cannula. If you have a high flow nasal cannula device, which gives oxygen at 40 to 60 liters, this is also good to achieve end-tidal carbon dioxide oxygen more than 90%, which enhances the safe apnea period. So for using drugs in trauma bay, it's a good idea to use fentanyl because fentanyl gives pain relief in trauma patients who are very agitated and thrashing around. It reduces the sympathetic tone, can cause hypotension and respiratory depression, for which you have to be very aware. Similarly, induction drugs are like etomidate, ketamine, midazolam, propofol, or thiopentol, but I would say etomidate and ketamine are most commonly used. Propofol is not so commonly used because it causes hemodynamic compromise. So patients who are at risk of developing hypotension, you can choose either of the drugs depending upon the availability in your centers. What about the choice of muscle relaxants? ATLS does say drug-assisted intubation. However, the use of succinylcholine is, if not indicated, should not be used. If it's contraindicated, like patient is having severe burns or having acute trauma with rhabdomyolysis or other contraindications, you can go ahead without use of dexamethasone. If you have rocuronium, it will be good to use rocuronium, but both the drugs have to be used in higher doses because of low cardiac output states. Those patients who are extremely desaturating, the muscle fasciculations induced by dexamethasone can cause further oxygen consumption and desaturation. So you have to be aware of that. And for rocuronium, we all know it's a long-acting drug, and we cannot reverse it, then we should be prepared for front of neck procedures. Delayed sequence induction is intubation is another process in which all those patients who are agitated, thrashing, inebriated, intoxicated can be first dissociated and calmed down by giving a small dose of ketamine, like 0.5 to 1 mg per kg, then pre-oxygenated and then paralyzed and intubated. A very much in use process in all institutes, including mine. If you talk about laryngoscopes, we don't have to worry if we don't have video laryngoscope, because most of the time we are able to intubate with direct laryngoscopy. However, if patients are severely injured and the necks cannot be manipulated, then it will not be useful. So we can use video laryngoscope because video laryngoscope does not require alignment of airway axis. It also allows others to view the screen and help facilitate ETI, like redirecting cricoid pressure. And they are also associated with less cervical manipulations. Use of bougie is indicated, and this has been shown in a beam trial published in JAMA, that use of bougie improves the first pass success rates. So this is another technique. This is called suction assisted laryngoscopic airway decontamination, in which the operator first inserts the suction and then takes it on the left hand side and does not remove it when doing laryngoscopy. It remains parked over there. So basically the idea is to keep on sucking out blood or vomitus, which keeps on appearing in a patient of trauma who's always assumed to be full stomach. Please try to use a Yonkers suction, which is more tough rather than the floppy disposable suction tubes available. Can I use a supraglottic airway device? Yes, we can use, and preferably if you have to use to salvage a situation, then use second generation, because that is a separate lumen to access the stomach and aspirate gastric contents. It has also got a conduit for intubation. However, it should be taken as a transitional device. It should be changed to a tube whenever feasible. Now, this is called a double setup. In a double setup, we have to be prepared simultaneously for orotracheal intubation and cricothyrotomy. And this happens in those patients who are at risk, but you would like to do one-time RSI before you proceed on to fauna. So this is also an airway salvage procedure which enhances the safety of the patient. So Western trauma associations in 2020 have given whatever I've talked about today in an elaborate algorithm, which is applicable in ED Trauma Bay. So this is accessible in Trauma, Surgery and Acute Care journal. So one can always go through it. And this is my airway response team, which comprises of one of my residents and one of my technical staff. They go with their video laryngoscope and other blades, which are placed in this intubation bag whenever the call comes. So I want to ask the audience, do you have one? If you don't have, it's time to have one, because trauma airways are potentially difficult, physiologically challenging. So with this, I thank you all for a patient listening, and you can access me at jen.kajal@pjmedu.in if you have any questions. Thank you very much.
Thank you very much to all the speakers. And I open the house to questions and comments from the other panelists as well as the audience. If there are any questions, you can type it in the chat box. While we wait for the questions, I'll ask a question. Thank you very much, Dr. Kajal. That was a very interesting talk of yours. And I was really impressed with the equipment that you have designed yourself, which is in our low resource setting, having all these things rather than waiting for someone else to mobilize it. Having all these things rather than waiting for someone else to mobilize it is very important. Can you share us a little more details of that equipment that you have designed? Can you share us a little more details of that equipment that you have designed?
A very good morning. Thank you so much for appreciating the talk.
Very good morning. Thank you so much for
There is an echo.
appreciating the talk.
Can we do something about it?
Yeah.
Somebody
There is
is
an
locked
echo.
up devices.
Can we do something about it?
Yeah.
Somebody is locked devices.
Let me check, sir.
So, Dr. Joseph, actually, we have not. We have created one bag in which Macintosh is there, and then we have got all kind of endotracheal tubes. Then we have got an SpO2, a finger probe, because we don't have monitors wherever our residents go. So I have kept one handheld finger probe, and then I have basically I have kept all the drugs in that intubating scrunch box. We call it a scrunch bag also, and then stillates, bougies. Just short of fiber optic, I have everything in that bag. And that bag has to be checked by the technical staff every morning. The time did not permit me, but I have a logbook for the technicians also.
Excellent, yeah.
And I check those logbooks on a daily basis. They write where the intubation was performed. This is the technician's job, to write in the register the time of the intubation and whether it was a red area or a yellow area, and whether a Macintosh was used or a CMAC was used. So from that, I can, do a monthly audit and see like where is my, deficiency, and whether I can improve further. So by doing this continuous audit for every month over last 5 years, I have come to know what are the problems my residents face. And I have my own data of 700 patients where we saw how surgeons intubate. Like, I didn't cover that part, but they're using, I don't know, it must be happening in all centers. They're using around 10 to 15 milligram midazolam, because all these patients are very difficult to control once they have head injury. I think Zulfikar will agree with me, he's sitting here, that they're totally incontrollable, and they're very big patients also at times, like muscular, heavy built from north. So when they are so difficult and to control, people keep giving 5 milligram midas, then another 5, and then another 5. So we see all kind of practices which happen on arrival. And unfortunately, in most of our centers, anesthesiologists are not present in trauma bay, which should be there. Through such forums, we would like to bring this point that one anesthesiologist should be there in trauma bay so we can do better jobs. And number two, oxygen is always a problem when we go to intubate, because most of the centers, they do not have, every bed doesn't have an oxygen port. So we have to be very aware, like which areas have suction port, your oxygen as well as suction port, and the patient has to be pulled to that side. So these are some problems which we have seen during our regular audits, but a very good idea to have your own airway response team.
Thank you. And what we did is in our institution, we insisted that everyone who works in emergency undergoes the ATLS training. Initially, it was very expensive, of course, so we had an institutional trauma life support training, and we made it empirical that unless you do the training, you will not get your first salary. So that way we sort of enforced it.
Absolutely.
So obviously things improved. And Dr. Zulfikar, thank you for your talk. So can you tell us a little more about that esophageal catheter, nasopharyngeal esophageal catheter? Is it easily available?
It's basically manufactured by Rush. It has not been marketed in India, but it's freely available in the US. And if you have my colleagues, once they come to India, I request them to get 10, 20.
Oh, okay,
And,
okay.
we manage it this way. But
Okay.
it's a wonderful device.
Yes.
I use it now very frequently, and I find it very helpful in awake craniotomies.
So, Dr. Julfikar,
Yeah,
can I have a question?
yeah, sure.
This esophageal, nasoesophageal device, how it is different from the esophageal obturator which we used in the difficult airway management?
It's very soft. It's very soft.
So you can insert it through nasal cavity.
Yeah,
Through
and it's easily tolerated by the patient. That is the advantage.
Okay. And what is the difference in the amount of air to inflate both the cuffs in the esophageal obturator and this nasal esophageal device?
In this nasal esophageal device, once we inflate the distal cuff, we use around 2 ml of air. And once we inflate the proximal cuff, we use around 5 to 6 ml of air.
Okay. That's good. So it can be tolerated well by the patients when he's awake.
Yeah, it's just like the way we have a nasogastric tube. Yeah, it's not easily tolerated, but it's comfortable once the patient is in. If we give him mild sedation, fentanyl or dexmedetomidine, then it's easily tolerated. In an awake patient, it becomes a little bit uncomfortable. If we
Is it possible to provide positive pressure ventilation using this device?
Yeah.
Okay.
It does not ventilate the patient actually. If we give positive pressure ventilation, it won't be a replacement for apnea. But if we have a hypoapnic patient where we have accumulation of the carbon dioxide, there it is helpful. Or if we have a patient who is maintaining a saturation around 70%, 85%, there it comes as an aid to the airway. It's not a complete replacement for intubation or an LM.
So primarily we can say it is basically a device to keep the airway open.
It's a device to augment the gaseous exchange during stages where the patient is sedated.
Okay.
Because what happens once in the awake craniotomy, as I was telling, we have asleep, awake, and asleep technique. During the awake phase, it won't be of any beneficial effects because the patient is completely awake and we do not really need any augmentation. But in the asleep stage, once the patient is on dexmedetomidine or we have given boluses of propofol or fentanyl, it becomes handy during those stages.
Okay. Thanks for the elaboration regarding the device. Kajal ma'am, hello.
Yes, I'm there.
Your efforts of creating the local airway team is very appreciable actually. We do have the same airway team, rescue airway team for the management of the difficult airway while they get the call from the emergency or the wards. Although in the emergency, you rightly said that in the trauma way, the anesthesiologists are not freely available. We only got the call once the emergency team member got difficulty in intubating the patients. And in that case, this rescue airway trolley is very beneficial.
Yes. And another thing I want to just add is that I ensure that all my residents who are posted in intensive care do one percutaneous dilatation tracheostomy under supervision and a couple of them alone. So once they go down as airway managers, they should know how to give a nick if the situation arises. And
Yes,
there
I
have been
agree.
a couple of times where my residents have saved the life of a patient because they were not, skeptical about using the scalpel there. So it's very easy to read, but very difficult to do. So whenever I audit at the end of the month, like how many residents did percutaneous dilatation tracheostomy and how many of them feel confident to do fauna. So that's also one thing I audit every month.
It's agreed, ma'am. Residents should be allowed to go for front of NAV dissection, and they should
Because
be
they are the
trained in
ones who
such
are
a manner.
available.
Yes,
They are the ones who are
exactly.
available. We are not there at odd timings. So I would also like to encourage all residents sitting in the audience to do PDTs under supervision.
Thank you, ma'am. Thank you very much.
Any more questions? And Dr. Zulfikar, I like to keep my patients more awake than asleep. But as you mentioned now, with the younger surgeons doing a lot of neuromonitoring, people are choosing this sleep technique. And I would also just like to make a comment that a difficult airway is a relative, I would say, contraindication to the awake procedure because you don't have access to the airway. So one must be a little cautious. Though you are prepared for all these eventualities, what is your supraglottic device of choice if you have to insert it?
iGel, I would prefer.
Yeah, okay. If there are no more comments, and I will thank all the three speakers for the excellent presentation, and I will hand over to the organizers. Thank you very much.
Thank you.
Thank you very much.
Thank you very much.
Thank you, respected
Thank you.
persons, respected speakers. That was a wonderful session. Let's move to the next session now. That's the pediatric session. So I would like to invite the chairpersons for the pediatric session. Dr. Dilip Pawar is a former professor, AIMS New Delhi. Dr. Pradanya Samant, Chief of Department of Pediatric Anesthesia, Wadia Hospital, Mumbai. Dr. Neerja Bharadwaj, Senior Professor, PGIMR, Chandigarh. Welcome, sir, ma'am.
Thank you. Good morning and welcome to the pediatric airway session. And let's get going. So I will invite the first speaker, Dr. Ramesh, who is a consultant pediatric anesthesiologist from Chennai. Over to you, Dr. Ramesh.
Am I allowed to share the screen? Okay.
Yes, sir. Yes.
Good morning, everyone. And it's really a pleasure to be a part of ADA and NAC. And really appreciable that sharp, this is now it's about 9:29, 60 seconds. Now it's 9:30 and my lecture is 9:30. It's really incredible to start exactly on time. So the tubeless anesthesia in children. Actually, the tubeless anesthesia in children is not new to me because it goes back to 1986 when my ENT surgeon those days, we used to do nasal intubation for adenoid and tonsil. At the end of the tonsillectomy, you will say, take out the tube. I want to do the adenoid properly. That time, I still remember using ether. So ether had a very good time for that time. You remove it, and then they used to do adenoidectomy. That time, we really very scared. There's no tube. There's going to be bleeding and all these things. Now we really feel that we have come back to the olden 30 years ago about the tubeless anesthesia. So there are many pathologies, laryngomalacia, paralysis, subglottic stenosis, webs, hemangioma, saccular, so many things which you have to do on the larynx. But whatever the pathology of the principles of anesthesia for the airway surgery remains the same. Actually, this particular interest came to me somewhere in 2012 when we organized the International Congress of Pediatric Airway in Chennai. The topic from France and United States and also from UK. Everybody has attended all over. You can see Dr. Ramkumar and Dr. Pawar, Pankaj Kundra, they are very good meeting, and that stimulated us. The faculty came to there, especially Fayot and Marciniak from Lille, France, has come to us, and they all taught us how to do laryngeal surgery. And later on, we met Dr. Monier, who is probably who written the book Pediatric Airway Surgery, who is this is the Bible for anything in the pediatric airway. And his colleague, Dr. Sandhu, who is he comes very often to India, and he has come to us also and taught us how to do the laryngeal surgery without tubes. Having said that, I'm sure Dr. Anil Patel is a game changer in the tubeless anesthesia when he started the use of Thrive in the ENT surgery in the adults, and slowly Dr. Humphrey from Australia, from Brisbane, has a very good paper which we thought we can do the same Thrive in children as well. And the next, I think Dr. Jagannath, the Narasimha, a young fellow, but he's a vice president of DAS Society, a big fellow in the airway. He's from Chennai, good friend of mine. And this is a beautiful article of a Thrive in children. This all made me to read and do a lot of cases with tubeless anesthesia. When he thought we have to do only paralyze and Thrive, there is another paper come from Booth, which has been explained by everybody. This is called the spontaneous respiration using intravenous high flow oxygen. That's what we are doing, but we call it as a Thrive. So if you come to this, there are so many things. F0, HFNC, HFN, you might have listened the whole in the morning and also yesterday about so many things about the abbreviations, but the principles are the same. What we use it either Thrive or Strive. Thrive is transnasal humidified rapid insufflation ventilator exchange, and Strive is spontaneous respiration using intravenous high flow or nasal oxygen. I'm sure all you would have listened to yesterday the beautiful workshop with Dr. Jivedya and other people on Thrive and high flow. So when you're doing a surgery in the airway, what the surgeon wants, this airway is mine, but I will share it with you. So they want unobstructed surgical access, avoidance of any airway device, and there is no movement. I don't know how it is possible. What the anesthetist wants, the airway is yours, but I will share it with you. We want adequate oxygen, we want removal of carbon dioxide, and it should be rapid wake up and recovery. So there should be compromise. So what is the balance? Is the airway is yours? No, it is not. No, it is yours. So you should have good communication with each other. You must tolerate hypoxia and hypercarbia. I show you a couple of cases to demonstrate this. Intermittently, you have to intubate. So we started our surgery with the Thrive in 2012. And this is equipment, whether you are going to Thrive, high flow, or with a Strive technique, your equipment should be, everything should be available, whatever possible. You've got a video laryngoscope, bronchoscope, laryngoscope, jet ventilation, all the monitors, and also some lasers, all the type of Parsons laryngoscope. So if there's anything, even a small procedure, if you get into problem, you should be able to handle it. I'll let you know at the end of the class a couple of cases how we handle the difficult problems. This is how we do it. We just induce with little bit of sevoflurane with little propofol, and then we don't want really little bit of oxygen and about 2 to 3 ml per kilo of oxygen with sevoflurane, and we maintain this surgery. But the golden trick, I think this is, if I have given a message to the people that if you want to do any airway surgery, liberally use spray. This is the golden trick, because the whole mucosa of the airway is being anesthetized, so there is no reactions, there is no problem. But please mind about the dosages. Calculate how much you can give it, so you can give it. So instead of 4%, I use 2% xylocaine, so you can use more volume. So when we started, we thought we have to have a Thrive. So we bought an equipment, Airvo, from intensive care unit. We brought into the operating room. We connected to that, and we are humidified. We did surgery. It's a long process. Then we realized we don't really need the Thrive equipment to be really to brought to this operating room. Even the boils machine, because the pediatric case, we can 8 ml per kilo with a good humidification. We can use the same without having a particular equipment. Later on, we thought instead of doing that, we can use Thrive on spontaneous. So we all do nowadays on spontaneous unless it's really need to paralyze. That is Thrive technique. When you put out the induce the child, you put an endotracheal tube only about 6 centimeters just below the uvula or just above the uvula. As you see here, you can see the tip which is being there. You don't have to go so deep. You can be little even in the little up also, no problem. But the tube is here. It is anything can be done on the larynx and the trachea. When you do position, little extension is needed for this. I'm giving you an unedited video of how we do a case which is for a bronchoscopy for a Thrive technique. As you see here, we give little bit of oxygen with sevoflurane, and we have a little 1 or 2 ml of propofol and pull the child to sleep and see the child is sleeping a little bit, and then the eyes are closed, which is okay to all the things. You monitor ECG and also pulse oximeter and see everything is okay, and then we can see that it's okay. We can have the tube, which is about 1-year-old child. I just put 4 size endotracheal tube in the nasopharynx. I sometimes give little of a ketamine or dexmedetomidine. I'll give ketamine about 0.5 milligram per kilo. Then you keep ventilating so that you have to tolerate the tube much better. Please be very slow. Don't be in a hurry to put the tube, because if you put the nasopharyngeal tube, that may stimulate and cause laryngospasm. Again, I want to tell you the golden trick is the local anesthetics. Give 2% jelly nicely. You put jelly, it's 5% jelly by little, nicely lubricate before putting the tube. So you all nicely, you do everything is okay. Take your time, monitor, go slow, not in a hurry. Then you keep ventilating and make sure things are okay. Deepen the child as much as possible, depending upon the pathology of the airway. Then you put the, I told you already, if possible, because the child is fairly deep, you can do a gentle laryngoscope, and there are some secretions. You just suck it out and spray the vocal cords. This spraying the vocal cords is the 2% xylacane, so don't exceed what is needed for that particular child. So just exceed for this local anesthetic. See what happens now. This is the two-edged sword. When you are spraying with the local anesthetics, that time the child may get into laryngospasm. So you must be very, very sure that you must be very slow, ventilate nicely. You can see there is some reaction with the child, but I'm able to have the ventilator properly and deepen now. Within a couple of minutes, it has been anesthetized. That spasm also will be relieved and the child will be all right. So don't lighten the child with the sevoflurane, with 100% oxygen, and make sure that things are okay. Wait for some time. Once it has been all right, you are happy to do it, then take the endotracheal tube and then you put this. You see, maintain the sevoflurane initially about 3 to 4%, and you can give about 1 or 2 ml of propofol so that they'll tolerate the tube better, so there is no reaction. You see, there's a tube is taken off, and then you can. There's a little bit of extension can be given, little bit, not too much. ENT doesn't, surgeon doesn't like too much of extension. You can give a small extension to the back so that it's easier to maintain the airway. This is just an unedited video so that you know what it takes some time before you can give the patient to the ENT surgeon. As you see here, the stomach is getting inflated, so I keep on emptying, but be careful that the NPO guidelines is properly taken care of when you're doing it. So you just have to put about 5 to 6 centimeter. Slowly you just put it, don't force it, because once it has got loss of resistance, then you fix it nicely with the plaster, whichever method you want to do it, like any other nasotracheal tube. Just fix it nicely. The child is spontaneous with 100% oxygen, and then for some time with the help of with sevoflurane, connected to here. Sometimes you can see this is the child which is on spontaneous with a regular respiration, no problem. Child is all right, deep enough to put the Parsons laryngoscope, and you can do the surgery. I'll give some couple of cases so that you can see what is the example of this. This is a 6-month-old child, noisy breathing since birth. When you put this one, there's a huge laryngomalacia, epiglottis, auditoris is pulled, and this is done with the division of the surgery, supraglottoplasty, with the excessive arytenoid tissue, and also being coagulated, and the prolapse epiglottis is also coagulated, so there is no supraglottic collapse. So what we can see here is after about 2 months of surgery, this surgery is nothing is seen, and the epiglottis is all right, and you can see the surgery, and the child is all right, no noisy breathing after about 3-4 months. This is another child which is a severe stridor with a subglottic retraction, smile with a voice change, and we put it, there was an history of intubation and ventilation. There is a web which is being you can see here, it is an arcuate web, and after that we are able to see here, this arcuate web is being cut off with the help of a tubulus, and then with a sickle knife, we just cut it off. After cutting it off, we are able to put a small plungette so that it doesn't stick together, and then it is stuck together like this. So this has been after 3 months, it is brought here, and then it is taken it out. This is a bilateral vocal cord palsy, which is a 4-year-old girl, very, very high-pitched inspirated stridor. And this inspirated stridor, we are able to do what is called the Casimir procedure, which is a posterior cardotomy, so that we give a good place for this. With the help of a coablator, we are able to, with the help of a laser, we can always do that and do this posterior cardotomy. This is a severe stridor, came in the knife with help, and then we fundoscopy, we found a huge polyp in the central larynx. So we did a inspirated stridor. With the help of the coablator, we debrided it off slowly with the tubulus, and then child was all right a little later. 4-month-old baby, severe stridor since birth, and then we found it is a subglottic, small subglottic stenosis with the membrane which is being there. You can see this is the one. This is okay. What we did is, we did with a sickle knife, we just did a small nick over that because it's an acquired, the thin one, we could do it. And then after that, we could do pass a dilator, dilated it, and the child is all right. This is the one which we are going to dilate with that, with the help of a dilator. And since we have a laryngoscope, we should be able to do it better. And you can see that this is the dilator going in with the different types and is being dilated with that. This is how we dilated. And so our anesthetic technique is induction is sleep dose of CO with 1 to 2 mg propofol. Maintenance is propofol 10 mg per kilo per hour. Dexmedetomidine can be used 0.1 to 0.5 per hour. Ketamine 0.5 mg per hour. Not all together. Please do in such a way that you titrate. So the golden trick, again, I'm telling, the local spray of 2% xylocaine. So the monitoring is saturation, respiration, expansion, but advisable to use a BIS and transcutaneous EtCO2. I think we are now, whatever monitoring, we are not able to get what is the EtCO2. I think if you get a transcutaneous EtCO2, we can know how long we can do tubeless anesthesia. Hypercapnia can be really tolerated for 30 to 40 minutes. See, as we know, there are a lot of articles that are permissive hypercapnia. Apneic oxygen carbon increased by 0.27 ml per minute. But during spontaneous with high flow, it is much less, 0.2 mm per minute. So troubleshooting with this spontaneous technique is airway reactivity. So you have to increase the depth or local spray. If it's apnea, decrease the depth, mask ventilation, trickle intubation. Desaturation, depth decreased, and complete airway obstruction, jaw thrust, intubation, bronchoscopy, sometimes jet ventilation. This one child, I'm telling, they're doing a tubeless anesthesia where they found they just want to remove that small polyp, and they found the saturation was 80. When the saturation was 80, what we did is you put the tube through the Parsons laryngoscope, and then once the tube is put in the Parsons laryngoscope, and slowly the saturation picked up, and then you can see this is okay. So in between, you might have to intermittently intubate. This is the last child, which is a really very, very challenging, done about 2 days ago, where you can see this is the child with severe stridor. Severe stridor, I don't know what it is, and we don't know what it is. We put a laryngoscope and the bronchoscope, and we found a tracheal stenosis. So this tracheal stenosis, Actually, when you do the tracheal stenosis, you want to do emergency surgery. When he did like this with the help of tubeless, the saturation fell to 60. And after some time, the saturation fell to 30, 34, 35. And what's happening like this is really challenging. That particular time, I took her from the ENT surgeon. You see that it's come to 27, heart rate also came down. I took from the ENT surgeon. I thought I'll put a tube. Instead of putting a tube, I did the bronchoscope itself. Because it's a tracheal stenosis, we'll bypass it with the jet ventilation. We are able to bring the saturation back. You can see here the saturation will come to about 89, 90, 95. Then we proceeded with the surgery and the child was really all right. You see 27 and 75. That means you must be able to have an alternate technique and you must be an expert doing a bronchoscopy in case you want to do a good airway. You can see that saturation is maintaining well and everything is much better. We did the surgery. And the surgery is all right. And next day the child was just keeping. We never imagined that child is okay. So just take home message. I know I'm fast, but it's all the pictures and the videos were self-explanatory. The take home message of this, for tubeless anesthesia, you can either follow thrive or strive technique, whatever you are comfortable with it. To my knowledge, strive is a good technique with a good local anesthetic spray for tubeless most of the times. Still, we have many limitations and complications, but you see, when you want to save the child, we should take out those risks, and that limitations, complication has to be accepted. And you know, about 12 years when I started, I was really panicky, but even now I am panicky, but I need more experience and more practice so that we can be really comfortable like a Cincinnati group or a France group. But one thing I want to conclude, please have a good pre-op planning. If this fails, what I will do? This fails, what I will do? You can't intubate. Are you planning to have an ultrasound? If there is not a problem, or you do cricothyrotomy. If you can do bronchoscopy. So every small child, you must have a backup plan to save the child. Thank you very much. I think I've exceeded a couple of minutes, but thank you very much. I think I'll reduce in the question time. Thank you, Dr. Pawar, Dr. Nirja, and Dr. Pragnya Samant.
Thank you, Dr. Ramesh, for giving such an excellent presentation. We move on to the second speaker, Dr. Vibhabari Nayak, who is a senior consultant, and she'll be speaking on airway in cleft lip and palate, the challenges. Dr. Vibha.
A very good morning. Thank you for the kind introduction. It is indeed my pleasure to be a part of this academic deliberation, and I'm going to talk on something that is close to my heart, that is airway management in cleft patients. Orofacial clefts are the most common craniofacial abnormality. Smile Train, the cleft charity, alone runs more than 150 centers across India, and I have been associated with them for the last 18 years. There have been many advances in the management of these patients to make them anatomically as well as physiologically near normal. They require multidisciplinary care and multiple procedures. Yet, airway management remains the most important component in the safe care in cleft children. Let's begin with understanding the difficulty of airway in these patients. Literature shows around 4 to 10% incidence of difficult laryngoscopy, which jumps up to almost 50% if associated with micrognathia. Though the incidence of failed intubation is less than 1% of these cases, the airway complications in the perioperative period can be as high as 30%. And this can be reduced by performing an airway assessment, not just of the anatomical factors, but also taking into consideration the physiological factors that I'll be talking about. Airway assessment in children is always challenging and is often subjectively done by most anesthesiologists. But a more objective way of assessing airway in these children, particularly the syndromic ones, is to perform a COPUR score. COPUR stands for Colorado Pediatric Airway Score and uses 5 parameters for assessment: the appearance of the skin, the interincisor distance, history of previous difficult intubation or obstruction, the mouth opening, and the range of neck movements. Studies have shown that COPUR score is more reliable than Malampatti score in syndromic children. Other cleft-specific factors that predict difficulty are isolated cleft palate, a wide cleft palate, younger children less than 6 months weighing less than 6 kgs, those with bilateral cleft with a premaxilla as can be seen in this image, and of course those with syndromes, particularly associated with retrognathia or short neck. Over 200 syndromes have been associated in literature with craniofacial clefts. Most of these are associated with other craniofacial anomalies, though some, like Vactoril, can also be systemic. And each can present with varying difficulties in airway management, including difficult mask ventilation, difficult laryngoscopy, and difficult intubation, or all of them. Of these, 2 important ones I wish to highlight are the Pair-Robin sequence and the Treacher-Collins syndrome. And the most important difference between them is that airway in Pair-Robin sequence tends to improve with age as the mandible growth catches up. And hence, it is helpful to delay the surgery in these children by a couple of months. Whereas in Treacher-Collins syndrome, the airway does not improve with age and can in fact become more difficult with increasing age. Conditions that can add to the physiological difficulty of the airway include presence of chronic rhinorrhea and association of frequent upper respiratory tract infections in these children due to regurgitation. Other reasons for reactive airway disease, like passive smoking and presence of significant congenital heart disease, can also add to the difficulty of the airway management. The most common device used to secure airway in these children is the oral South Pole RAE tube. But as can be seen in this image, there can be a significant disparity in the size and length suitability to some children. The trend to use cuffed RAE tubes is increasing and can obviate the leak-related problems. But for the length and the curvature disparity, some centers prefer using flexometallic tubes. Supraglottic airway devices have also been safely used by few centers in these cases. Particularly, the flexometallic laryngeal mask airway has been safely used as reported by Dr. Pankaj Kundra. Over the recent years, there has been an increasing interest in the use of point-of-care ultrasound in selecting the endotracheal tube size in this group of patients, particularly those with gross disparity in age and weight due to malnutrition. Assessment of subglottic transverse diameter by ultrasound is more accurate than the age-based formula to calculate the endotracheal tube size. And this also has been noted to reduce the airway-related complications because of the appropriate tube size and depth in cleft patients. The awareness and knowledge regarding the pediatric front of the neck axis has been increasing in the last few years, and it would be apt to use point-of-care ultrasound in preemptively identifying landmarks for front of the neck axis in children with anticipated difficult airway. And this can be done in the pre-op holding area while the child is still in the mother's lap. Moving on to direct laryngoscopy in these children. The preference of Miller or Macintosh blade depends on the training and the experience of the anesthesiologist. But Miller blade performs better in infants and those with retrognathia because the space available in the mouth in this group is significantly reduced. The biggest challenge here is to avoid slipping of the laryngoscope into the cleft defect. And this can be achieved by using a paraglossal approach and has been particularly beneficial in children with wide cleft or bilateral cleft with premaxilla. Same can be achieved with blade modifications like the winged blade, as has been described by Dr. Dhulkhed. But the most commonly used method to minimize trauma is using a rolled gauze piece tucked in the cleft defect while performing laryngoscopy. The use of video laryngoscopy in cleft children has been increasing over the years, but studies show unequivocal benefit in cleft patients, including one study by Dr. Nirja Bharadwaj and the group did not find any advantage of video laryngoscopy over direct laryngoscopy, even for a paraglossal approach. But video laryngoscopy is the most beneficial in those with difficult airway. Pediatric Difficult Intubation Registry also mentions that video laryngoscopy with standard blades have a higher success rate than those acutely curved blades in younger babies. Video assisted difficult laryngoscopy is basically video laryngoscopy with normal curvature blades. And this seems to have been becoming increasingly popular due to COVID pandemic. But when using acutely angulated blades, appropriate anterior bend of the bougie or the tube with stillet similar to the curvature of the blade is essential to improve the first pass success rate. Supraglottic airway devices, as I mentioned, are not commonly used as primary airway securing devices, but are the most reliable airway rescue devices, particularly in patients with syndromic phases. They can also act as a conduit for intubation, and AirQ intubating LMA seems to be superior to other supraglottic airway devices in having the best first pass success rate. Fiber optic bronchoscopy, which is considered gold standard in difficult airways, has its own challenges in pediatric patients. Based on the availability of the size and other supporting devices, it can be used through a nasal or an oral route. The use of combined techniques is gaining popularity, that is, using one or more airway gadgets together has been shown recently to have higher success rates, like fiber optic bronchoscopy through a supraglottic airway device or fiber optic bronchoscopy along with simultaneous video laryngoscopy are effective techniques in securing airway of syndromic cleft children. A recent study comparing video laryngoscopy with fiber optic bronchoscopy as the primary airway plan showed comparable success rates of both. But due to better availability, reduced time, as well as cumbersomeness associated with video laryngoscopy over fiber optic bronchoscopy, there seems to be a gradually reducing role of fiber optic bronchoscopy in the future years to come. Another challenging situation is airway management after a previous cleft surgery. Supraglottic airway devices may cause palatal dehiscence and hence should be avoided or used very carefully. One must also avoid the nasal tube if possible. But in dental procedures that require maxillary wiring, nasal tube has to be used, and interestingly, the same side of cleft is preferred due to the septal deviation away from the cleft side. If pharyngoplasty has been performed previously, then fiber optic guided intubation will reduce the chances of damage to the pharyngeal flap. In children where you anticipate postoperative airway obstruction, preemptive use of nasopharyngeal airway or tongue stitch or both has been found helpful to be placed towards the end of the surgery to avoid respiratory obstruction in the early postoperative period. Having said this, I wish to emphasize that there is no role for routine use of these techniques in children with normal airways. Prone positioning has been found to be useful in children having obstructive symptoms. Here I wish to share our experience with this child who underwent a redo palatoplasty and developed severe palatal edema due to a lot of dissection and causing difficulty in breathing in the early postoperative period. This got relieved with high flow nasal oxygen that helped maintain the patency of the pharyngeal airway passage due to the high flows. There is no literature available on this, and hence the use of high flow nasal oxygen in this subset of patients needs to be explored further. Thus, to summarize, the cleft children with difficult airways should be appropriately identified and flagged to be managed with appropriate airway management plan to ensure their safety in the perioperative period. And I also wish to conclude with this front page of Pediatric Anesthesia Journal from the March 2020 issue, which portrays the future possibility of use of artificial intelligence in predicting difficult airway from a face scan. I'm sure we'll be there soon as we continue to strive in airway safety of these special children. Thank you so much for a patient listening, and I'll be happy to answer any questions. Thank you.
Thank you, Vibha, for that excellent presentation. Let's move on to the next presentation by Dr. Jason, who's a professor and consultant anesthesiologist at Tata Memorial Hospital. He'll be speaking on unanticipated difficult intubation. Over to you, Dr. Jason.
Good morning, everyone. I will be talking about unanticipated difficult airway in children. So what makes the difficult pediatric airway different from the adult? Okay, the anatomical differences, I will like to just reinforce that the children have a large floppy epiglottis, which is omega shaped, a relatively large tongue, a higher laryngeal position, and a prominent occiput, which leads to neck flexion. So these are some of the differences. Apart from these, the physiological differences are that they have a compliant chest wall with loss of intrinsic muscle tone with anesthesia, resulting in loss of functional residual capacity, atelectasis, and rapid desaturation. There is increased work of breathing, increased respiratory rate, increased rate of oxygen consumption, making the apnea time shorter and leading to faster desaturation. There are decreased type 1 fibers, which are prone to fatigue and making them prone to fatigue and respiratory failure. And there is increased vagal tone, due to which during any airway instrumentation, because of the increased vagal tone, there can be bradycardia or cardiac arrest in response to instrumentation. Apart from this, the airway management procedures need to be performed under general anesthesia or deep sedation in infants and children, unlike adults where awake airway techniques can be performed. There are size constraints for various airway equipments. The apnea time is less because of high oxygen consumption, rapid desaturation. There is lack of experience for an occasional pediatric anesthesiologist, and laryngospasm and post-intubation stridor are much more frequent in children than in adults. Because of all these reasons, the pediatric airway is more challenging. However, the incidence of unanticipated difficult airway in normal children is relatively rare. Children, though, have a narrow margin of safety, and mismanagement of the difficult airway can lead to disastrous consequences. Keeping all these things in mind, in 2016, the IDA published guidelines for the management of unanticipated difficult tracheal intubation in pediatrics in the December 2016 issue. This was the paper. These guidelines are developed to provide a structured, stepwise approach to manage unanticipated difficulty during tracheal intubation in children between the age group of 1 year and 12 years. The recommendations for management of the difficult airway in children are mostly derived from extrapolation of adult data because of non-availability of proven evidence on the management of difficult airway in children. So this is the entire algorithm in a nutshell, which I will take you through one by one and step by step. So before I come to that, about pre-oxygenation, adults and older children are routinely pre-oxygenated before induction of anesthesia to increase the oxygen reserve, denitrogenate the patient, and have a longer time for apnea. So pre-oxygenation may not be possible in young children who are combative, have separation anxiety, and who may not accept the placement of a face mask. High flow oxygen can be administered, or oxygen enriched environment can be given by placing the mask with high oxygen flows as close to the face as tolerated to enrich the inhaled air with oxygen. It is preferable to do this for 3 minutes till the end-tidal oxygen concentration reaches more than 90% or end-tidal nitrogen reaches less than 4%. Any airway instrumentation or intervention is attempted only if the oxygen saturation is more than 95%. So with that, I move to the step 1 of the guideline, optimizing bag mask ventilation, laryngoscopy, and intubation. So before I do that, how to optimize face mask ventilation in children? Maintain adequate depth of anesthesia because they are prone to develop laryngospasm. Maintain patent upper airway while ensuring that soft tissue is not being pushed, okay, so that the nares are free and the cheeks, buccal pad of fat, and the submental area is not all being pushed into the oral cavity. The head has to be maintained in neutral position for the reasons described, that they have a large occiput and flexion of the neck is very common. Use of airway adjuncts may be done. Right, correct sizes of oral and nasopharyngeal airways may be necessary. Ventilation with 2% bag mask technique may be needed. Identify and treat laryngospasm using CPAP, propofol, intravenous induction agents, and if required, a muscle relaxant. Relieve gastric distension. So you can put a nasogastric tube to avoid diaphragmatic splinting and rapid desaturation. And administration of a neuromuscular blockade to treat laryngospasm if the above maneuvers are unsuccessful. Prerequisites for doing a laryngoscopy and intubation are having an IV access is mandatory before wheeling the patient before doing a laryngoscopy. Appropriate monitoring in the form of ECG, pulse oximetry, NIBP, capnography should be always attached and available. Pre-oxygenate with 100% oxygen. Maintain adequate depth of anesthesia, analgesia, and neuromuscular blockade. Nasal oxygen may be administered with nasal prongs or catheters during the attempts at intubation and laryngoscopy, and using correct size of equipment is mandatory because the airway is very prone to trauma and edema. Apneic oxygenation, a word about apneic oxygenation, it is used to extend the safe apnea time during the laryngoscopy, and it is not a replacement or a substitute for effective pre-oxygenation. It is merely an adjunct. Apneic oxygenation may be provided using nasal cannula in addition to the face mask, but if the mask seal is not correct, it may need to be removed. There is an acronym known as NO-DSAT, nasal oxygen during effort securing a tube, which was coined by Richard Leviton, and the flow rates of oxygen, approximately 1 liter per kilo of patient weight, may be used. The physiological basis behind apneic oxygenation is that the oxygen consumption in an adult, which is described as 220 ml per minute, Okay, so that is the oxygen consumption, and carbon dioxide is generated at 20 ml per minute, which goes in back to the lungs, diffuses back to the lungs. So this relative negative pressure gradient, around -200 pressure gradient, creates a subatmospheric pressure in the lower airways. So if your upper airway is oxygen enriched, there is aventilatory mass flow, and it leads to better apnea time. So various techniques of oxygenation, apneic oxygenation, like using a nasal cannula, a Thrive, or a high flow nasal cannula, or a nasal trumpet with an endotracheal tube adapter, can be used. So with that, I move to step 1, the laryngoscopy and tracheal intubation. So after the first unsuccessful attempt at laryngoscopy, you may either be using a direct or a video laryngoscope, continue nasal oxygen. There is only one more attempt at intubation, and that should be done only if the saturation is more than 95%. Final attempt should be done only if an anesthesiologist with pediatric experience is available. Mask ventilate between attempts, optimize position, use external laryngeal manipulation, bougie, stillet if required. Consider changing the device, technique, and operator between the attempts, and maintain adequate depth of anesthesia. If successful, confirm tracheal intubation using a capnography. If failed, resume bag mask ventilation with 100% oxygen. Again, a word of about laryngoscopy here in children. You can use a Miller blade or a Macintosh blade or a video laryngoscope, and there is something called as an external laryngeal manipulation, which is different in pediatrics, that the little finger of the person performing the laryngoscopy may be used to give external laryngeal manipulation. And there is something known as a bimanual laryngoscopy, that the person who is doing the laryngoscopy gives the external laryngeal manipulation and gets the glottis into view, and another person intubates after getting the glottis into view. So this is something which is different and peculiar in pediatrics. So these are the various spectrum of airway equipment and laryngoscopes that are available in pediatric sizes. You have the Macintosh blade, the Miller blades, the Stillet, the pediatric Frovas and bougies. So 5 French 50 centimeter bougie is usually used in neonates and infants. This is available by the Cook company. 8 French bougie of Frova is used in children up to 5 to 6 years of age, and an 11 French bougie is recommended for use in children over 6 years of age. A various spectrum of video laryngoscopes like CMAC, Mac blade, Miller blade, D blade, Karlstor's CMAC, pediatric glide scope, TrueView, AirTrack are all available in the market for improving the success of laryngoscopy. With that, moving on to step 2, with the unsuccessful 2 attempts at intubation, move on to step 2, which uses a supraglottic airway device as a rescue device. Continue bag mask ventilation with 100% oxygen. Continue nasal oxygen. Preferably use a second generation supraglottic airway device with a maximum of 2 attempts. The second attempt being done only if the saturation is more than 95%. Resume bag mask ventilation between attempts. Consider changing the size and type of supraglottic airway device, and maintain adequate depth of anesthesia. If successful, wake up the child, or continue anesthesia using the supraglottic device only if it is considered safe. Intubation through the supraglottic device should be done only if you have trained expert help and the adequate sizes of fiber optic scopes under vision. It can be done. And tracheostomy should be done only if mandated by the procedure. Otherwise, pediatric tracheostomies are fraught with dangers. So these are the plans if successful. If unsuccessful, move on to rescue face mask ventilation and declare failed ventilation through supraglottic airway device. So these are the various spectrums of supraglottic devices that are available in pediatric sizes: the ProSeal, the Cobra, the Ambu LM, AirQ, the iGel, and Ambu Aura I. But out of all of these, the second generation supraglottic devices are recommended for use in children with the pediatric relevant sizes. Again, coming to intubation with a fiber optic scope through the supraglottic device, the options available are either you can use an endotracheal tube railroaded over a fiber optic scope, or using a guide wire through the working channel of the fiber optic scope and railroading a tube over that, or using an entry exchange catheter over a fiber optic scope in older children. Coming to step 3. So after the failed attempt at laryngoscopy and supraglottic device insertion, you move to rescue face mask ventilation, continue nasal oxygen, ensure adequate neuromuscular blockade, and rule out laryngospasm as a cause for difficulty in ventilation. Final attempt at face mask ventilation using optimal technique, oral, nasal airways, and adjuncts. Consider insertion of a nasogastric tube to prevent the gastric distension or decompress the stomach and prevent diaphragmatic splinting. If successful, wake up the child. If unsuccessful, declare complete ventilation failure, call for additional help, and proceed to emergency surgical airway access. Do not wait until the child begins to desaturate. Coming to step 4, after failed laryngoscopy, supraglottic device insertion, and rescue face mask ventilation, after failure of all of the above and calling for additional help and declaring complete ventilation failure, move on to emergency surgical airway access. Continue nasal oxygen and efforts at rescue face mask ventilation and perform one of the following techniques depending on the age of the child. So if the child is less than 8 years of age, a surgical tracheostomy is the procedure of choice if surgical help is available. If surgical help is unavailable and the child is less than 5 years of age, a transtracheal needle puncture needs to be done. Between 5 and 7 years of age, a needle cricothyrotomy is the procedure of choice. Whenever you're doing a transtracheal puncture or a needle cricothyrotomy, a pressure-regulated jet ventilation device is mandatory to be used. The reasons for doing a transtracheal puncture in children less than 5 years of age is the larynx is much higher and it is difficult to palpate the larynx and the cricothyroid membrane due to the adipose tissue, which is higher in children. The cricothyroid membrane dimensions are small and are not well palpable. The angulation, as you can see from this figure, because of the conical larynx is such that when you do a transtracheal puncture or a cricothyroid puncture, the cannula is more likely to go cephalad rather than caudad. And that is why a transtracheal puncture is preferred rather than doing a cricothyroid puncture. Again, so this is to show you about the conical and the cylindrical larynx. Again, whenever you are doing a transtracheal puncture, patency of the upper airway has to be maintained for adequate expiration to occur. Avoid barotrauma by using a pressure-regulated jet ventilation device like a Manujet or a Sanders jet injector and begin with the lowest pressures to see a visible chest rise. Avoid kinking and dislodgement of the cannula. This is a Ravuson's needle, which is available in pediatric sizes for transtracheal punctures or needle cricothyrotomies. So once the needle is in the trachea, it is confirmed to be in the trachea after aspiration of air. It is advisable to begin with the lowest pressures of 0.5 bar, which you can adjust with the pressure regulator, and gradually increase the pressure till a visible chest rise is seen and there is improvement in the oxygenation. The inspiratory-expiratory ratio should be maintained at 1:4, so there is enough time for expiration to take place through the upper airway to prevent barotrauma. If the child is more than 8 years of age, a needle cricothyrotomy is the procedure of choice with the upper patent airway and pressure-regulated jet ventilation device. Surgical cricothyrotomy is contraindicated in children less than 12 years of age, and a surgical tracheostomy should be done as soon as possible and preferably in less than 40 minutes following a cricothyroid puncture. So post-airway procedure plan, further airway management plan with chalking out of the airway management strategy, treat airway edema. Because of this repeated airway instrumentation, children are very prone to develop airway edema. Monitor for complications, and counseling and documentation and counseling the parents is necessary. Thank you very much.
Thank you, Dr. Jason. Is Dr. Pawar there or Dr. Pradnya?
Dr. Pradnya is on. Ma'am, please unmute.
Yeah.
Dr.
Hello.
Pawar is.
Hello.
Yes, ma'am, you're audible.
Yeah. So all three presentations are nice, and we go for the question answer. But I see there are no question answers. In a chat box, I see few comments to Dr. Ramesh and Dr. Vibha. I think I have some few comments regarding. Can I comment, madam, something? Madam Nirja, madam.
Please go ahead.
Yeah. So I think already Dr. Ramesh has a comment regarding whether you can use Thrive in a CLE patient, and he has already mentioned that you should not be using for the surgical procedure. But I have a comment. I think using a Thrive in a CLE is not a very good idea. Because if you have a very high flow, you can use just damage or say open the bullae, and you can have a surgical emphysema straight away. I think you can use a nasal cannula just to pre-oxygenate with 4 to 6 liters. Then I think that's a very good idea about, and I think one just comment like whatever Dr. Ramesh has shown video, those looks very scary sometimes in a small children for a tubeless anesthesia. But once you know that you can oxygenate the patient, I think those who are experienced don't. Hello. Hello.
Yes, ma'am. Please continue.
Yeah. So that's actually not very scary, but you have to know how to manage and oxygenate the patient. That's most important. One thing about Dr. Vibha, I think you have heard about the flexometallic tubes, isn't it, Vibha? So I think with the flexometallic tubes, the experiences is not very great, because once they have, usually they are cuff tubes and very difficult to manipulate in a cleft patients, and post-operative edema is much more than with a cleft, this flexometallic tube. Regarding SADs in a cleft, as you said, fine, it is not possible, I think, but SADs we have used in a difficult interventions for, like patients with the Pierre Robins, for a rescue analgesia and for removing, or say doing this Ramstead, not Ramstead, this tongue to lip adhesions. I just wanted to ask you about the USG you said about the FONA. So do you do is routinely about this FONA in children?
Yeah, so I would, no, so I just want to start mentioning the flexometallic tube. We do not use flexometallic tube, ma'am, but there is mention of flexometallic tubes in literature, and I know certain institutes who use flexometallic tubes routinely. Their say is that it prevents the kinking of the tube that can sometimes occur when the mouth gag is opened. I mean, mouth gag does have a slot, but it can still sometimes kink the RAE tube. So that is one. As you said, supraglottic airway device. Actually, I just read the Dr. Pankaj Kundra's article, and I actually discussed with him on how he uses it for palate surgeries. And I haven't yet been able to use them in my institute myself. What we use is only for incomplete cleft lip palates, and as you said, like tongue tie releases. And as a rescue airway device, it is very, very useful. The use of FONA is not done routinely, because according to me, having done so many patients with cleft lip and palate, not all of them are difficult airways. But if there is significant amount of retrognathia, if the child already has obstructive symptoms, before we are taking up the child, because after palate repair, the palate gets lengthened and the obstruction does increase in these patients, at least in the initial 24 to 48 hours, where there is some amount of palatal edema. So in these children, I would definitely want to just mark it and keep, though I haven't had to use it for doing FONA in these children till now.
Yeah, Vibha, that's what actually I wanted to, emphasize these points. I think in our institute also, whenever we anticipate difficult interventions, beforehand only we do USG and just mark, where we can do, unless if it is like a plan when these, when CICC, so you just mark it beforehand, okay. And not search for when the when you cannot intubate and cannot ventilate the patient. That okay. Now one more, just wanted to tell you this palatoplasty, post palatoplasty is actually specially redo patients, and definitely 99% these patients post operatively give a lot of trouble. So instead of giving the high nasal for oxygen, usually in our institute when we anticipate, we always put a nasal tube. Okay, like a nasal airway or say simple nasal portex or whichever endotracheal tubes, and we just keep it rather, because sometimes it so happens because of the adhesions, sometimes we may not be able to negotiate. I think sometimes we can put a bilateral as well, bilateral tubes. So if one tube gets blocked, the second tube is, but the smaller sizes tube. I think that's, and we never had any problem for post palatoplasty. Now that's I think a good idea. I feel these things. I just thanks Vibha. And then third, about the third speaker, Jason's nice presentation. But I think all these guidelines are there. All children's above say 1 year. So in a neonatal, even the IDA does not have, in most of the world also does not have guidelines. So personally, I emphasize that whenever you are doing a neonatal syndromic children, make it a point or say give a message that you have to make your own guidelines of your own institute. Correct. Whatever available, because they may not be available, FOB may not be available, or say whatever the instruments are available, you make a plan. What do you say about those patients then?
Absolutely, madam. I completely agree with you. See, most of the people are trained in managing pediatrics during their residency or even post residency and have some amount of experience in managing children, at least more than a year. But neonatal anesthesia is a specialized population, definitely apart from the changes in the anatomy, physiology, and the narrow margin of safety. Special set of expertise, experience, and skills is required to manage neonates. So I completely agree with you, and it is not everyone's job. So I would, at least in the guidelines, if you go through the main text and whatever has been written in the main text, that neonatal population is a specialized population and it is best left to institutes which can cater to neonatal population and people who are managing neonates on a routine basis because of apnea spells, because of so many other things. Neonate is a completely different set of population with specialized equipment, skill needed. So it is not recommended to be done by any routine anesthesiologist who is an occasional pediatric anesthesiologist.
Yeah, thanks a lot. Yeah, I think.
Can I make a comment?
Yeah, sure, ma'am.
This is in connection to the flexometallic tube we were talking about for cleft lip palate surgery. We are not routinely using flexometallic tubes for cleft palate, but however, we have used them occasionally in few patients. And my experience of that is that the flexometallic tube, the only problem we faced was that smaller the size of the flexometallic tube, more chances of increased airway resistance.
Yeah, correct.
So the ventilation was a problem in those cases. And the second thing I wanted to highlight about the RA tube being compressed by the, the mouth gag which we open, the best way to prevent it, we have found in a setting, is to introduce the needle covers between the tubes and the mouth gag, and that prevents the RA tube from obstructing. So
Yes, we
use it routinely. So that is one thing which we are following.
Yeah, that's a really good idea. Yeah, even we do so sometimes, or you just tell surgeon, to just release it. There's slight.
Sometimes the surgeon is not very, amenable to that, especially if the child has a receding mandible or the mandible is a smaller one. So,
yeah.
And the tongue is big, so he has difficulty in releasing it because his surgical vision is obscured.
Yeah.
So another thing, Dr. Ramesh, I would like to ask you or maybe comment upon it. You were talking about tubeless anesthesia and the use of a normal ETT to introduce through the nasal cavity. Why not use a NPA, nasopharyngeal airway, instead of that big tube hanging there? This is one. And secondly, because you have to repeatedly remove the tube and introduce and maybe interrupt anesthesia and surgery, why not go in for a jet ventilation technique? That is also a tubeless way of performing the surgery.
Madam, the choice is yours. Okay, the choice is yours. Number one, first question I want to tell you is, number one, is that to have the correct size of a nasopharyngeal airway less than 1 year is a very, very difficult one to get it, number one. Number two, if you have the tube, I have seen many times, I put the 4-size tube, I showed the intubation, the troubleshooting. When there's a problem, you can do it. Please believe me, I have done once or twice. I have done 45 minutes continuously without interruption. But for the people to understand that you can always put it in case there's a necessary. I don't intercept at any time routinely. The second is that if I have an endotracheal tube we can actually increase the length and decrease the length depending upon they're doing a scopy. I can put it down a little more. I can pull it out a little more. The third, suddenly there is a desaturation. You may not have another endotracheal tube. I take the same endotracheal tube, put it back into this one. So I think practically I feel that endotracheal tube is a better option than having an nasopharyngeal if you have to take it out and doing it. I don't do routinely interpreting. I have done about 15 minutes of time without any interruption, with a good spare, without any problem. But I told 2 cases just for a troubleshooting. Don't get worried. You have a backup plan. If there is any problem, take it out and put it back. That's all. So we don't, if the surgeon had done me repeatedly, they would have sent me out from the hospital. So I think I don't do it because they don't like it, because especially when doing surgery. Third is jet ventilation is not very much. When there is a problem is obstruction at the upper end and you a jet and you may not have an expiration to follow. You can use, if you do a bronchoscope, see if you have done a rigid bronchoscope in the last case where I have done it, when you do a bronchoscope beyond the obstruction you have gone in, then jet ventilation is okay. Without having a bronchoscope with the trachea, with the doing a jet is not a very good idea. But in the group in Switzerland, they've got a very good controlled jet ventilator. We don't have that sort of a jet which has got a pressure and all this, then you can use it. But that's a good option, but you should be, I feel that jet ventilation should be very, very careful. A lot of pneumothorax, mediastinal emphysema have been reported with a jet with a tubeless anesthesia.
Yeah, I agree. For a complete obstruction, probably jet is not a good idea. But I was talking about some, some procedures where there may be a little bit of opening around it. And then probably jet would be a good. But as you said, there are problems of pneumothorax and all those stuff. I agree with you. Thank you for that.
This is the learning curve for me. It's 10 years. We are not expert, but I think next, probably Dr. Sheila or Jason asked me, I can come with the better options next time.
Yeah, so again, since we have a time, I think 2 minutes I can discuss the same thing about Dr. Ramesh. All these patients who are with a tubeless anesthesia, those who are, with epiglottic pexies and all, so vocal cord, adductor palsies and webs, especially those who are doing with all laser surgeries and without intubating them and without ventilating them. So most of the time we have experience because so many cases we do. So sometimes if the surgeon take a long time, so and we do apneic oxygenation or Thrive, one of them. And if they take a long time, the anesthesia depth is also quite high. And because there is no ventilation at the end of the surgery, the children usually, they don't wake up very fast. So sometimes the EtCO2 keeps building up. So I think in most of the situation, if it is possible, we just intubate them, see the EtCO2 and ventilate till the EtCO2 is normal, and then quite good, post-operatively even the ventilation, because during the period of maybe 30 minutes or so, the basal or say oxygenation or ventilation is not there. So I think these patients, they do much better once, even the way we say it is a tubeless. So at the end of the surgery, after say 45 minutes or so, for very small children, we have to intubate these children. So it doesn't become absolute tubeless. Bigger children, definitely, yes, we can, but very small children, I think apneic oxygenation for a long time, it is not a very good idea, use a tubeless. At the end, you must ventilate them and bring down because sometimes the CO2 we see there 70, 80 mmHg and they don't breathe at all, they don't come out very well. And we need to, have them awake with a good airway reflexes. So because when they manipulate, we keep on giving a propofol, or we keep on giving a dexamate, or we keep on giving the ketamine sometimes, and that keeps them very deep. I think this is one of the point we have learned in during all these procedures, especially with the striders and all.
The best, I just want to tell you, the best option probably is a transcutaneous EtCO2 monitoring.
Exactly, yes.
You can stop the surgery right now. We
exactly,
have knowledge, we will be able to resuscitate. I think when you have, I don't think in India we have a transcutaneous EtCO2.
No, we don't have.
But airway surgeries outside, they all monitor. The endpoint is a transcutaneous EtCO2, and that tolerate little bit of hypercarbia than the usual, because we know the surgery is more important.
Exactly, yeah. So intermittently, when we are ventilating, when they remove the patient, they desaturate, we connect it to the mass EtCO2 and we see how much is the EtCO2, since we don't have this transcutaneous EtCO2. I think that's a really good session. I think time is up. So can we continue or?
I think we can call it a day. I think everything has been discussed.
Yes.
I think we should
very nice
stop in
session.
time.
Yeah. Congratulations to all the speakers and nice presentations.
Thank you. Thank you very much.
Thank you very much.
Thank you, everyone.
All the sessions. Thank you, Ramesh, Viva, and
bye.
Hello, Dr. Pawar.
Thank you. Thank you.
Hello.
I could join.
Yeah. Hello.
Thank you.
Hi, Pragya.
Hi, Dilip. Hello.
Bye.
Thank you. Thank you very much.
Thank you very
It
much.
was a wonderful session.
After such an enlightening session, let's move on to our next session, which is the editor's session. To chair this session, I invite Dr. Anju Garewal, Professor and Head, Department of Anesthesiology, Dayanand Medical College and Hospital, Ludhiana, and Dr. S. Balabhaskar, Professor, Wings Valeri. Over to you, respected chairpersons.
Good morning. My side to the organizing committee. Of course, the National Airway Conference under the leadership of the podium. Nice to be here and on a Sunday morning, and there is some relative freedom for us to discuss. Of course, we'll try to finish all the deliberations with 45 minutes that are allotted. Along with us, Dr. Anju and me, we have basically 4 panelists. One of the panelists to be representing IJA.
I believe Dr. Balabhaskar has, he's back again. Good morning, dear panelists. We are indeed privileged to have you all. Over to you, Dr. Balabhaskar. So till Dr. Balabhaskar resets his internet issues, I take it as a privilege to, Avinash.
He's on mute. Sir, please unmute. Continue.
Thank you. Dr. Balabhaskar, you'll have to unmute yourself.
Good, sir.
He's having network issue. Please continue.
Okay, thank you so much. On behalf of Dr. Balabhaskar, my co-moderator, I welcome Dr. Ramkumar, the Chief Editor of Airway, Dr. Atul Kulkarni, the Chief Editor of IJCCM, and Dr. Pradeep Bhatia, the Chief Editor of JOSCP. I believe Dr. Bajwa would not be joining us today. And with this, we would like to welcome you all for this editor session. We had a session last year as well. And so if Dr. Balabhaskar, your net issues have been sorted, can I hand over the mic to you? So you may please start.
So one thing scared about the network issues. Very sorry with the live programs. Sir, sorry to the panelists. Ramkumar sir, good morning, Dr. Pradeep and Dr. Atul. Am I audible, madam? Am I audible?
Yes, sir.
Am I audible?
You're audible.
Yeah, sir, you are audible, but there are a lot of disturbances. I don't know if several other mics are still operating. Disturbances there. The voice is not very clear, actually.
Yeah.
There is no network issue, actually, at my end.
Okay. How is it, sir? Now, can you hear me?
Yes, sir.
I think the event manager should mute the other mics, actually.
Yeah, they must be attending to it. So sorry for this small interruption. I hope we can continue smoothly in the next 40 minutes approx. Sir, Ramkumar sir, this is basically a little bit of continuation of last year's program, because we are participating in our own Airway Congress now, and you are the editor-in-chief of the Airway Journal. So we'll start with you, and of course we have other editors-in-chief of 2 more journals. Airway research is the one which we always talk about, and we want publications in research only in the form of vigilant investigations. In continuation of last year, you think there has been progress in terms of the research and submissions to the Airway Journal, sir?
Dr. Bala, can you hear me? Just as a voice check. Yeah, great.
Yes, sir.
So in
Yes, sir.
comparison, I would say that, there's been a very marginal improvement in submissions to the Airway Journal. And as regards the quality of the articles that's been coming in, the numbers are about 20% more. But looking at the quality, I don't think that has changed much. That is as far as the Airway Journal is concerned.
So in terms of frequency and submission, you are happy?
Not really. 20% is like statistical lies. 20% increase need not necessarily from 60 to 72 is a 20% rise, but not a great rise. That's what I mean.
That's what. So the very idea of drawing our own colleagues from other journals for today's panel discussion is also to know about the status in their journals. And also one of the background reasons is when we have a specialized airway journal, we should also be getting some transfers from the other journals. So that's in terms of the airway articles. Sir, Dr. Pradeep sir, can you tell me how much were the really airway related articles published in JOSCP?
Sorry, could you please repeat the question, please?
We are talking about the airway publications, the research done in airway and publications in different journals. So yes, we have a dedicated journal which is now progressing quite well under Dr. Ramkumar sir. So we have airway related articles published in other journals also, including IJA, JOSCP, and also critical care, IJCCM. So how much is the proportion, and is it a significant number in JOSCP?
I cannot compare it with the last year. Actually, I have taken over only in April. Dr. Anju might be having some idea. So progress, probably I won't be able to comment, but yes, we get a good number of articles related to airway. So when I search the journal about the articles on airway, airway supraglottic on search, I got 121 results, and airway laryngeal mass 324 results, something difficult airway 496. So overall, about 900 odd articles have been published on airways. So most of these articles, actually they compare one type of supraglottic airway to the other type of supraglottic airway, and one type of video laryngoscope to the other type of video laryngoscope. So most of the time there is no novelty, and it is just simply a repetition. I can understand the problem with the authors and researchers that probably they don't have the imagination, idea, or innovation, how to do the things differently or how to innovate the things, because the pressure of publication is much more rather than lateral thinking or out of box thinking, which is really not easy for everyone to do that. One has to have some kind of research oriented mindset to think differently. So it is the publication pressure over all the medical colleges that we are getting so much of repetition. So after I have taken over I'm actually not boasting about it, but then rejection rate has risen because of the repetition of the kind of articles that we are getting. So lately, what we are getting is more of the articles on the ultrasound on the airways, which is a good thing. And I believe that we can have more different dimensions of airway assessment through ultrasound. Not only landmarks, measurements, but I guess it can be, as we get more research published, we can probably routinely used for airway assessment. It's a standard of care maybe. So that is it. Repetitions, yes, but improvement on the front of ultrasound on airway. That's
See, JOSCP is a very well established journal. It's growing in status year by year. Of course, under different, you have taken up recently also an editorial role. When you say your rejection rate has improved, increased further, mainly because you wanted to see that really innovative articles in airway are published. But would there be articles otherwise which are very well designed, very well implemented methodologically, and discussion, everything has been perfectly done? So those are some of the types of articles which possibly because of paucity of space you may not be publishing. It would be useful, like if you have some interaction with, for example, Dr. Ramkumar. Yes, some articles are there very good, and
from what we know, you got a quarterly journal of JOCP being published. So is it possible sometime that you refer
Yes, sir.
some no, author group to Dr. Venkatesh sir and see that it can be taken up?
I have not done as yet, and the rejection rate is mostly because of simply repetition and the poor quality of writing, actually.
Okay.
So if an article, though it may be a kind of sort of repetition, but it is very well written and has followed all the norms and registered with the clinical trial registry, it is very well written, that yes, it may be published, because it is not possible to get all the articles with a difference. It is not possible.
Yes,
Sometimes repetitions are there. But yes, poorly written articles, it is very difficult to publish, or poorly designed studies are, actually it is not possible. And referring them to the airway journal would not, I think it would, I won't mind that, but they are actually poorly written article. If Dr. Ramkumar says I can do that, I don't have any problem.
Ramkumar sir, it's purely healthy discussions. Not, that's why I said really bad articles must never be taken up. We are not going to encourage. Just if you are not able to handle the number of quality articles, would it be possible to have
Yeah, it all depends on Dr. Ramkumar what he says.
Ramkumar sir.
Dr. Balabhaskar, when we launched the Airway Journal, you were also part of the team that looked at it. We did market research.
Yes,
we
sir.
found that almost 25% of the articles submitted to the IJA and the JOACP were airway related. And therefore, we thought that we have a dedicated journal. We might actually be doing something good, for the Airway Society as such. That's the reason why I started. Now, I'm also on the editorial, I'm also in the external reviewer for both for IJA and for JOACP and for an international journal. So I now can compare the quality of articles coming into the Airway Journal vis-a-vis these three other journals, 2 national and 1 international. And I'm sorry to say that the quality is not that different. So I don't think it is that discards from other journals must come to Airway. I do not really want that. And I don't want any kind of a patronization by any of the editors from any other journal, because I don't think it's in the hands of the editor. It's in the hands of the author where they want to publish. And I think it is wrong for us we shouldn't be a postmaster, diverting articles from one place to another. However, I have received 2 articles in the, for the Airway Journal, both of which were related to respiratory care, but not related to the airway. And I've referred them both to IJCCM and to the IJRC, which is the Indian Journal of Respiratory Care. I know both the editors, and I thought they would like to accept that. So if the subject is not appropriate for your journal, by all means, I think you should. But I don't think that would be a problem for JOACP or IJA, which has a very broad way of looking at articles.
The domain is covered, lost. Thank you, sir. No, it's just purely, that's why I put a preamble there. It's never to say that our airway journal is like in any way not comparable to IJ and JOACP. They are very well edited and very well presented.
Absolutely. So it's a matter of time only that airway journal will also be indexed, and definitely it will definitely we are very sure about it. Its quality and its future, definitely.
Yes, sir.
I think the present editors of both IJA and JOACP are nth generation editors, and I'm sure their predecessors would have had the same problem when they started the journal 60 or 40 years ago. So we are a very fledgling journal. I'm not really concerned about competing with peers, not at all.
Definitely not, sir. Definitely. Sir, Atul sir, again, ICU related and airway related combinations, they keep continuing and to be submitted. How much percentage is that?
So let me see. It's less than 1% of our articles are airway related. Primarily because there are no novel ideas as such which are coming through in ICU. I mean, like Dr. Bhatia said, presently the newest area which is related to airway management is ultrasound. So I saw one article that was published, which essentially talked about preparing for the unexpected, in the sense that the article talked about how the trainee should be taught using ultrasound to identify the cricothyroid membrane. So it was more of a contingency planning than airway management per se. But it was a good suggestion, so we published that. And there was another article which is more ICU related in the sense that this article talked about measuring pepsin in endotracheal fluid to diagnose aspiration pneumonia, and it wasn't very useful. I mean, the negative predictive value was good, but the positive predictive value and other values were not good. So those are the only two articles that we published this year, that is 2021. Now, otherwise, there have been no novel articles in IJCCM. In the other articles we published in 2020 were mainly to do with how to protect the person who is intubating because of the COVID pandemic. And most of the articles have been about the barriers that can be used and the intubation box and things like that. So it was more personnel safety rather than any innovation in managing the airway per se. I mean, the traditional techniques were used, but the innovation was mainly in the type of barriers that they put up to keep the personnel safe. I think which is a very, very time sensitive topic that time. So we published those, but those also were not too many. I think we published about 8 articles out of the total 800 or so we published. So rejection rate is quite high. We get about 16 to 1800 articles a year, and even if we are publishing monthly, there is too much pressure to publish. So unless they are really good and they are well done studies, they probably get rejected more often than not.
Okay, sir. Thank you, sir.
Yeah. As we all actually look at these articles, and there has been an issue about quality of articles being submitted. Dr. Ramkumar, I would really like to know how can we actually educate our viewers on overcoming methodological limitations? We understand there are methodological and ethical limitations to doing airway research.
Right.
So your inputs into this.
Well, I think, once again, the majority of publications that come into journals, at least what I've seen, is that they are from the youngsters, the younger generation. Most of them are publishing their dissertation work, which is probably the first and maybe the last ever research they will ever do, depending on the kind of institution they are trained from. So I think it's not really the responsibility falls squarely on the senior person to guide them properly on the methodology. And many seniors also, I'm sorry to say, learn on the job. As you keep guiding more and more people to do research, I think that's when you kind of fine tune your own technique and your own way of looking at methodology. I think the one thing we need to emphasize is that review of literature is very often done as the last thing. And we review literature. My message to youngsters is the review of literature is to find out what has been done in your topical area of interest by earlier researchers. What mistakes have they done? What are they proven without any doubt to be true? And are there any hazy areas that need to be further investigated? I think that's what review of literature will tell you. And most of the time, most articles start off saying, there's not much literature in this particular aspect, therefore we are presenting this. And I think the author has really not done an honest search for the topic. So I think it stems from the junior and it goes through up to the senior. I think the entire team of people presenting the paper has to work on the methodology. And I would put the blame primarily on the shoulders of the senior. I'll stop there. Atul is raising his hand. Yeah.
Yeah, Dr. Atul, you're
No, sir. I just wanted to carry your point forward. I mean, unfortunately, during our days of post-graduation, our teachers were not trained in research, and therefore we were not taught research. And the legacy just carried on, which is not a good legacy to carry forward. And some of us are lucky that there is peer pressure and we have interest, so we try to learn new things. And fortunately for, I must say, at least that I see myself surrounded by people who are interested in doing research and there is a discussion, healthy discussion in the department about this thing. And unless this percolates to every university, I mean, thesis is not something which has to be gotten out of the way before you appear for your final exam. Till that attitude comes in, I think things are not going to change. And fortunately, the younger generation of teachers does seem to be taking it up, in the sense, maybe because of their seniors, for example, because of Dr. Ramkumar or Dr. Balabhaskar, that you taught us why it is important to do research. And unless that percolates down, so primary responsibility is for the senior person in the department and the guide, because sometimes the guides are also facing their student for the first time. They're getting a new student, a first student of mine. So that kind of thing also happens. So they need a helping hand. And we have found that in our department, we always discuss even the thesis or any research project. We have a departmental meeting where we discuss that this is what we are planning to do. And the suggestions come really thick and fast. And that is one way of improving research methodology. And the student is present at that time when the project is being discussed. So they also learn as to what is required for doing good research.
Absolutely, sir. Actually, indeed, I would say with NMC making mandatory the biomedical research module, mandatory for the younger assistant professors and associates for their promotions, probably they will have that kind of a little training into research methodology, and with pioneers like you all, they can be further guided. And as I fully agree with Dr. Atul Kulkarni, and even in our institute, we have a monthly thesis progress meeting and also a protocol meetings in the department as well as with the institution, and that really thrashes out. And we should indeed encourage our residents even to do that literature review presentations in the class, so they kind of understand where they are lacking and inputs can come in from seniors. Yeah, Dr. Bhatia, you have your inputs. You'll have to unmute yourself.
Yeah, actually, I'm quite optimistic about the future. The reason being that there is a pressure from medical council and for promotion and appointments and all those things. So research papers are to be published. And most of the journals, they won't accept the papers unless it is a quality article or quality research. So things are bound to improve because everyone needs to be promoted. So what I have observed in the past few years that ethical committees, which were not there in the most of the medical colleges, they have come up. They are reviewing the whole research work. And then if an article is not published just because it is not registered with clinical trials registry, then the person understands the importance, and then the next time probably he and his friends won't do the same mistake again, and all these studies will be registered. So gradually, as we give the reasons for rejection of any article that it is not properly ethically properly discussed or not registered, or for the several technical reasons, I'm sure things are bound to improve and we'll take care of these things. But then yes, the problem again remains that publish or perish kind of a thing, that you have to get it published and no more idea or no great ideas about those repetitions will be there. But I hope the quality of presentation will improve. That's what I believe. And how can we improve that? Recently, we have published an editorial also in the latest issue of JOACP about all the observational studies. But because we are getting lots of observational studies these days. Why? Because they think that the interventional study needs to be ethically cleared and has to be registered with CTRA. What they are doing now, that the same thing they are presenting as a prospective observational study, which is very clear that it is in the guise of that it is not observational study. They have definitely have done some kind of intervention, and it is a plain simple distortion of facts. So we have written an this editorial, and this is the way that we can educate people.
Perhaps, rather than have observational studies also need a CTRA registration, and that is what we should get.
Yes, that is what we have written. That is what we have written in the editorial.
Yeah. So, and also I believe that since there are ethical limitations, especially if you're doing research in parturients on airway related topics, So I believe we should, as editors, probably also encourage genuine case series, which can perhaps contribute to the literature, rather than have just guised, I don't know, I can have your inputs on this, but guised observational studies are not probably the way forward.
I am surprised that they got past the ethics committee. I mean, generally, the ethics committee will also look at the scientific content and they will catch this. I mean, ethics committee will catch the intervention study being presented disguised as an observational study. I'm surprised that I'm surprised they got away with it.
So
And
what people
also-
are doing that without registration, they are sending the observational study, which actually were interventional studies. Since they were not ethically approved, they think that it is not required to do, or maybe say retrospective observational study, for example, though they have done some intervention. So this is all things which we read it properly, we can easily catch that there is a problem in their research work.
I think one of the limitations I recently faced in our ethics committee was an absence of an anesthesiologist or an airway expert in the group, because once you have a non-anesthesiologist panel sitting on the IEC and they kind of comment and restrict your methodology for their own concerns, perhaps it also takes away some of the methodological problems. So I think as seniors, we must insist on having an expert, a subject expert sitting up there. This has been a limitation, honestly.
But then this problem could be with all the specialties. Say, for example, actually, I am a member of ethical committee in my institution. So what we get is all kinds of research proposals from, say, Department of Dermatology, Department of Psychiatry. So the ethical committee members may not be aware of the nitty-gritty of that particular specialty. And again, it is not possible to get a member from all the specialties. So normally what we do is, things cannot be very clear. We look at things, the research proposal just ethically. And if there is any query, we just ask them or discuss with them. Normally, it is not possible to get representation from all the departments.
Yeah, so I think a middle way out is perhaps have a subject expert through which the proposals go through, and after they have a subject approval of them, then the ethical committee can look at the ethical aspects. That is something that sometimes does happen in some institutions, So, looking at these constraints. Yes, sir.
Can I say something?
Yes.
Yeah. I think like many of the other seniors have spoken about it. When I was working at Manipal, now I'm retired, we have a departmental dissertation committee, and we have a 4-step process, starting from the beginning of your research till the time you finally present your results. It goes through this, the entire department has to listen to your presentation, and anybody can critique it. I think that's you have best peers among yourselves. So I think we have to make use of that opportunity.
Yeah, we also have that, and all the good institutions, they have these things, but we cannot say it for all the medical colleges. It may be there in some of the colleges, but may not be there in most of the colleges also.
The point I wanted to make, Dr. Bhatia, was that the psychiatry specialty or OBG specialty or surgical specialty, your peers within the department have cleared it, and that should be a signal to the ethical committee that yes, it has gone through a panel of experts in that field.
Absolutely. So, Dr. Ramkumar, can you kind of, look at some of the controversial topics which you would really like RCTs to be done, and some research coming on that particular area in airway?
Well, yeah, I want to first of all say that any research on a human subject is being looked at with a magnifying glass nowadays by any ethical committee. And when it's related to the airway, there really isn't much that you can change if you're going to do a prospective study. And even otherwise, it's a life and death situation. We can't really be changing too many things in the methodology when you're dealing with the airway. So I think that's the inherent problem with the area that we're talking about. Any airway related research will have ethical issues. And I think if you can get something through the ethical issue, then all the methodology would have been very clearly enunciated. Having said that, referring to what Dr. Bhatia was saying earlier, we are not going to create any earth-shattering discovery with our current research. We're only going to reinvent the wheel, maybe, But what I would like to say is that, when you, let's say I'm taking the example from Dr. Bhatia, you talk about supraglottic airway devices, right? Most of the time, the primary outcome is how long does it take to place it? 12.5 seconds versus 16.5 seconds. 4 seconds is not a huge difference, and we all know that. So I think we have to start looking at different primary outcomes. For this type of surgery, is a supraglottic, second generation supraglottic, like laparoscopic procedures. Some among us would not like to do it with a supraglottic airway device, right? And in the earlier session on pediatrics, we had Dr. Vibavari referring to Dr. Pankaj's article on supraglottic airway for cleft palate surgery. Now, people have published this in renowned journals. You can look at that and see, how you can progress or disprove that point. I think that is the only way. But otherwise, I think airway-related research is going to become even more difficult as you move along due to ethical considerations.
Yeah, and redundancy shouldn't be a part of the research, as you very rightly said. It should be clinically relevant. Your results should be, and your outcome should be clinically relevant as well.
No point looking at intubation time. There are other outcomes which are more important. Start looking at that, then it might make more sense. Same device, same subjects, same investigators, but you're looking at a different outcome. Might make a difference.
Yeah, over to you, sir, Dr. Bala.
Yeah, so I would just like to add a little bit to the previous discussion. In fact, one of the serious discussions, as per my information, that happened in NMC was to altogether do away with the thesis for PGs, postgraduates. So that was from one of the colleagues who also part of that meeting. He said, let there be not any thesis, dissertation done in the current form, that they let them present some brief scientific paper or usual poster presentation and e-poster. That is enough. What they found was it is taking away a lot of time of the PG studies. Basically, only thing is let there be more uniform teaching schedule, especially where there are journal clubs. Give higher preference to journal clubs where we talk about methodology, the strengths and weaknesses, review of literature, and everything to be discussed there, and then try to push for small case reports and other things. So that was one which has been taken up. So maybe, but they told it is being considered more seriously, and with the number of PGs being increased in different colleges, it's almost doubled since the last 5 years. So all of us are constrained by the limited number of clinical cases. So there is actually sharing of some of the samples between 2 to 3 dissertations also. That's also happening, and it's also taken as valid. We'll not go into that discussion. And so that probably the NMC has also tried to help out us, because last year the Index Copernicus has been taken off as one of the agencies recognized by NMC. So the so-called predatory journals, I think most of them have gone off the market now. When they come back, I don't know. But at this point of time, they are not there, and the load on our journals will be more now at this point of time. But of course, because we are maintaining the standards, we are rejecting many of the articles. So one help that has probably come from NMC is recognition of 4 authors, okay, including a separate author for corresponding author, and adding a case series. So there are 2 things here. One, they are going to help us, and probably there will be some risk with respect to the quality. So how do we take it forward? Dr. Pradeep, can you please give your opinion on this?
Quality, sorry, quality on?
Quality. So in the sense, people might claim, so I have done 3 cases, you take it as case series, just like that.
Yeah, I would give my opinion on first the ethical issue. That several times, yes, what we are all saying that ethical issues are there with the airway research. Say, for example, if I want to do a study with the apneic oxidation using HFNC, many of the people sitting there and deciding about the ethical art, they will consider no, endotracheal intubation is a standard of care, and what if the during apneic oxygenation, what if the patient aspirates, what if the patient swallows the blood and the patient develops say pneumonia or respiratory pneumonia, or even for that matter, relative may not give you the clearance, may not give you the consent. No, we want our child to be safe. I don't want this nonsense, this apneic oxidation and no intubation kind of thing. No. So these things are really difficult. But then by publication of several case series, we can get enough data, enough evidence that yes, these things can be done, and we can convince the research ethical committee people that there is now enough literature in the form of case series. So that can be one thing. And secondly, as far as thesis work in the postgraduate are concerned, as you have pointed out, I still think that there is a value in thesis writing, because the candidate learns how to do some research work. If he is exempted from writing a thesis, probably he will just go through all the theory work, or maybe the interventional skills would like to develop, but he will never ever learn how to do thesis. At least he learns it, at least preliminary. Okay, this is the study design, this is a sample size, this is what I have to do. This is, I mean, these things are important for future research. If it becomes easy for a PG student to clear, then without writing a thesis, so probably number of ordinary articles will decrease. That I agree, but then they will never ever learn. So rather than exempting them from writing thesis, we should try to improve the quality by several series of lectures and editorial articles, and sensitizing them about the even what is ethics in your writing, and what is plagiarism, and what is duplicate publication. All these things they have to be sensitized only. I believe that it should be continued.
But one thing is with airway related articles, now we are more dependent on devices and equipments generally. Actually, advances, yes, the basic techniques of handling the airway have been discussed for long, and we are more dependent upon, yes, visual endoscopes and new supraglottic devices. Generally, they are costly initially when they are introduced into the market. So would it be apt for us to accept a case series in such situations?
Yes, my take is yes. It is not easy to do interventional study all the times on airway-like thing. Airway is a life-saving part of the whole patient management. So yes, there should be more stress on case series type of application, rather than always pressurizing people to go for interventional study, which is not right actually. Case series may be as informative actually. Though biases can be there, I agree on that, but still it adds to the literature, adds to the knowledge.
Yeah, one more thing to add to the ethical committee thing, one fashionable thing that has happened. Now, I regret to say this. Yes, there has been problem with respect to the opinion of other ethics committee members in different institutions. It must be the case across India, because I am the member secretary in my institution. So there is an external, you have got a specialist who also joins.
Yes.
Yep. So there is more frequently, they raise the point of insurance. Is a patient insured against any damage that might arise out of your research? So this is one new things. Now, of course, in strictly really indicated a novel study, maybe we can consider. But because of paucity of knowledge related to each of our specialty, it has become. Now I'm not telling just like that, because I got this input from at least 7-8 people. They are telling that we have to insure or do something like this. We are upset, number one. Number two, some of them don't understand the meaning of randomization. When we say a randomized control trial, randomization also you should not do. So what they are doing is, our colleagues, they are projecting it as an observational study, but implement randomization while they conduct the study. So this has been the way that has been going taken forward nowadays. Now, of course, let us be optimistic that things will improve in the future also. And now that there is choice, because we are talking about airway, we have got choice with respect to the journal, airway journal, we have got JOSCP, IJA, then IJCCM. So can we guide our potential authors where all they can submit? Can there be a joint approach? Yes, we are all open, we are accepting airway articles. Dr. Atul, something like that?
Well, it becomes a very, very specialized area, isn't it? In the ICU, I mean, it has to be. There are very few studies currently which are being done in intensive care units. Like we have discussed, there is not much that can be done. We can look at different devices, and as Dr. Ramkumar suggested, we should be looking at different outcomes. So if you talk from an intensive care type of perspective, then you are trying to look at how to make the airway safer. I mean, that is the main problem because the patient's problem is something different entirely. That has nothing to do with the airway. Airway is a means of keeping the patient ventilated and oxygenated. So that happens along the way. And when we do a procedure, it is like any other procedure, central venous cannulation, where you don't want a pneumothorax or a hemothorax or things like that. During airway, you don't want any mishaps. So in ICU, the research is more related to how to make airway, securing the airway safer. For example, there is something called as intubation bundle. Then there are airway scores, which we of course share with the anesthesiologist. But there are certain scores which are specifically developed for use in intensive care unit. For example, we are doing a study where we are trying to validate that score which is proposed by someone in our ICU. Intubation bundle is another example of how to make the airway management safer. So essentially, you are trying to make sure that the patient doesn't become hypoxic and patient doesn't have a cardiovascular collapse during airway management, which are big things in the intensive care, not so much in a elective surgery where patients are otherwise fit and whatever happens with the airway management happens when the patient is in the best possible optimized condition, which is not the case in the intensive care unit. So that is the thrust area for ICU. For example, HFNC or NIV, they have both made the oxygenation reserve that you can get before intubation much more than you would get with plain ambu bag ventilation, because you are adding PEEP, some amount of PEEP, and you are adding pressure support in NIV. So that is the kind of approach that we are looking for in an airway article in intensive care unit, intensive care journals.
So if you want to suggest some tips of airway related articles, which could be part of ICU management.
Yes. So so for example, the use of ultrasound for real-time confirmation of intubation, if it happens earlier than the end-tidal CO2 measurement, but then you need expertise for that. I mean, you have to be 100% sure that you are good enough to pick up that. The second was identification of the ectothyroid membrane, which I said we published this year as a part of the safety in case the patient becomes hypoxic during attempts at intubation. Those are the kind of studies which we are looking for publication in critical care journals.
Okay, thank you, sir. Sanju, you can just pick up.
Yes, I think we have another 3 more minutes left. So I think we can kind of sum up. We can have each of the editor letting us know what exactly are the alt metrics, especially for airway to go further. And we can start with Dr. Ramkumar. How would you get authors to be submitting to you, especially the airway research, considering people are more looking at alt metrics of the journal and rather than the quality.
Right.
Yeah.
Right. So I think I would probably answer this question taking a spectrum of junior authors on one side and a senior author on the other. Junior authors are probably just getting into the act of publishing, and they would definitely look for index journals, and I would recommend them to do that. Okay, I would not lead them astray and tell them please publish in the airway journal, right? But I think when you start off, you need to get a few articles into an index journal. So that's the way a junior person should go. And I think we don't need to teach our juniors nowadays how to do market research. It's at the tip of their fingers. They know which journal is good. And there are many things, citation index, author age index, and the popularity of the journal. All these, I think, are combined together to form, I think, what's called the alt metrics. But I wouldn't really, be fooled by this new technology. I'm sorry to say. I think it's more important that we should see what kind of a journal we are publishing and go back to some of the back issues, see what kind of articles have been published, and then think whether that is appropriate for your kind of research. Now, as far as the seniors are concerned, I'm rather pained to say this because, we have a lot of seniors who, when you look at their CV, they have 150 publications in index journals. And there are many such senior stalwarts in All India Difficult Airway Association also, right? So I think these stalwarts, senior members within the association, need to guide the juniors to present in what is called their own official publication, the Airway Journal. I don't think we need to go with a begging bowl to Atul Kulkarni or Pradeep Bhatia and ask him to give us discards from their journal. And I think that would be the way I would go. I think it is up to the senior members of the All India Difficult Airway Association to recognize it is entirely up to them to motivate their juniors and, get it published well, in a journal.
Perhaps I think you can kind of, I could invite them out to write on articles which enlist research, areas of research especially for the newer researchers. So coming from them, from masters and experts becomes a really guiding light for them.
Absolutely.
I would hand over the mic to Dr. Bala Bhaskar for a final comment and wrapping up.
Thanks a lot, Tanju. We are short of time. And the last point which you made was, I think, very apt. And it goes with the ideas proposed by Dr. Ramkumar also. Many times, people would ask us, sir, which topic I should pick? So it is from across the country, wherever we go. So this particular question is why us from our own journal groups distribute a list of topics which are potentially implementable across the country and different setups. So that's one of the ideas. Okay, so these are the articles. I mean, this is the type of article. This is the type of research you can take it up, and they are easy to do in your own setup, and they are more likely to be published in the different journals. So that's one of the ways. And of course, as I told you in the beginning, this was continuation of the last year's discussion. It was purely a healthy academic discussion amongst us, and we hope whatever you have discussed today is very useful to our potential authors when they try to submit the articles and conduct the research also. So we have covered the CTRA part, the ethics committee part, the methodology part, something related to statistics also, and the type of help that can be provided by the editorial group also. So I would thank Dr. Anju and of course the organizing group, and apologies for small network issues in the beginning. Thanks to Dr. Ramkumar sir, Dr. Atul Kulkarni, and Dr. Pradeep Bhatia. Thanks for the good exchanges. Sir, Ramkumar sir.
I'm sorry, Dr. Bala, I forgot to mention one thing. The Airway Journal has brought out 4 articles. The 4th one is coming out in the September-December 2021 issue. It's a series of 4 articles that concentrates on airway-related research by Professor Ramesh A., an ENT surgeon in St. John's Medical College with special interest in research. And I believe that's a must-read for anybody who's interested in airway research. So it's a concluding article coming up in September-December issue. I encourage all IDA members to please read that. Thank you.
Sure.
I believe, sir, you must take your journal to more social networking sites for better visibility. So that can take us furthermore ahead. Yeah. Thank you so much.
Thank you.
Thank you.
Thank you all.
Thank you.
Thanks for the invite. Thank you.
Thank you. Good day, sir.
Good day.
After such an interesting editor session, let's move to our next session, that is on update on airway devices and techniques. To chair this session, I invite Dr. Chandrasekhar CR, Consultant Anesthesiologist, Sagar Hospital, Bangalore, and Dr. Rasesh Diwan, Consultant Anesthesiologist, SAL Hospitals, Ahmedabad. Over to you, respected chairpersons. So
You're muted.
yourself.
Dr. Chandrasekhar, you're muted. Please unmute yourself.
Yeah. Dr. Amit Shah is a well-known member of IDA and is an expert airway specialist. I'll hand over the mic to Dr.
At the outset, I would like to thank Dr. Bhatia, Dr. Rakesh, and Dr. Sheila for giving me this opportunity to speak in this prestigious National Airway Conference. I'll be speaking about video laryngoscopy and an update. And at the outset, I would like to disclose that we have developed a video laryngoscope device and we have a commercial interest in this particular device. But what I have expressed, what I am trying to explain here is the evidences and the views, and it is not to compare any device with our own device. So video laryngoscopy is essentially, instead of direct view from outside, it is your view beyond the curvature of tongue, so that the primary curve, you overcome primary curve, look towards straight away towards larynx, so you don't need to align axis, you don't need to maintain proper position, force is not necessary, and there is a large field of view. The device which looks around corner of tongue is called indirect laryngoscope, and if you use video camera, it is called the video laryngoscope. So video laryngoscope by definition is a device which is used in place of line of sight visualization to accomplish endotracheal intubation. Now earlier with direct laryngoscopy, there are very few devices and we had to do very few things before we start the anesthesia, but now there are multiple devices and we have to understand. So we'll try to understand how to differentiate and classify them and how to optimize intubation with each type of device. If you really carefully look at the blade part which goes inside oral cavity of every device, it has a different shape and angle, and we need to understand that. So first to develop was a device which can be which was essentially anatomically shaped as per the oral cavity, but the device tip was almost pointing towards vallecula, and we can call it hyperangulated device. Second to develop was later on to facilitate easy intubation, a device which was still again anatomically curved but not as much angulated, and it was sort of pointing towards vocal cord rather than vallecula, and we can they were channeled video laryngoscopy blades and they are anatomically curved, and of course camera could always be incorporated in Macintosh type of a laryngoscopic blade and can be used as a video laryngoscope. So video laryngoscope can be classified as anatomically shaped and non-anatomically shaped. Anatomically shaped can be hyperangulated or angulated channel video laryngoscope, and non-anatomically curved could be Macintosh type of a video laryngoscope. So to understand device and optimize intubation with the video laryngoscope, you have to understand angle of blade, which you have already understood. You also have to understand direction of camera and in which direction the vision is, and what is the area of the vision which is available. Also, to successfully intubate, you need to, as in the video laryngoscope, you are looking somewhere else and intubating somewhere else, you need to develop hand-eye coordination. So we'll try to understand how to optimize intubation with the various types of device. So first we'll look at the hyperangulated non-channel type of a device. Hyperangulated non-channel type of device looks up towards larynx. Epiglottis do not block your view and force requirement is actually minimum. But since the angle is hyperangulated, the endotracheal tubes are not shaped like that. You need to change to reach larynx. You need to change the shape of the endotracheal tube with the help of a stellate. Majority of the device are supplied with their dedicated stellate according to angle of their blade. But if you don't have one, then you can use regular stellate, which you can change the shape of endotracheal tube according to your blade. Once this hyperangulated stellate with the stellated endotracheal tube, once you reach the larynx, if you push it further, it will go and hit anterior tracheal wall and you might feel impingement or you may create trauma. So to avoid that, what you need to do is to withdraw stellate outside the larynx and only push endotracheal tube without stellate into the larynx, and this is very, very essential. So here, if you look at carefully, I have introduced, this is CMAC D blade. You get a fantastic view, and once you introduce this hyperangulated stellated endotracheal tube from the corner of mouth, Once you reach the larynx, you carefully observe my fingers. I am only pushing endotracheal tube without stellate. It is essential that you push only endotracheal tube. So these are the 4 important points which you must understand to intubate with a anatomically shaped hyperangulated non-channel blade. Now, anatomically shaped channel video laryngoscopes are, as already discussed, it looks straight and the tip is not pointing towards valvular, it is pointing towards laryngeal opening. So epiglottis may come in your view and you need some lifting force to elevate the epiglottis. After achieving proper view, once you push the endotracheal tube through dedicated channel, it will go straight towards larynx, and passage beyond larynx does not require any further manipulation. But because of this dedicated slot, because this tube track and view axis are connected, if your tube is not going towards laryngeal opening, for altering direction of tube delivery, you require manipulation of device or endotracheal tube. Here, if you look at carefully, as the tube comes out from the channel, it goes slightly down, and then the natural curvature of tube, endotracheal tube shape, it takes up towards the laryngeal opening. So you need to withdraw the device to allow PVC tube curvature to take its own course, or you may need to pull up to helps to direct tube anteriorly. Also, you can do side-to-side movement of the device so that tube trajectory can be altered towards laryngeal opening. Or you can manipulate the endotracheal tube as you are pushing it in the channel, so that tube can be sway sideways on either side by doing clockwise or anti-clockwise movement, so that the tube can be directed towards laryngeal opening. Macintosh type of a video laryngoscope blade, basically you may or may not require stellate introduction. You can be introduced from the center of oral cavity or from the angle of mouth. Procedure, pressure and displacements are almost similar to conventional. So it is good for the teaching, but its role in difficult airway has been questioned by few authors. So this is Macintosh type of a video laryngoscope blade. If you carefully look at this patient, you get a good view, but you can intubate without use of stellate. So I'm introducing it without use of stellate. You can directly intubate. There are many Macintosh type of devices are available in the market, and in fact even you can use bougie with the such video laryngoscope devices. So golden rule for successful video laryngoscopy: you need to check the device, battery, charging, anti-fogging, etc. Angle and channel blade video laryngoscopes devices are introduced from the center of oral cavity. Sniffing position may not be helpful according to one study where they have compared, they have seen sniffing position as a counterproductive position in angulated and hyperangulated, so the anatomically shaped device. Always look inside oral cavity whenever you are introducing any either device or endotracheal tube, and you should not see only on the screen, which creates blind spot. Experience with standard Macintosh blade laryngoscope does not equate to the skill with the video laryngoscope. Experience with one video laryngoscope does not mean that you have skill for every video laryngoscope. A good video laryngoscope you may not guarantee you easy intubation. A bougie may not be of solution, especially in anatomically shaped device. And the video laryngoscope chosen must be selected according to the indications and according to these 3 clinical situations: rescue or anticipated difficult airway, hyperangulated or anatomically shaped channel video laryngoscopes will work better. For routine users, that Macintosh type of device really works well and easily. But after little experience, you can easily use anatomically shaped device. But if there is a blood in the airway, only device which works is a Macintosh type of device. Now we'll try to look at the update on various situations and procedures where video laryngoscopy can be done. So first we look at the Cochrane review, which was published in 2016. 64 studies identified during this 2015 survey that enrolled 7,000 patients. And authors very clearly identified that video laryngoscopy may reduce number of failed intubation, particularly among patients presented with a difficult airway. They may improve glottic view and may reduce the laryngeal or airway trauma, but it may not reduce number of intubation attempt or incidence of hypoxia or respiratory depression. So adult patients, VL versus DL, adult patients, if there is a difficulty, it is going to have a definite role. Again, video laryngoscopy versus direct laryngoscopy, known difficulty for the experienced anesthesiologist. 9th study, including 1,329 patients, use of video laryngoscopy was associated with significant better view, less mucosal trauma, and it has definitely added value for experienced anesthetists, improving first pass success and the view of glottis and reducing mucosal trauma. In children, results are not so encouraging. Evidence suggests that indirect laryngoscopy or video laryngoscopy leads to prolonged intubation time with the increased rate of intubation failure when it compares with the direct laryngoscopy, though this is very low quality evidence. So it might lead to improved view, but we are not sure about its other part of the intubation success. Similarly, other meta-analysis also concluded that there is no benefit in pediatric patients on time to intubate and failure of the first attempt. They are nearly same with the direct laryngoscopy. In obstetric patients, there are 4 RCTs with 428 participants, 9 observer studies, and 35 case reports were included, where 100 participants were there. So first pass success rate and time for tracheal intubation demonstrated no difference in video laryngoscopy and direct laryngoscopy in patients without difficult airway. But patients' observation studies and case report underline the role of video laryngoscopy as a primary choice when difficulty with tracheal intubation is expected as a rescue modality or in difficult or a failed intubation. Similarly, orotracheal intubation comparison of video laryngoscopy versus direct laryngoscopy outside operation theater, where they identified 15,000 plus emergency intubation. VL compared with direct laryngoscopy associated with greater first pass emergency intubation in ICU and among less experienced clinician reduces the esophageal intubation, but it was associated with higher hemodynamic instability. Video laryngoscopy versus direct laryngoscopy in neonates, author concluded that though there is a moderate to very low quality evidence suggests that video laryngoscopy increases the success of intubation in the first attempt, but does not decrease time to intubation or number of attempts for the intubation. For awake tracheal intubations, 8 studies including 429 patients were included. Video laryngoscopy for awake tracheal intubation is associated with shorter intubation time. It seems to have success rate and safety profile comparable to fiber optic bronchoscopy. In obese patients, 1023 reports initially identified 8 RCTs involving 747 patients were eligible. A video laryngoscopy overall superior for tracheal intubation as it improves glottic view and makes intubation easier in short intubation time and reduce intubation failure in obese patient. Again, it has identified another meta-analysis in obese adult identified that performance of both type of video laryngoscope with or without tracheal tube guide was superior to that of Macintosh laryngoscope, except for the intubation time where channel video laryngoscope works better. So at end of my lecture, video laryngoscopy definitely improves glottic view in all the situations. It improves success rate in predicted difficult or difficult airway situations. It has been found helpful in emergency room, obese individual, obstetric patients, and neonatal patients. In pediatric patients, though it provides better glottic view, it may take prolonged time and authors' conclusions are not encouraging. And in awake tracheal intubation, it is as good as fiber optic intubation. Thank you for your kind attention.
Can we move on to the next speaker, please? Dr. Apex Patwa is the Chief Consultant Anesthesiologist at Vadodara. Over to you, sir.
It's a pleasure to be here with all of you. Thank you, Team ADA Jodhpur, for giving me an opportunity to speak on awake tracheal intubation. Awake tracheal intubation is an established technique. Look at this video from Dr. Chandi Varghese. Awake supraglottic airway insertion and followed by fiber optic through the supraglottic airway and intubation, self-intubation. How is possible? It's possible just because of optimal airway anesthesia. So success of, it's an established technique, but the success of awake tracheal intubations depends on the mainly two factors. Patient factor means patient should have proper comfort, and that can be achieved by airway anesthesia and optimal sedation. And operator factors depends on the decision making of the selection of devices, and we should have proper optimal skill and experience to use that devices for awake tracheal intubation. Then and then we will be having a success, and we should not compromise the patient safety. So when we are performing the awake tracheal intubation, optionate through any possible route, and we should have backup plan. So airway anesthesia plays a crucial and important role for the success of awake tracheal intubation. And see, common issues with the awake airway management is the discomfort and sympathetic stimulation associated with the awake airway management. And gag reflex, glottic closure reflex, and cough reflex are the protective mechanism against the invasion of foreign body into the airway. And we need to block it. We need to prevent its reflexes by the airway anesthesia. And usually that can be done. To block the gag reflex, we need to block the glossopharyngeal nerve. To block the glottic closure reflex, we need to block the superior nerve. And for the preventing cough reflex, we need to block the recurrent laryngeal nerve. And if you look at the sensory innervation, most of the nasal part is supplied by the branches of the trigeminal nerve. An area posterior pharyngeal wall, posterior third of tongue, to the superior surface of the epiglottis is supplied by the glossopharyngeal nerve. And the inferior portion of the epiglottis up to the vocal cord is supplied by the superior laryngeal nerve, and infraglottic region is supplied by the recurrent laryngeal nerves, which are the branches of the vagus. So which type of route and devices or technique you want to use for awake airway management, according to that you need to block the nerve. For a nasopharynx and oropharynx, you need to block the trigeminal and glossopharyngeal nerve. If you want to use the supraglottic devices or orotracheal intubation, then you need to block the glossopharyngeal nerve and vagus nerve. And if you want to go for a nasotracheal intubation, then you need to block all three nerves, trigeminal, glossopharyngeal, and vagal nerve. Let's look at the different blocks. See, glossopharyngeal nerve can be blocked by either intraoral approach or peristyral approach. When you are selecting the intraoral approach, you need to have a proper mouth opening of the patient, and you need to insert a needle into the glossopalatal base of the glossopalatal fold, 0.5 centimeter lateral to the lateral border of the tongue, and you need to inject at least 2 to 3 centimeter local on each side. So another block is a peristyloid approach of the glossopharyngeal nerve is associated with the high complication because this nerve lies adjacent to the major vascular structure, and styloid process is identified by the line, midpoint of the line joining the mastoid process and mandible. And you need to insert the needle perpendicular to skin plane to hit the styloid process. Then you need to redirect the needle and go underneath the styloid process 1.5 to 2 centimeter deep from the skin area, and you need to inject 2 to 4 cc of local anesthetic agent to block the nerve. And again, you need to perform this block bilaterally. However, in most of the clinicians are using the 10% spray over the posterior wall and the base of tongue to achieve the glossopharyngeal nerve block. That is another technique over and above the invasive technique. Again, superior laryngeal nerve can be blocked just underneath the greater cone of hyoid bone. After fixing the hyoid bone, on the lateral border of the greater cone of hyoid bone, you need to insert the needle underneath the hyoid bone 1.5 to 2 centimeter deep from the skin, perpendicular to skin plane, and instill the local anesthetic, inject the local anesthetic agent. And you need to perform this block bilaterally to adequate and optimal anesthesia. The another block is a translaryngeal injection. This you need to locate the cricothyroid spray, generate the wheel over the cricothyroid space by the local, then insert the IV cannula on the inferior portion of the cricothyroid membrane.
Injection
Then inserting the needle cannula inside, aspirate the air, then withdraw the needle, advance the cannula into cricothyroid membrane. That's this, and then inject the local anesthesis to the IV cannula into the infraglottic region. And this serves two purposes: it's anesthetize the infraglottic region, and as well as it's acting as a landmark as you are crossing through the cricothyroid membrane. You can identify the cannula inside and proceed. And if required, you can repeat the local anesthetic injection through the cannula. So coming to the selection of devices, see, flexible endoscopic intubation or fiber optic intubation is a gold standard for managing difficult airway in an awake state. But video laryngoscope and video stillate emerging as a comparable, effective technique with the flexible endoscopic intubation for awake tracheal intubation. So there are this very interesting publication of 2018. They have systematically review and meta-analysis of the video laryngoscopy versus fiber optic scopy for awake tracheal intubation, and their main objective to identify the time needed to intubate. And very interesting finding: awake video laryngoscopic intubations having a shorter time to intubate compared to the fiber optic intubation. And considering the complications, first attempt success rate and failed intubation, there were no significant difference between the video laryngoscopic intubation and fiber optic intubation in awake state. So there are number of devices available: channel bed, non-channel bed, video stillate. So another very interesting systemic review and network meta-analysis of 2021 published in the July only, and they have compared the fiber optic scope, video stillate, non-channel and channel bed for awake tracheal intubation, and they found that the video stillate took shortest time to intubate and fiber optic scope took longest time to intubate. So and considering the first pass success rate, incidence of esophageal intubation, change of airway technique, oxygen desaturation, airway bleeding, or the rate of horses and sore throat-like complications, there were no significant difference among all these four devices. So they concluded flexible bronchoscope, optical stillate, and the channel and non-channel video laryngoscope were clinically comparable for awake tracheal intubation. However, further work should focus on the optimal airway device for awake tackle intubation in different specific clinical scenarios. So we are having number of technique to perform the awake tackle intubation like flexible endoscope, video laryngoscope, video stimulated blind nasal, and retrograde intubation. Let's look at the different techniques. This is one of the video of non-channel video laryngoscopy intubation through a nasal route. So this is the post-hemimandibulectomy case for the redo surgery where bilateral superior laryngeal nerve block and transcrical injection was given and nasal passage was lubricated with the xylocaine gel and introducing the tube up to the oropharynx, asking the patient to open the mouth. And we could see the laryngeal structure and advancing the tube into the larynx. And many times, if your tip is not directed towards the laryngeal neck, then you need to inflate the cup to align the tip with the laryngeal inlet. That's called the cuff inflation technique. Look at the patient's comfort; he's fully awake and even sitting. See, this is another technique of awake tackle intubation with the video laryngoscopy with the channel blade. Here, the airway anesthesia in form of a glossopharyngeal nerve block, bilateral superior laryngeal nerve block, and transcrical spray. And we could easily intubate the patient in an awake state. This is another device. As called, so usually size of the video stilate is 4 to 5 mm, and you can bend the tip 3 centimeter proximal to the tip, and you can load the tube over the stilate and then bend it again to make a hockey stick reshaping. This is one of the video of awake tackle intubation with the video stilate. Video stilate has to be introduced in a two-way, either retromolar or central position. This is one of the video with video stilate introduced into the center and maintaining the centralizations. Able to see the epiglottis. You have to go underneath the epiglottis to visualize the laryngeal structure. And once you visualize, then you need to detach the tube from the stilate and advance the tube inside the larynx. Look at this, you can visualize the tip which is going in, tip of the tube which is going in. And you can visualize, appreciate the tracheal rings also. And after intubation, connecting the tube with the circuit and checking the ETCO2 waveform. And look at the patient comfort. Patient showing there is no discomfort and showing the tongue. So flexible endoscopic intubation or fiber optic intubation is gold standard and established technique to manage the patient in a awake state for intubation. It has to be introduced perpendicular to face plane. You have to go inferior to inferior surface of the inferior turbinate. Can identify the entry into the oropharynx by oval shape opening. Visualize, you can easily visualize the laryngeal structure. Secretion and fogging are the common problems, common hurdles with the fiber optic intubation. And once you are, and to make entry into the larynx, you need to flex the tip of scope downward if you are performing from the head end, and identify your entry into the trachea by a tracheal rings. And once you visualize the carina, advance your tube from the scope into the larynx. And because of lack of time, I'm not able to cover the hurdles, tips, and techniques of the awake fiber optic intubation in detail. So simple recommendation for the vertical intubation. Select the technique in which you are having expertise and confidence. Take measure to increase the comfort. Oxygenate to any possible route when you are doing airway management. Ensure adequate airway block. Limit the maximum dose of lidocaine. Caution use of minimal sedation. And administer anesthesia only after confirming the EDT placement by ETCO2. And usually this training of the vertical airway management requires structured training, starting from the classroom teaching to simulation-based training, followed by supervised on-patient training, and then we should have to give the independent exposure to the candidate. And minimum exposure is required to overcome the learning curve, and they should have group discussion for improving analytic and thinking for the decision making. And that's the reason AIDA is running a fellowship in advanced and difficult airway management. It's a residential fellowship. Thank you.
We'll move on to the next speaker, Dr. Sohan Solanki, is a professor of anesthesiology at Tata Memorial Center, Mumbai. Over to you, sir.
Hello everyone, I am Sohan Solanki and I will be speaking on the use of high flow oxygen therapy. So what is high flow oxygen therapy? So high flow oxygen therapy, when we give very high flow of oxygen around 70 liters per minute to the patient, and this gas or oxygen is heated and humidified, because an increased flow would be always detrimental to the tissue if it is dry and cold. It also increases safe apnea time and prevent desaturation. So high flow oxygen therapy, if it is given in a patient with the use of muscle relaxation, it is called the Thrive, and it gives 100% oxygen. And if it is used in a spontaneously breathing patient, it is always with the oxygen blender, so which give oxygen from around from 21% to 95% maximum FiO2. What is Thrive? So Thrive is transnasal because it is given through the nose, humidified because the oxygen is humidified and heated in the humidifier, and it is called the rapid insufflation because the very high flow is given and is cause the ventilatory exchange at the alveolus level. So this Thrive is very effective in oxygenation. It clears CO2 from the body. It has a PEEP effect and is always heated and humidified, so it is comfortable to the patient. So the Thrive is useful for the pre-oxygenation in the operating room. It is useful for the apneic oxygenation and also for the apneic ventilation. So when should we consider Thrive? So Thrive is considered for the apneic oxygenation for airway instrumentation and procedure. Also during an anticipated difficult airway where we give the supplementary apneic oxygenation. Also in the operating room after the extubation, and in any procedure under apnea, like in the endoscopy suite, we can do use the Thrive for endoscopy. So what is apneic oxygenation? So we all know that a human body at rest consumes around 250 ml of oxygen, and this 250 ml of oxygen is taken from the alveoli and carried by the bloodstream to the tissue. And at the dirty tissue level, around 20 ml of CO2 is produced, which is carried by the bloodstream to the alveolus. So this creates a negative pressure inside the alveolus, which cause a mass flow of the oxygen into the lung. And we all know that in a normal healthy adult, the FRC is around 1.5 to 2 liter, so which can give the apneic window of around 6 to 8 minutes, but it can further reduce in a patient with any risk factors. But if we give high flow of oxygen, maybe around 70 liters per minute, it increases the oxygen reserve, it improves the FRC, and it helps in the extending the safe apnea period in this patient. It also has a PEEP effect, which can keep the airway open for the effective oxygenation during the entire period of apnea, and it is also heated and humidified, so it prevents any mucociliary damage. What is apneic ventilation? So apneic ventilation is because of the cardiac oscillation. So these cardiac oscillation act as a pump for upward and downward movement of gases when patient is apneic. And this is called the vertex approach. When we give the high flow oxygen at the supraglottic level, and along with this cardiac oscillation, it helps in the ventilatory exchange at the alveoli level, and it limits the increase of the arterial CO2 during the apnea period. So it is very beneficial during, especially in a prolonged apnea period, especially in like in the airway surgery or some ENT surgery, but probably it is not helpful when we need during an emergency airway management. So this is the Thrive machine. We will discuss into the videos demonstration. So this is the Thrive setup in the this left diagram. This Thrive is being used during the time of the intubation, and in the right diagram we can see that this is used during the endoscopy into the endoscopy suite. So this is the video we recorded during a procedure under apnea. So this is the Thrive machine, and it has an oxygen source which is connected to the central oxygen supply. The pipe connected to the central oxygen supply. And this is the high oxygen flow meter, which can give oxygen up to 70 liters. And oxygen by through this pipe will go to the this humidifier. And this is the patient circuit connected to the humidifier. And this circuit will be connected to the patient via the nasal cannula. This is the water bag. So this water bag is used to fill the humidifier whenever the water is empty or the desired level is not there into the humidifier. And this is the nasal cannula to give the high flow oxygen. So this is connected to a HME filter, and this end will go to the patient's circuit. These are the two soft this nasal prongs which will be connected to the patient nostril, and this tubing is connected for the EtCO2 monitoring if we want to monitor the EtCO2 during the pre-oxygenation period. So we will connect these prongs to the patient with the help of the strap given along with the cannula, and this end is connected to the patient circuit. So you can see this patient is connected to the nasal cannula, and this patient is now until now it is completely awake. So we'll give oxygen around 35 to 40 liters for the pre-oxygenation purpose. You can see the screen. So the screen will show temperature. So you can change temperature from 33, 35, or 37. 37 is always default setting. And you can see this the temperature. Also, the temperature at this the temperature when the oxygen is being given to the patient. So after the pre-oxygenation, we can induce the anesthesia. We can give the muscle relaxation. You can see on the screen the patient SpO2 is 100%, and after the patient is induced, we can increase the oxygen level up to 70 liters per minute. And we have given the patient to the surgeon for the procedure, and the patient SpO2 is still 100%. And the surgeon is taking the biopsy from the vocal cord. You can see the SpO2 is still 100%. So after the surgery is done, we can do the dental suctioning to remove any blood clot or any secretions are there. And we can keep this high flow oxygen till the patient is awake. So you can see on the monitor that during this entire surgery period, which took around 12 minutes, the SpO2 was 100% without any mass ventilation. We have also used this Thrive machine into the operating room in the for the intubation. So you can see that this the Thrive is used for the pre-oxygenation and also during the 3 period after the given long-acting muscle relaxation. And so no back mask ventilation was done after giving anesthesia, and we have directly proceeded with the intubation. So intubation was a little bit difficult in this patient, but we managed to intubate the patient with the help of normal McIntosh blade. And after the surgery is over, we extubated the patient also over the thrive. So once we deflated the cuff, we on the flow, and then we extubate the patient over the thrive. So in this, neither during the intubation nor during the extubation, there was no back mask ventilation needed for this patient. So what is the other use of the, what is the second use of the hypopneumic oxygenation is when the patient is spontaneously breathing. So it is mainly used in the intensive care unit for the acute hypoxemic respiratory failure. And nowadays in the COVID-19 patient, the principle is same. We give the high flow inhaled oxygen up to 70 liters per minute. But the goal here is to deliver a respiratory flow rate sufficient to meet or exceed the patient inspirative flow rate. What are the physiological benefit of giving high flow oxygen? Because it gives the more reliable delivery of FiO2. It also washes out the nasopharyngeal dead space. It has a PEEP effect. It causes the alveolar recruitment and also improve the mucociliary clearance. In what condition we should use in the patient with acute hypoxemic respiratory failure? So if the patient is having a PF ratio of less than 300 over oxygen 6 liters or above, the patient is having a PCO2 of less than 45, and if there is no history of any chronic respiratory failure. And in what condition we should not be using high flow? When if the patient is needing immediate intubation, the PF ratio is less than 150. If the patient is having a rapidly progressive respiratory failure, or the patient is hemodynamically unstable and on support, patient is having a severe and unstable arrhythmia, if the patient is having a low GCS or copious secretions, and if the patient is having a hypercapnic type of the respiratory failure, then we should not be using the high flow oxygen in the patient. So this is the high flow oxygen used in the intensive care for the acute hypoxemic respiratory failure. So you can see that this is the oxygen blender, and so it blends the oxygen and can give oxygen from 21 to 95% of the maximum. And by these two buttons, you can increase or decrease the flow rate from up to 70 liter, and you can increase or decrease the FiO2 by just decreasing or increasing the flow on the flow meter. So this is the patient is like given this high flow oxygen therapy in intensive care for acute respiratory failure. Thank you very much.
Thank you, speakers. Dr. Rashesh is there?
I think he's not
sir,
there.
Dr. Rakesh Garg is there, sir.
No, Rashesh, other chairperson is not there.
Dr. Rakesh will join us, the chairperson.
Okay.
Because of unavoidable circumstances.
Okay. Thank you, all the speakers.
Dr. Rakesh Garg, Additional Professor, AIIMS, New Delhi, will co-chair this session along with Dr. Chandrasekhar. Thank you.
Thank you, madam. Thank you.
Thank you, all the speakers. I got a few points we have noted. First, I'll come to Dr. Amit Shah. Congratulations for your excellent presentation, sir. So you said about the new device. Is it devised by you or it's commercially available?
Device is not commercially available. We are again revamping it. So it's right now it is not commercially available.
Okay. See, in fact, approximately what would be the cost? Because commercially available devices are a bit expensive. Not all institutions may not afford all those things.
let's see, we are not right now in position to comment on what would be the cost of device. We are still, actually, we had it in market. Then because of some problems, we are revamping that entire device. And right now, I think I'm not I'm unable to comment on what would be the approximate cost of the device. But obviously, we will try to.
I'm just objecting. Sorry, I am just intervening you. Just because of conflict of interest, we should not discuss this point cost in this platform.
I agree. I think, Dr. Shekhar, if you allow me,
please.
I think similar question we can ask. Now the market is full of so many video laryngoscopes. If you just go on Google, the market is full of them, and every now and then some modification comes to you. So for the benefit of me, if I want to purchase say 1 or 2 video laryngoscope on a generic way, with your experience, what will you suggest to us, the participants who are listening, that if they want to have 1 or 2, which they should go for in a clinical practice when they are facing difficult airway?
So it depends upon, number one, what your clinical practice is. And if you are having more difficult airways, if you are likely to have more difficult airways, then anatomically shaped device, either hyperangulated blade device or the device which is channel, which is also angulated, not hyperangulated, but they have angulation. So either of device, depending upon your power of purchase, you can take that call. And there are various types of device at various cost ranges available, so you can take that call. If you are associated with the teaching institute, and if your purpose is to teach students, that is a primary purpose, then I would suggest that you can go for a Macintosh type of device, because it is an easy transfer from a direct laryngoscopy to Macintosh type of a laryngoscopy. And now in Macintosh laryngoscopes also, there are versions which are hyperangulated blade. So if in case of difficulty, you can use those particular hyperangulated blades. But for the routine intubation, you can use the direct laryngoscopic type of Macintosh blade, which it is very good for the teaching and for the team communication. So it depends upon what your clinical practice is.
But I think what I could gather from you, sir, is Dr. Amit Shah, that probably the hyperangulated, one set of hyperangulated and one set of anatomical blade would be a good option to have a combination in patients in centers where they are facing often on difficult airway. This is what I could
Yes. Hyperangulated and angulated would be good choice. Whatever device you choose, you should have proper experience, and you should try it in couple of times till you get confidence with that device in some normal patients, so that you can gain an advantage when you face a difficult situation. So whatever device you use, you should have proper clinical experience of using that particular device in number of patients.
Sir, Dr. Shekhar, you were asking something. Sir. Sorry, I interrupted you between.
Yeah. Okay, Dr. Rakesh, please.
Dr. Sohan Solanki. Dr. Apex Patwa, so you talked about the awake intubation, and you were talking about various techniques of creating the anesthetic aspect of it. So sometimes we use combination of those things, spray as you go, and then gargles, and then sometimes some blocks, and we use anesthetic agents in different volumes for different things. So is there any concern or safety with regards to the total anesthetic dose to prevent the toxicity? How do you, with your experience, how do you just manage different solutions at different places so that we are not causing toxicity?
Usually, in a simple way, you should not exceed the dose of local anesthetic, specifically Lidocaine, 9 milligram per kg, and according to you titrate your technique. So usually in my experiences, what I am using, I am lubricating the nasal passage if I am using for a nasotracheal intubation, nasal passage with the xylocaine gel, followed by a 2 or 3 spray of 10% xylocaine over the posterior pharyngeal wall, and 3 cc at 1.5 on each for each superior laryngeal nerve block, and another 2 cc for transcricoid spray. So my local spray will not exceed more than 9 milligram per kg. So you should always, and regarding the sedation, so those who are starting their career for doing awake tracheal intubation, they should not use sedation, because sedations, you need to have a proper or optimal titration of sedation when you are using in awake tracheal intubation. And you should not use the sedation just for replacing, there is a replacement of the inadequate topical anesthesia. That is most important thing. And sedation can lead to a decrease anterior posterior depth of the pharynx, which can increase the difficulty of negotiating the pharyngeal part when you are doing in a awake in combination with the sedation. So as far as the sedation to be used only to relieve the anxiety, and you need to titrate in an optimal way that there should not be any collapse of the airway, and at the same time patient should follow the command.
Absolutely. I think a very good, important carry-on message you have mentioned, sir, and it will be useful to us. I think Dr. Sohan, for some reason, having some network issues, so he's not able to join. I will put forward this question to any of you, Dr. Apex or Dr. Amisha, for this. We are talking about the HFNO for airway management, for procedures, and so on and so forth, sir. What is your experience and its role during the extubation part, or during the extubation in a critical care setting? Do it have a role? Can we use it doing some extubation in a critically ill recovering patient for early extubation? Do it have some role for Sohan is with us? I think he's able to join. So any one of you, sir. Sohan.
Sohan is there. I think Sohan is there. Let's take the question by Sohan, then we'll add on that part.
Dr. Sohan, welcome. Welcome back. So I was just asking, your session was really wonderful when you talked about the HFNO role in our clinical practice. I was just asking, with your experience, what role does it have at the time of weaning and extubation in operating room and critically, especially critically ill patient? Can we use it? If yes, what will be those patients and how to use it in very brief?
Yeah, so actually it has a role, because if we use this high flow after the extubation, and we continue to give around 70 liters of this flow, so it will give a PEEP effect also, and it will help in any reintubation in those type of patients.
So how exactly are you using it? I mean, what will be the group of patients, and how do you start with? You are using for some duration soon after extubation. So just with your experience, or any of the speakers here can just highlight.
I'll take this question, Dr. Rakesh. See, if you look at the mechanism of action of the HFNO devices, so how it will be helpful is that depends on the patient conditions. Like it's a one thing, it decreases the work of breathing. That is one thing. Second is possible to provide the 100% FiO2 by matching the flow as per the patient peak inspiratory flow rate during the expiration, during the extubation. That is second thing. And a third thing is generate the CPAP of 3 to 7 centimeter of H2O, so which prevents the atelectasis if it is going to happen in a post-op period by keeping the alveoli open at 4 to 7 centimeter of H2O. So this is how it's helpful in during at the time of extubation and post-extubation period. So it's decrease the work of breathing, it improves the oxygenation, and it keeps the alveoli open.
And also improves patient comfort also.
And
nasal cannula will improve patient's comfort versus a mask where patient may feel claustrophobic.
Yeah, so as soon as we deflate the cuff, I think we should start the flow, so that there is some oxygen will go into the lungs before we just pull out the tube. And it has a PEEP effect. I think it's around that 3 to 5 of PEEP it gives, not very much, but it definitely helps in keeping the airway open, and that high flow is beneficial in this patient.
I think very important message, because when we are talking about the weaning failure, or probably the extubation failure, I think this will be one of a very good rescue tool, because we are aware that re-intubation or extubation failure do have a high morbidity in various aspects. So I think this emerging rule, and COVID has taught us the use of HFNO very well, and now I think most of the centers have it. So I was just not suggesting it. It was being used in the ward, so it's a good opportunity for all anesthesiologists to get those HFNO back to your ICUs and recovery areas and OT, so that we can use it comfortably for our patients. So we should not be let them lie in the one corner of the ward of COVID. Let it be back to our OTs and we can use it. Dr. Chandrasekhara, any questions from your side? We have another.
Dr. Apej,
yes, sir.
You were talking about the video laryngoscopy versus fiber optic intubation. See, what is happening regarding the time duration? What we generally as a postgraduate teacher, we teach is only these fiber optic, all these things come only during difficult intubation. We have started a study on video laryngoscope compared with fiber optic in routine patients. So our postgraduates started doing fiber optic in routine patients. Our study, the time duration of intubation has drastically come down. Research is going on. We'll be able to tell you how useful if it is starts using in a routine cases. And the other thing which I wanted to add is, see, the same we are talking about HFNO. See, the fiber optic intubation, we have got two channels. One is for suction, other one is for injection. What we do is, once we put to the injection port, we connect a high flow oxygen. Say now newer machines will deliver up to 15 liters of oxygen. Go in, see that pressure dilates the oropharyngeal, because esophagus, pharynx and all in the spontaneous patients, you collapse and expand, collapse and expand. If you start giving a high flow oxygen, one is your vision will be good, and there will be the collapse will be minimal. So these three points which I've noticed. Have you any experience in these things?
So I'll just add to these things. So you are using the high flow through the instrument channel of the fiber optic.
Yeah, because as you enter,
yes, sir.
the pharynx starts moving.
The problem is using the high flow through the instrument channel. When your scope tip is in the oropharynx, that is fine. But when you are entering into the larynx, and if you are delivering high flow, there are higher chances of having barotrauma. So it's not recommended to use the high flow when you are in the trachea. Then you should reduce the flow to 1 to 2 liter rather than using the high flow when you are in the trachea.
Yeah, it is useful to prevent the collapse.
And true, but at the same time, there are risk of barotrauma if you are using high flow inside the larynx at the level of trachea.
So, it is. I feel that if you want to use high flow nasal oxygen with fiber optic intubation, it is more preferable, though it helps you in initial oropharyngeal dilatation, but nasally it is more advisable. If you have to give it nasally, so that there is an oxygen flow, there is a CPAP, there is slight dilatation of the oropharyngeal cavity, and then it will not have that problem of barotrauma when you go inside the larynx and trachea.
As Rakesh pointed out, this COVID has taught us a lot of lessons. This is one which adds on to our armamentarium, because you connect nasopharyngeal, go in and intubate, ventilate, and do whatnot.
Yes, I think I know we have such wonderful experts here. We can go on discussing for next couple of hours and days with them. They are full of experience. Dr. Apej Patwa, Dr. Amisha, and Dr. Sohan Solanki. They're full of experience of decades. But due to shortage of time, I think we need to wind it off. And thank you so much for a wonderful session, Dr. Sohan Solanki, Dr. Apej Patwa, and Dr. Amisha. And I, along with my co-chair, Dr. Chandrasekhara CR, thank you everybody. Thank you organizers for giving this opportunity. And thank you all the participants for your wonderful inputs. Thank you so much, and over to organizers.
Thank you all. And being the host for the next year, I'd like to invite all you people to come and physically come and share our hospitality and share the knowledge. Thank you. Thank you, everybody.
Thank you.
Thank you, Chairperson. Bye.
Thank you very much.
Thank you.
Thank you, respected chairpersons, and for this wonderful discussion on airway equipments. We now come to an end for our pre-lunch session. We have a 30 minutes lunch break and we will restart the session at 12:45. Please do join us for the interesting airway quiz after the lunch. Looking forward to have you all. Thank you so much.
So I think personally, I will request all the attendees and everybody to come up with the quiz and cheer the team. It will truly be a wonderful event, a live event. In the form, you will just feel it live. So a wonderful team and wonderful quiz masters, very nicely arranged. And Dr. Apex wants to speak something.
Yeah, and there will be enthusiasm from the delegates, and there will be an expert quiz master with us, like Dr. Rakesh.
No, it's a big
So
team.
you should not miss this. You should not miss this opportunity to enjoy and learn during the quiz.
And our secretary has already started the lunch, so we are missing it. So we could see our secretary having, and the president-elect. Okay, thank you so much. Have a happy lunch.
Happy lunch.
Huh?
Happy
No,
lunch.
both of you are not lunch, groundnuts. Both of you are pulling each other's legs, huh? Okay. I wish we could meet. No, next year. Next year, Bangalore. Bangalore, we are coming.
Yeah.
Go have some lunch. Lunch break is going on.
There is an meet the expert session going on. Please join in the networking lounge.
Avinash?
Yes, sir, I'll call you.
Good morning. Good morning, Rakesh.
Yeah, hi, good morning.
Good afternoon, sir.
Good morning, Mrityunjay.
Good morning,
We
sir.
have to admit Dr. Murali Shankar. So hall coordinator has to tell us.
So I'll tell Avinash, can you allow Dr.
I'll send you the link.
Yeah, yes, sir.
Dr. Murali Shankar is not in the waiting, sir.
No. So I'll send him the link.
Yeah. I will request all the team who are entering, keep your video on now. And may I know who is this? If you can rename the painkiller, your actual name, please. Avinash, please allow team C to enter into the panelist, which is there in the attendees.
Let me. Yeah, team C, yes, sir. Yeah.
Dr.
C
Murali
is
Shankar is
joining.
trying to
Yes.
join.
Sir, you can send him and ask him to enter through the faculty lounge, sir, in hall A.
Yeah, I tried. I again sent him the faculty link.
Okay.
Even otherwise, I'll send him.
Right. So I will request all the team of quiz to join immediately so that we can start on time. If they are not joining, the team can be disqualified also.
So team A is joined, team C is joined, and the painkiller is team.
There are 4 teams.
Shall we write the ABC or the name of the?
No, I think we can keep as team A, team B, team C, and team D like this.
Okay.
In a uniformity. So we have mentioned them into the.
You can say C and you put your name, no problem. You can say C and then your team name.
Yeah.
No? You can use that all. Team C and after that you can put the name.
Team C, I think there are 2 team C on the screen. They both are same.
No,
because they are sitting separately.
No.
Why there are 2? They have.
I think the painkiller. Team D. Okay, fine.
Yes, they have come now.
Team B, can you please open your camera? Team A also.
Team A.
Okay, 4 teams are here. Can you please unmute yourself so that we can check your audio?
And in case team C are 2, can you just keep Dr. Shripad? Can we keep them as team C1 and C2 because they are in 2 different modes?
Yeah, that is what I was about to say. If they have split, you should use team. Which team? Team C, huh?
No, sir.
We
are just one team, team C.
Team D, sir.
So team D, can we put as team
D1? Make it team D1 and team D2.
Yeah. No, sir. Actually, it was maybe confusion. Team A, team B, team C, and team D. 4 are there.
Right.
Yeah.
So I can see team A, all the 3 members. I can see team C, all the 3 members. Team B, all the 3 members. Team D, 2 members are here.
Team D, only 2 members are there. Yes.
So just unmute and speak. Are you 2 members only, or the third person will be joining from a different link?
Sir, they'll just join in 1 second, sir.
Sure, please. And keep your video on throughout the session. So don't switch it off. Okay.
You can put him be there, no problem. Am I clearly audible?
Yes, sir. Yes, sir.
Thank you.
Team D, is there any participant in attendee? Can you please check? You can check in the attendee.
Sir, 1 second, sir.
Devasis Gaur, okay. Devasis Gaur, please click on join as panelist. And Devasis Gaur is from which team?
Is Devashish part of team D, please?
No, no, sir.
I think it's from team D.
No.
No.
Link fast. Zoom link.
Devashish is from which team? Can you just raise your hand and speak?
Put on camera and say team D1.
Sorry?
Devasis Gaur.
Just hold on, Avinash. Let's see. Devashish Gaur is from which team?
Yeah.
Team members, are you aware of your team member name? Devashish Gaur is from your team. Should we
Yes,
allow?
yes, sir. Yes, sir. Yes, sir. That is our third team member, Yashashmi, sir.
Yes,
Okay.
Sasvi. Okay, let me.
Avinash, allow,
Can you let
and
me
ask-
rename? Let me rename. He's already in. Let me rename.
Rename it as team D2 and team two members. You change your name as team D1.
Okay, sir.
So team A 3 members, team B 3 members, team C 3 members, team D 2 members in one frame and 1 member in the second frame. Over to Dr. Shripad, sir. I think we all team members are here and we are on time, sir.
Yeah. Good morning, everyone. I welcome all of you to NAC 2021. In the middle of this wonderful airway conference organized by Jodhpur team and AIDA leadership under Dr. Sheila and Dr. Suma et al. We had a wonderful academic feast and again to this exciting quizmasters are Dr. Shankar Bhatt from KSAGDA Medical Academy, Nitya University, Mangalore. Then we have Dr. Rakesh Garg and Dr. Mrityunjay Kumar from AIMS, New Delhi. We also have 3 teams. Team A, please introduce yourself. Team A, please introduce yourself.
Good afternoon, sir. We are a team from AIMS Jodhpur.
Good afternoon, sir. I'm Dr. Dipanshu Dan from AIMS Jodhpur.
I'm Dr. Pallavi Sahu.
I'm Dr. Soumya Goyal.
Thank you, sir.
Welcome and good luck to you. Please, Team B.
Good afternoon, sir. We're from KSAGDA Medical Academy. I'm Dr. Apurva Manjunath.
Welcome to Team B and all the best. Now Team C will introduce themselves.
Good morning, sir. We are the team from PGM Chandigarh. I am Dr. Sendil. This is Dr. Revati and this is Dr. Rakul.
Good luck and welcome to Team C. Team D, please introduce yourself.
Good morning, sir. I'm Karen Selvin from SN Medical College, Jodhpur.
Good morning, sir. I am Ankit Vyas.
Good morning, sir. Myself, Dr. Shishwani Gaur from SN Medical College, Jodhpur.
Very well. All of you did excellently in the prelims beyond our expectations. They scored more than 80%, most of them. The questions were very difficult, and in fact, we were surprised that level of understanding is so good among the participants. Very good. Now the disclaimer, after I welcome everybody, including our quiz masters and the delegates and the esteemed faculty and the organizers. I like to say that we have not harmed any animals in the preparation of this quiz, but I can't say same thing about the human beings, because my quiz masters have worked beyond their duty hours and family hours. So thanks to all of my teammates, we are able to put up this quiz. And we have not done any videos or patient pictures. If at all, we have done with the consent of the patients. And then now I again welcome everybody, all the audience, to this exciting quiz. And I hand over the mic to Dr. Rakesh Garg for the beginning of the round 1. Before that, I have only one instruction to all the members of the teams, that team members please give only one response, and that first response will be considered as a response from the team. And when you are using the buzzer, if they are sitting separately, the first whoever buzzes the buzzer will be considered as the first response. If there is any second response, that may help the other team and may not help you directly. And so be careful. There are 5 rounds in total. First one is very simple option round. Second round is buzzer round. Dr. Mrityunjay Kumar will be doing that. And third round is crossword, and fourth round is match the following. I will do that. And finally, there will be rapid fire round by Dr. Murali Shankar. And each question will fetch 10 points in first 4 rounds and 5 points in the 5th round. Most of the rounds there are no negative points. So all the best. Maybe the best team win. Over to Dr. Rakesh.
Thank you so
All
much,
the
sir.
best, everyone.
So I think, is there some tachycardia and noradrenaline level surge in the participants? Yes, no?
So the buzzer link ended, sir.
Yeah, so buzzer link is already with you. So when you use it,
it has
the answer. And
it has ended. It is showing that the game code has ended.
Dr. Modi,
buzzer has to be put on. Sorry to interrupt. The buzzer has to be put on by myself. Now there is no need for buzzer. When the buzzer round comes, we'll do that. Thank you.
Okay, sir.
So I will request Dr. Murali Shankar to share the slides, please. So here we start, and all the best to all the teams, and welcome to the airway quiz by IDA at NAC 2021. All the decisions, whatever the questions are, they will be, the final answer will be as per the quiz master, will not be going into discussion. So quiz master decision is final and binding. Take it as a sportsmanship, right? And enjoy the quiz so that we have some wonderful cheering moments at the end of the show. So we have 5 rounds for this team, for this quiz. And these 5 rounds will be the choice round, the fastest first round, crossword round, match the following rounds, and the rapid fire round. As we move on with the different rounds, we'll show you the rules for each of the rounds. And the first round is the choice round. You can choose your question, right? In this, each team will get 2 questions. There will be 2 rounds of questions for each team. We'll give you 10 seconds to answer the question. If you answer it correctly, it will be 10 points. If you give wrong answer or do not answer, there will be no negative points for the same. The question will not be passed to the other teams. They will be given the next question as per the sequence that will just show you. So let's go to the team first, team A first, right? So we have 10 questions for you. You can choose your question.
6. 6.
Question number 6, please. So you have to identify the procedure.
Retrograde intubation.
Okay. Absolutely correct. It's a retrograde intubation. So 10 marks goes to team A. Let's have for team B now. You choose your question from 1 to 10, please. Those questions which has been answered, like 6, will not be given to you. So you can choose your one question from the pending one.
8, sir.
Question number 8. Identify the maneuver.
So 5. Stabilize.
So time is out. I think, want to have a guess, no?
Video laryngoscope
No, I
assisted.
think they answered before the time is over.
Yeah, so they will not get any marks.
Manual inline stabilization.
Right, it was a manual inline stabilization, which is usually used for a patient with actual or suspected cervical spine fracture when the patients come with trauma. So no marks for team B. Team C is ready?
Yes, sir.
Yeah, choose your question, please.
Question 4, sir.
Question 4, yeah. What does Patel test measures in airway examination?
Thyrometric distance. Thyrometric distance.
So you said thyrometric distance? Right. So you get the full marks. The correct answer is thyrometric distance itself. So congratulations, team C. Wonderful. And let's move to team D now. So please choose your questions.
Question 1, sir.
Okay, quiz master, show question number 1, please. Which is the first robotic intubation system? You need to name them.
Pentamax. Penta is AWX.
Sorry, can you repeat it?
Time up.
Okay, it's time up. So this robotic system was Kepler intubation system that was into the market for robotic intubation system. It's still under evaluation and has found some merit. So I think a wonderful attempt by all the questions. I think you all are enjoying it. So let's move to the second round. Are you ready? We can have thumbs up for all teams, you know, if you're ready. Are you enjoying it? Good. So we go to that round 2, and this time we'll start with team D first. So team D, it's your turn. Choose one question of your choice from the pending questions.
Question number 3, sir.
Yes, team master. Question number 3, please, for team D. In which year did All India Difficult Airway Association established? You are attending the national conference for the same. Team D.
1972, sir.
1972 is not the correct answer. The correct answer is 2010, where the All India Difficult Airway Association was established. So sorry for the correct reason. And I think we must appreciate that All India Difficult Airway Association is doing a wonderful thing. We have our own guidelines. We have our own official journal now, The Airway, and it is a wonderful organization. So please come and join and contribute towards IDA. So we move to team C now. Are you ready, team C?
Yes, sir.
Choose your question.
7, sir.
Quiz master, question 7, please, for team C. In airway blocks, which nerve can be blocked by depositing a local anesthetic agent posterior to the styloid process through peristyloid approach?
Glossopharyngeal nerve, sir.
Okay, so you said glossopharyngeal now? Yes, absolutely. Yes. It's the correct answer. Congratulations, team C. You get full marks, 10 marks. So let's move to team B. Team B, choose your question from the pending questions which are there in this round.
Sir, 5, sir.
Yeah, Team Master, question 5, please, for Team B. Where do you use Cook Blue Rhino? You can see this equipment. So it's time out. This is the procedure where we use this equipment, and the procedure is PCT, percutaneous dilatational tracheostomy. So this is one of the place where you dilate the tracheal opening. So Team B, you lost it. No worries. Just the first round, warm-up round. Team A, are you ready?
Yes, sir.
Choose your question, please.
Sir, question number 2.
Question number 2. Team, please show the question 2 for Team A, please. So where does O in Lemon scoring stands for?
Obese.
Obese.
Obesity.
Obese.
So he said obese. So the correct answer is obstruction. It's not obese. There could be many other reasons for it. And it has conditions like epiglottitis, the abscess, the trauma. So correct answer will be obstruction, not obesity per se. So you will not get the correct mark. So I think we have completed 2 rounds. Are you enjoying, teams? Are you enjoying?
Yes, sir.
So I think at this point of time, Dr. Shripad.
And at the end of round 1, I want to update the scores. Team A scored 10 points. Team B yet to open the account. Team C leading with the 20 points. And Team D also need to open their account.
So let's have cheer for Team C, who is leading the show right now. But it's just a start, so don't worry. We have so many rounds which are quite a good scoring. Dr. Shripad, can we give question number 10 for our audience now? With your permission.
Yes, question number 10 for.
So this goes to team, all the audiences. Please put up the answer into the chat or the question answer, and whosoever answer first will get a surprise gift. Bilateral firm digital pressure on the stylet process behind the posterior ramus of the mandible is called as. What is the maneuver?
Larson's maneuver.
Okay, so its correct answer is Larson's maneuver. It's a kind of Vigdas Jathas which is usually used for relieving the laryngospasm. So I think this is the end of round. Or do you want to have second question? Audiences, participants, do you want to have another question? Name the plant from which the arrow poison curare was extracted.
Cocaine.
Is it cocaine? Are you sure? Who answered it? So if we are not aware of the name, probably the answer or the award will goes to Dr. Mrityunjay then. So I think the quiz master will get the award. Mrityunjay, Shripad, and Murli will get the awards. So okay, so we end the first round here. And thank you so much. I think everybody is cheering. Can everybody just show your both thumbs if you're enjoying it? And I will request all the audiences be active. So you will have audience rounds in between, and there will be a surprise gift from the organizers who answers first. So thank you so much, and over to Dr. Shripad, please.
Yeah, meantime, I like to announce the prizes for the quiz winners. The first winners will get 3,000 rupees each. People from the team winning the quiz will get 3,000 rupees each, and the runners-up will get 2,000 rupees each. And so there is exciting prize in the waiting. All of you cheer up and get ready for next round.
So this
now,
means
all of you.
This means a grand prize of rupees 9,000 for the winner of today's quiz, and a grand prize of rupees 6,000 for the runner-up quiz today, isn't it, Dr. Shripad?
Yeah, that sounds like a bigger amount.
Now, please note down the code for. Please note down the code for the buzzer. Code is 998995. All the 4 teams, please note the code for buzzer 8895.
Sir, can you type it once?
You may please.
Sir, can you type in the chat also 8895?
Yes, one sec. Yeah, I have sent it in the chat box. And buzzer, please, players, buzzer check.
Sir, it says invalid code.
Okay. So, yeah. So what Team B has buzzed.
Sir, this is in just buzz.in.
Yes, buzzin.live. It's not a previous one.
So can you put it in the chat again, sir?
One team having a difficulty in logging in. Somebody has a problem with logging in, huh?
We are trying.
I'd like it 60 seconds. Yeah, Team D and Team C have buzzed. Team A is also buzzed. Yeah, all of the teams, all of you are buzzing very good. Great. Okay. So Dr. Mrityunjay can please start.
They have been buzzing around, sir, actually. So good afternoon, everyone. Welcome to the
Now
quiz
reset
show.
the buzzer.
I hope all of you are enjoying yourself. So this is a game that we are playing. So don't worry. Like it's all quiz is a game which depends on the ability, which depends on the matter of chance also. So don't just enjoy the game that you are part of. So these are the rules of the this round. We have 12 questions, and team which places the buzzer first will get the chance to speak first. And correct answer, if you get the correct answer that time, you get 10 points. If you end up saying wrong answer or not able to get the able to answer after pressing the buzzer, you'll be charged a penalty of 5 points. So be careful about that. And there is a no pass in this round. So question doesn't pass. I'll be just displaying you the answer after that. And there is a 10 seconds to answer the question. Is it clear? Any doubts? So all the best. May the force be with you. We'll start the first question. Okay. Where do you use Brodsky simple maneuver? So it's so since no team has taken up, so it's like it's used during it's a maneuver which has been designed by the Brodsky, who has done lots of work on the fiber optic bronchoscopy and double lumen tube insertion and obese difficult airway. And what it is, the method of insertion of a DLT without the help of a fiber optic bronchoscopy, where they go up to put the DLT where the maximum resistance is felt, and then the pressure manometer is connected to the to the cuff, the bronchial cuff, and according to the reduction in the pressure, they decide about the optimum placement of the DLT. So should we go to the next question, sir? So you have to identify this device.
Yeah, team B has pressed first. Team B.
Sir, ramp position, sir. We use that for ramp position.
Yeah, it is a ramp position, but we'll be needing an accurate answer. This is a tubes elevation pillow, which is used for making the ramp position in morbidly obese patient. So you are the person to take a call on that, whether they should be awarded a mark or not.
They get -5. We wanted name of the device.
Okay, sir. Okay. Thank you. So moving on to the next question. Next question, please.
Next question.
So we have to identify the device.
Team C. Team C has buzzed first.
And lung, sir.
Yeah, that's right. It's iron lung, and it is also called negative pressure ventilation, which was the earlier ventilator that was used, and it had played quite a big role in the polio epidemic that we had in old time. And mind you, there are still some indication of negative pressure ventilation left, and it is available for use. So should we go to the next question? So you have to identify this person who is considered to be the father of fiber optic bronchoscope.
Dr. Murphy.
Team D has the buzz.
Dr. Murphy.
That's strong answer. It's Dr. Shigeto Ikeda. He's a Japanese physician who has taken a cue from the gastroscope and developed a fiber optic bronchoscope, and we all know the use of it, which is increasing day in and day out, and it is a life-saving device for all of us. Next question, sir. So you have to name this device, which is an improved version of the combi tube. We want the name, and the name should be accurate. Please don't press the buzzer if you want to just guess it.
Nobody has pressed the buzzer. Time is over.
It is also called it's an improvised version of the combi tube called Easy Tube. It has got a better cuff seal, and of course the pressure seal that is created is far effective and causes less damage. So next question, sir. You have to name the ventilation technique which is used in this.
Team C has first. Team C.
Jet ventilation.
So yes, it is. I'll have to ask our experts, like other members, because it's an improvisation of the high frequency jet ventilation which was used, which has come, but it is a flow control ventilation as such, and which is connected to the tri catheter which is there, and the advantage of this ventilation technique is, along with that as we see in high flow frequency jet ventilation, there is an accumulation of air. There is no time to egress it actually adequately. So it takes a command over that, and there is a proper active. Yeah, we can give actually, sir. We can give it, sir. There is active expression happening here. So we'll be moving on to the next question. You have to identify this device. We want the name of the device.
Nobody has buzzed yet, though it is a very simple question.
So this question goes to
audiences. Yes.
No, anybody can answer. No points though.
It's Clover's chloroform apparatus. This is gentleman is Joseph Clover. He is an English physician, and he's the one person who is behind the suggestion of the jaw thrust, which we use actually day in and day out. He's the person responsible for it. Okay, and he devised the first portable chloroform delivery device, which is also called Clover's chloroform apparatus. So should we move to the next question, sir? So you have to identify this equipment.
Team C.
Bronchial blocker. Bronchial blockers.
Specifically.
That is.
Yes.
I was. Yeah. So it is an endobronchial blocker, but it is univent endobronchial blocker. So what to do, sir?
Bronchial blockers, we'll give it. It's a type of
Okay, sir.
bronchial blocker. We'll give it.
So this is team C.
So what happens here is it's a single lumen tube which we use. We can use in the difficult areas also, which we use during for the lung isolation. The patient is intubated with the single lumen tube, and we have inbuilt bronchial blocker which goes inside, and it can be manipulated through the end. And we can see this tube can rotate, and accordingly we can direct it to the left or right bronchus. And another advantage of this tube is we can keep it for the post-op ventilation.
Shripat, who was the team who answered this one?
Single lumen tube.
Team C.
If we require it at all.
Next question.
Okay. So this should be a simple one. Name the sign seen in the M mode during normal lung ultrasonography. All of us.
Team B.
Sir, seashore sign, sir.
Seashore sign, sir. Team B, no.
Team B.
Seashore sign, sir.
Yeah. Yeah, it is a seashore sign or sandy beach sign, which is seen normally during the lung ultrasound, and if in case of pneumothorax, this sign is altered to true. Okay. So next question, we have to identify the procedure which is happening with the help of this example.
Team D. D for Delhi.
Video still sir.
Sorry?
The use of a video still sir.
No, I'm
sorry.
This is
I'm afraid that is a. Yeah, I think Sarah has already displayed the answer. That was a wrong answer. Yeah, it's a lighted stillet, light band. I think
it's a wrong answer because it's not a video slitter. It's a light slit. There is no video into it.
It's light band. Video stillets are different and light band different. We had earlier a track light, which was a fantastic device earlier. Yesterday we had a beautiful demonstration of that. So this is not video stillet. Sorry.
Sorry, team. And we have to identify this equipment.
Team B.
Yes,
team B for Bombay.
Sir, video laryngoscope, sir.
I'm afraid that is there. That is a big thing actually. It's a total. Yeah, that's a wrong answer. It is a total track video laryngeal mask. So this is I think this is the answer to all the prayers for the difficult airway management that we have been waiting for. Okay, this has got an LMA design here. Okay, it is inserted like LMA, and it has got a port which is visual here. Through this we can insert the endotracheal tube. Okay, and what happens is like we can put a bigger tube here. Up to 7.5, 8.5 tube also can go inside this. It will come out through this. And and so can we go to the previous slide, please? Previous one, yes, sir.
And we are running out of time. Can you please little be faster?
Yes, sir. We have an oxygenation port and suction port here. So that is the advantage. These are the advantages of that. Okay, sir. We have to identify the equipment. Sir, next question, sir. So we have to identify the technique in which a 20 gauge cannula is attached here.
Team A.
The toxin bubble technique. Yeah, team
A.
Yeah, team A. Read the question.
Spray as you do.
It's called McKenzie technique. I'm sorry for that.
Okay.
So can we give it, sir?
Sorry.
This is the wrong answer.
Okay. We'll move on to the next question. It's over, I think. The rounds are over. This was the last question that we have, and so we can show the scores after this session.
Right. So we'll show the scores, sir. So after this interesting round, Dr. Shripat, can I announce the scores? So after this interesting round,
yeah.
So after this interesting round, we have Team C is leading. So 3 cheers for Team C with the highest score of 50. Team B has lost the points now to 0. Team A is 5 and Team D is -10. So we have more rounds with more scores. So all the best, all the cheers to all the teams. So we move on to the round 3 now.
So be careful with the buzzer round also next.
Okay, so now we are moving to third round. Round 3 is going to be a crossword round where we are going to have 6 crosswords, but each team will get only 1 crossword to answer. After seeing the theme, I will display the theme first. Then you can buzz the buzzer. You buzz the buzzer, and those who buzz the buzzer will get to answer. Each crossword has 5 options, and if you get all the 5 right, you will get 50 points. But once you buzz the buzzer, then you will not get one more chance. The chance will go to rest of the teams. So only 1 chance for the team. So if you never buzz for 6 questions, then you will not get a chance. So last team also need to press the buzzer after 3 teams do their answering. 15 seconds for each answer. Each correct answer will fetch you 10 points. No negative points. But look at the theme and decide whether you want to answer it or not, because you got only 1 chance. All right, so these are the themes: history, equipment, anatomy and physiology, algorithms, airway techniques, and extubation. The themes may not be exactly applicable, grossly they are yes. Are you ready? Shall we go ahead? Shall we go? Yes, this first theme is history. Who wants to take it? Nobody wants to take? Yes. Bravo Team A. Yes, your questions are here. So name the technician who helped Robert McIntosh develop a new curved blade in 1943, which is still popular. It's a very popular blade we still use. Yes, time is up.
Cycle.
Yes?
Cycle.
Sorry? That is Richard Salt. He was a OT technician with Robert McIntosh. On the basis of the direct laryngoscope blade, he developed our currently used McIntosh laryngoscope blade. Your next clue is who described the sniffing position as ideal for laryngoscopy for the first time. For the first time. Fourth letter is R. Any answer? Anyway, no negative points, you can guess. All right. That is Alfred Christian. It's a way long back in 1880. He said that sniffing position is very good for laryngoscopy. Your next clue is here. Who was the first practitioner anesthesiologist to appreciate difficult airway? And he carried a few essential equipment in his bag in very olden days, in 19th century. Any answer? Yes. Okay, your time is up. The answer is Joseph Clover. Already Dr. Mrityunjay was stressing on this name. Joseph Clover was a very successful practitioner who used a lot of chloroform, and he made his own chloroform equipment. Right? Yes. Your next clue is which body produced the first set of difficult airway guidelines? It has got 3 letters and it is an acronym.
In 1993, they came out with the guidelines.
DAS difficult.
Sorry, it is not DAS. Your guess was very close. It is American Society of Anesthesiologists 1993. They came out with the first set of guidelines, but they were very difficult to follow because lots of options were put together. But now we have very simple algorithms under the leadership of Dr. Sheila and Dr. Rakesh and many of our stalwarts. The last option, clue is, what is S-March maneuver? It has got 2 words, 3 letters and 6 letters. S-March maneuver, it is very popular.
People hold the mask. It's double. 2 people holding the mask for difficult mask operation.
No, sorry, it is much simpler than that. It is jaw thrust.
Jaw thrust.
It is much simpler than that. Thank you so much for the team here for this bold buzz. Though unfortunately you may not be able to do it, but your attempt was very good. Thank you. I don't think you got anything out of it, but anyway. Now the chances for the rest of the 3 teams. This round is about equipment. Who wants to take it?
Team C.
Team C, very good. Here are your clues. What does the letter
Brightness.
B stand for in
Brightness.
B mode USG? Yes?
Brightness.
Very good, excellent. That is right. It is a brightness. Okay, they get 10 points.
Yes.
Your next clue is, name the LMA with the traffic light system that enables continuous monitoring of cuff pressure during its use. 3 letters acronym and 9 letters answer.
Hey, this is the presenter, I think, so. Today.
All right. I think you have run out of your time. Better luck for the next clue. This is LMA protector. We heard a lot about in this conference about LMA protector. It has got 3 colored bands on its cuff, which indicates whether cuff pressure is maintained within limits or not. Your next clue is the technology used in cameras of video laryngoscopes. It is a 4-letter acronym.
Total internal cameras.
Sorry, that is not for cameras. That is for the optical fibers. And the correct answer is COMS. Composite oxide metal semiconductor, right? So it's a very wonderful technology which makes you very bright and clear images of the objects in front of you. All right, your next clue is, what is the problem of too large a suction catheter while doing suctioning through endotracheal tube?
Lack of ventilation, but then what is the word? Problem of a too large suction catheter.
You are suctioning through a large suction catheter.
Blood loss.
Sorry, you run out of your time. That is simple atelectasis. So don't use a big suction catheter. You are losing all the benefit you gained during PEEP and IPPV for last 24 to 48 hours. Your last clue is, jet ventilation is usually used during these kind of procedures. It is a
Laser.
laser, excellent. That is laser, and you get 20 points for that. I think with this,
They scored 20 in this.
in this round, you got 20 points. Very good. So now the clue for next to only 2 teams remaining. So about anatomy and physiology.
Press AR, press Team A can't.
Team A and team D can't.
Team A and Team C can't. Team
Who
D has
pressed?
pressed.
Huh?
Team D.
Team D has pressed. Okay. Answers. You please answer team D. Team D. This is the longer axis of the pharyngeal passage. 10-letter word. Team D, any answer? That is transverse. Okay. So your next clue is, at this level lies the commonest site of obstruction due to foreign body aspiration in upper airway. This is the level at which they have to name the organ at which level there is a commonest
obstruction due to foreign body aspiration.
Permit aspiration, yes. Any answer? Okay, we'll go to the answer. It is esophagus. Mostly the cricopharynx is where the foreign body gets stuck. That is the beginning of the esophagus. So next clue is position of vocal cords in bilateral vagus nerve palsy. In a bilateral vagus nerve palsy, what is the position of the vocal cords?
Cadaveric.
Excellent. You get 10 for that. It is a cadaveric position. Where the vocal cords are paramedian with the complete relaxation. The last clue for you is watchdog of respiratory tract. I think you get this. Watchdog of respiratory tract, quickly. Larynx, very good. It is a larynx which watches the lower respiratory tract and protects it. Very good, excellent. You got 20 points. Okay, very good. You got 20 points. Now there is one more clue, last clue for you. That is, what do you call the trachea when the tracheal cartilages are fused posteriorly? Normally they are not. If they are fused, what do you call them? 5 and 4 letter, 2 words. Okay, it may be difficult a little bit. So we'll give the answer. It is called stovepipe. Stovepipe. When it is fused, it lives permanently. Stenotic trachea and is a major procedure to correct it. Children will have severe stridor, respiratory distress, and they need a surgery to correct it. Okay. So there you get 20 points. And we'll move to last team. Team B. Team B. Team B you have 3 choices. You can choose anything. You can choose algorithm or any other 2. Are you there for this? Team B.
No, sir. Other 2, sir. No, sir.
No, okay. You are spoiled with the options. Okay, we'll quickly move because we are short of time. You can see the answers there. Okay, you want to take airway techniques? Do you?
Yes, sir.
Bus. Okay. Yes. Right. Your clues are here. This remains most popular induction agent during rapid sequence induction and intubation. 8-letter word.
Propofol.
Propofol, that's right. You get 10 for that. The next clue is this drug has maximum anti-synagogue effect.
I see.
Yes, loudly. You are running out of time. We'll go to that is scopolamine. Sorry for that. Your next clue is lack of this is an absolute contraindication for awake flexible scope intubation. This is a basic minimum requirement for performing prophylactic intubation. Time is up. Time is up. The answer is skill. If you don't know how to use it, don't use it. Very simple. Dr. Rakesh will watch for this. Your next clue is apneic oxygenation is also known as dash respiration. Morning, we are listening to apneic oxygenation.
Diffusion.
Diffusion. Yes, let us check. That is diffusion respiration. You get 10 for that. Very good. Well done. And there comes the last clue. This tests the mandibular protrusion. 4-letter acronym. Yes, we are done with the time. And the answer is upper lip bite test. ULBT is the correct answer. I thought you got it. So at the end of this round, Team B got 20 points. And Dr. Rakesh, can you please announce the positions?
Right, sir. So I think Team C is leading by 70 points. Cheers to Team C, followed by Team B, 20 points, Team D, 10 points, and Team A, 5 points. But cheer up, we have 2 more rounds, which are scoring rounds. So cheer up, and let's move to the next round.
Okay, we'll move to next round. All the best, all the participants. Though Team C is leading, you have still chance because we have 2 more rounds left. We can still make it. Right. Next round, we are going to. Okay, we'll skip this quickly. Don't think that you missed this. Anyway, no problem. It happens. And now we are entering the round 4. This is a very simple round. Match the following. We are going from team 1 to team 4 in that order. You will get 4 options on one side and 4 responses on other side. You have to match 1, 2, 3, 4 to A, B, C, D. And tell us within given time. Each correct match gets you 10 points. If all matches are correct, team gets 10 more as bonus. That means if you get all 4 correct, you get 50 points. Questions does not pass. 25 seconds to answer the question. Shall we go? Team A. I will give an example before that. Just see. Okay, we all about AIDA. Airway Guidelines Inception NAC.
Airway is the journal.
Anybody can answer.
Airway is the journal. Guidelines 2016. Inception 2010. Conference.
Very good. Excellent. So obviously NAC is the conference. What we are doing now. Very good. So now we'll go to. This is the answer. Right. We'll go to your next question. Question number 1 for you. Team A.
Lung ventilation, bronchopleural fistula. Total ventilation failure, cricothyrotomy. Gastroparesis, endotracheal intubation. Hello.
Yes, your time is over.
Sir,
you answered.
Yes, sir.
Sorry, you answered. Ventilation failure, cricothyrotomy, right?
Yes, sir.
One lung ventilation, bronchopleural fistula, right?
Yes, sir.
Endotracheal intubation, gastroparesis, right?
Yes, sir.
Yes,
sir, we answered. Yes,
Yes,
sir.
sir.
Yes, sir. We said.
I didn't hear.
Sir, we
But
answered.
anyway, as all above 3 are correct, 4th has to be. So I'll give you full.
Thank you, sir.
So we get 50. Okay, these are the answers. Very good. Well done. Well done, team A. Now question moves to team B. You get 25 seconds. Carefully think and answer. Laryngospasm, oxygen toxicity, pre-oxygenation, neuroleft anesthesia. Other side, absorption atelectasis, maximum reduction in FRC, negative pressure, pulmonary edema, retrosternal distress.
Laryngospasm, C, sir. Oxygen toxicity, A. Pre-oxygenation, B. And D is neurolect anesthesia is D.
Okay, time is over. You answered laryngospasm, negative pressure, pulmonary edema, correct? Oxygen toxicity, you said absorption atelectasis, wrong. Pre-oxygenation, you said maximum reduction in FRC, right? That is also wrong. Neuroleft anesthesia, retrosternal distress is wrong. Answers are, you got only 1 correct, you get 10 points. Laryngospasm, negative pressure, pulmonary edema, correct. Oxygen toxicity, retrosternal distress is the first manifestation. Pre-oxygenation causes absorption atelectasis, and neuroleft anesthesia activates expiratory muscle to the maximum tone, so it causes maximum reduction in the FRC. Very well. We'll go to team C. All the best, team C. So you have to match difficult airway in ICU, difficult mask ventilation, dental nomenclature, and video laryngoscope with the grades and scoring of hand, Makocha, Pogo, universal numbering system. Yes.
Sir, difficult video laryngoscope is Pogo, dental nomenclature is universal numbering system, difficult mask ventilation is Han, and difficult airway in ICU is Makocha.
Excellent. Excellent. Here are your answers. Difficult airway in ICU, Makocha, difficult mask is Han, dental nomenclature is universal numbering system, and video laryngoscope is Pogo. Excellent. You got 50 for that. Team C. One round of applause to team C. Now the last question to the last team, team D. All about symptoms and signs. Match the following: esophageal intubation, pulmonary edema, upper
Esophageal
airway obstruction.
intubation, double trachea, pulmonary edema, multiple B lines, vocal cord palsy, hoarseness, upper airway obstruction, proof sign.
Excellent, very good, very good. You did excellently. You got 50 for that. Excellent. You said esophageal intubation, double trachea, pulmonary edema, multiple B lines, and upper airway obstruction, proof sign, and vocal cord palsy is hoarseness, right? Proof sign is nothing but expiration through the partially closed lips to provide positive pressure during exhalation so that airway does not close. You see this sign most of the times in COPD patients. Well done, team D. Now, in this round, teams scored like this: team A 50, team B 30, 10, and team C 50, and team D 50. And over to Dr. Rakesh for the scores.
Wonderful. I think they have picked up in this round. So the team C leads by 120 marks, followed by team D with 60, team A with 55, and team B by 30. So cheer up. We have the last round, and which is a rapid fire round, a very scoring round, and you can pick up the points here as well. So moving to the last round, round 5, rapid fire round.
Okay. Here are the rules. There will be 10 questions in 1 minute time. Okay, 10 points for the correct response. No negative points if you tell the wrong answer. If the participants don't know the answer, just tell pass, so that next question will be asked. Because 1 minute to read the question only, I will take around 50 seconds. So if you take more time for answering, you will miss easier last few questions. So okay. So if you don't know, just you can tell pass. Okay. So team A, are you ready? Team A?
Yes, sir.
Yes, your mic is on. I am audible clearly?
Yes, sir.
Okay. So Rakesh sir, every right answer 10 marks. Okay.
No negative.
No negative marks. Yes. So I am going to start. Timer, Rakesh sir. I'll start the timer. Okay. So I am going to start the timer. Okay. The question going to come now. What is the level of vocal cord in normal adult?
C4, C5.
Wrong. Hearing brewer reflex is also called as?
Pass. Igel Mohammad Yasir.
Yes, very good. Non-enzymatic spontaneous degradation of cis heterocurium is called as? Yes, very good. Expand Ambu.
Artificial manual breathing unit.
Very good. What is the boiling point of desflurane?
23.
22.
Yes, I can give. What is Peary-Robbins sequence characterized by underdeveloped jaw, backward displacement of the tongue, upper airway obstruction? True or false?
True.
Right. LMA is made up of which material? Yes. Pressure applied over anterior neck during rapid sequence intubation is called as?
But
No.
Selleck's
Wrong.
maneuver. Selleck's maneuver.
No, I can't give you that.
Beer-Lambert's law.
No, your time is over. Only 9 questions we could cover. So you have answered 1, 2, 3, 4, 5, 6 right. They have answered 6 right, sir. So we will go to the answers. Oh, sorry. We won't go to the answer. I will just tell the answer. What you have not told is, what is the level of vocal cord in normal adult is C6. Hearing brewer reflex is also called as inflation reflex. And pressure applied over anterior neck in the rapid sequence intubation is Selleck's maneuver. The principle does pulse oximetry use is Beer-Lambert's law. Okay. So they have answered 6. So team B, are you ready? Team B.
Yes, sir.
Yeah, team B. Your questions will start now. The depression between the root of the tongue and epiglottis is called as?
Vallicular.
Yes, right. Head's reflex is also called as.
Passive.
Who designed the first video laryngoscope?
Passive.
Remifentanil is metabolized by.
Plasma esterase.
Yes, very good. Expand SLIPA.
Passive.
What is the boiling point of isoflurane?
Hot. 22.
Wrong. Macrognathia is common in Treacher-Collins syndrome. True or false?
Treacher. False. False.
Yes. Partial Syracuse fiber optic intubation airway is made up of which material? Okay, your time up.
The ninth.
It is aluminum. Okay, so you have not answered the head's reflex. It is also called as paradoxical reflex. The first video laryngoscopy by Dr. John Pacey. He invented a glide scope. Expand SLIPA. It is also called as streamlined liner of the pharynx airway. The boiling point of isoflurane is 48.5 degrees centigrades. Partial Syracuse fiber optic intubation airway is made up of which material? That is aluminum. What is the name of the maneuver in which LMA is placed to facilitate endotracheal extubation? Is Bayliss maneuver, which is the principle which explains the flow of gases and the resistance in endotracheal tube is Hagen-Page flow. So they have answered only 3, sir. Pakish sir, they have answered right 3. Yeah. So team C, are you ready?
Yes, sir.
Yeah. What is the length of trachea in adult?
15 centimeter.
Wrong. Pulmonary toxicity caused by oxygen therapy is called as?
Oxidative stress. Who designed LMA brain? Succinyl choline is metabolized by pseudocholine.
Yes.
Expand RAE, ring alder.
Yes. Yes. Sixth question. What is the boiling point of nitrous oxide?
Minus 70.
Wrong. Apnea hypopnea index of more than 5 per hour considered as pass. Endotracheal tube is made up of which material?
PVC.
Yes. What is the maneuver which used to increase the success
Shandy's
of
maneuver. Physical
yes.
principles is used
Right. Which physics principle is
used?
used? Yes, right. Okay. So you have not answered the first one. What is the length of trachea in adult? That is 10 to 11 centimeter. Pulmonary toxicity, it is called as Lawrence-Smith effect. What is the boiling point of nitrous oxide? Minus 88. Apnea hypopnea index, that answer is false. Rest everything you have answered.
Sir, we said false, sir.
You said false. I didn't hear.
Achha.
It's okay, man. Anyhow, you are leading now. 10 point में क्या फर्क पड़ता है? छोड़ दो. So we will go to team D. Are you ready?
Yes, sir.
Yes, sir.
Sir, they have answered 3, 6. Okay, team C, total 6 right, sir. Okay. So team D, are you ready?
They said false, so we can give it 7 correct answers.
Okay, sir. Okay. So team D, are you ready?
Yes, sir.
Yeah. So team D, your time starts now. Which is the main bronchus, which is wider and shorter? Yes.
Right.
CNS toxicity caused by oxygen therapy is called as?
Metabolite of halogen, which is
Wrong. Who designed the first cuffed tube?
First cuff.
the fifth answer is
Randall
Renderson.
Baker Susek.
Wrong. Fourth one. Name the metabolite.
Of halogen, which is hepatotoxic. So the fifth question, Randall Baker Susek mask.
Yeah. Okay. What, sixth question.
Pass. Next question.
What is the boiling point of sevoflurane?
Sir, 58.
Yeah, I can give. Klippel-Feil syndrome is a bone disorder characterized by abnormal joining of two or more vertebrae. True or false?
True, sir.
Yeah. Eye gel is made up of which material?
Thermoreactive polymer, sir.
Yeah. Name the maneuver in which thyroid cartilage is displaced by applying pressure over the neck. Wrong. Your times are. That is burp maneuver, but your times are. Yeah. So the questions you didn't answer was CNS toxicity caused by oxygen therapy is Walbert effect. Who designed the first cuffed endotracheal tube is Frederick Trendelenburg. Name the metabolite of halothane, which is hepatotoxic, is trifluoroacetyl metabolite, TFA. Okay, then you didn't answer. Yeah, burp maneuver answered, but before that you told Sellick's maneuver, so I can't give. So which physics principle applies in Venturi devices? That is Bernoulli's theorem. So these people have answered 1, 2, 3, 4, 5 correct, sir.
Yes.
5 correct.
Oh, wonderful.
So actually, there was some problem in PPT. Actually, when I pressed answer, this one was not coming, and that's why. Yeah. So Rakesh sir. So
absolutely, I think it's a wonderful show, and Dr. Shripad, Dr. Murli Shankar, Dr. Mrityunjay did a wonderful job. And the final score, the winner will be announced by Dr. Shripad, Dr. Mrityunjay, and Murli Shankar. The scores are the team C led by the highest score of 190, followed by team A with a final score of 115, with team D with 110, and team B with 60 points. So the final score, Dr. Shripad, to announce the winner and the runner-up. So I think you must have all have enjoyed the today's virtual quiz, isn't it? All the team winners, teams, in fact. Dr. Shripad.
Yes. Thank you everyone for the wonderful participation. All the teams have done wonderfully good. Though always somebody has to win, and everybody can't win, right?
team C highest.
At the outset, I like to before we close, I want to thank all organizers, Dr. Rakesh, Dr. Sheila, and organizing chairperson, everybody, for this wonderful opportunity to be hosting the quiz, and the participants and the audience, and especially my quiz masters, and also my better half, Dr. Kulkarni, for preparing the part of the quiz. It was a wonderful experience doing quiz with you people. Now the final points tally stands like this. Team D has scored 60 points. They did wonderfully well in the end. And team B scored 110 points. They also caught up a bit late, but they did catch up. And if they put a little more effort, they could have scored better. 150. Team A has scored 150 points. They did extremely well towards the end. And team C led from the front and scored 190 points. So the runners up are team A with 150 points, and team C has won the quiz with the big margin, that is 190 points. Congratulations, team A and team C. Team A.
Team A is Revati Sendil.
Team A is
Team A is
Team A is Dipanshu and others, and Team C is Revati and others. So congratulations to the winners, and well done all the finalists. And you get rupees 3,000 per head. That is 9,000 rupees for Team C, and rupees 6,000 rupees for team A. Congratulations again. You will be given Amazon gift vouchers by the organizers of the conference. Again, I thank the organizers and all the participants and quiz masters and audience. Thanks everyone. Thanks Shekhar and his team for giving this beautiful stage to host the conference and the quiz. Thank you very much. Thanks one and all. Again, take the names of Dr. Rakesh, Dr. Murali, Dr. Mrityunjay for helping me to put up this quiz. Thank you so much. And bye everyone.
Thank you everyone.
Thank you.
Well done.
Thank you.
And all of you are a winner already since you have come to this stage and you have participated in the quiz and you have played a very fair and nice game. So congratulations.
So thank you so much, and do join us in the validatory function today evening for the final announcement of the results, please. So do join in the validatory function today evening.
15 minutes again.
So thank you so much, and over to organizers for next session, please. Thank you.
Thank you so much, sir. Thank you.
Thank you,
Thank
sir.
you.
Oh, check.
Good afternoon all. After this amazing quiz session, let's move on to our next session, which is adult case discussion. I would like to welcome our chairpersons, respected Dr. J.V. Divatia, Professor and Head Department of Anesthesia, Critical Care and Pain, Tata Memorial Hospital, Mumbai, and Dr. Govind Raj Bhatt, Assistant Professor, Department of Anesthesiology and Critical Care, KS Hegde Medical Academy, Mangalore. Over to you, respected chairpersons.
Yeah, good afternoon.
Good afternoon, everybody.
Good afternoon. So thank you for joining us. And this is the case discussion session where so we'll put up adult cases, adult difficult airway cases. So what we'll do is we've got a series of cases. We'll flash a picture and then we will put up options for the audience. So the audience can type in their options on the chat, and and while your responses come through, we will have the expert panel give their comments on how they would handle that case. Right. So I am Dr. J.V. Divatia from Tata Memorial Hospital, Mumbai. I'm moderating this session along with Dr. Govind Raj Bhatt, who is Associate Professor at Shema in Mangalore. He's also the current treasurer of the All India Difficult Airway Association. And our expert panelists are Dr. Namrata Ranganath, who's a very renowned onco anesthetist at Kidwai Memorial Hospital in Bangalore, Dr. Manpreet Singh, who's Professor of Anesthesia at Government Medical College, Chandigarh, Professor Bindu Sen, who's Professor at PGI Chandigarh. Dr. Sohan Solanki is also my colleague, Associate Professor at Tata Memorial Hospital in Mumbai. And we also should have Dr. Manoj Kamal. Is Dr. Manoj Kamal there? Associate Professor at, Additional Professor at AIIMS Jodhpur, and our host, one of the hosts of this meeting. Unfortunately, Dr. Naveen Malhotra and Dr. Sarvari Swaika could not join us, but we'll carry on with this excellent panel anyway. Okay. So let's start off, and I'm going to put up the first picture. Okay. So this is a patient who's for cancer of the tongue, who's for a commando. He's, as you can see, he's got this big ulceroproliferative growth on the right lateral border of the tongue, which is crossing the midline, going on towards the floor of the mouth. He's got ankyloglossia, and mouth opening is actually quite good. It's more than 3 fingers. So what would be your approach to this patient? So these are the options for you. Delegates, you can type in your option on the chat. So we'll wait for about 15 seconds for you to type in your responses, and then we'll throw it open to the panel. So, okay, so no one is yet typing on the panel. So maybe I'll just quickly move on to Dr. Namrata. You're the onco anesthetist. So tell me, how will you go out? What will be your approach to this patient?
Hello, Dr. Namrata, madam.
So my first choice will be awake fiber optic, and my plan B will be tracheostomy.
Okay, so any reason why the mouth opening is quite good? So why do you want to do a fiber optic intubation in this patient?
Yes, sir. So for any other intubation, if I'm doing awake video laryngoscopy or inhalational induction or IV induction, I have to use a laryngoscope. And then it's a right side of the tongue, huge mass, proliferative mass, which with the touch can bleed. So that is the reason I would not, even if it was on the left side and it was a smaller lesion, probably I would have gone ahead with the other. But in this particular case, definitely I would like to go for fiber optic.
I think Dr. Namrata made a very, very important point. So this is a big lesion on the right border of the tongue, which would come in your laryngoscope blade, and there could be risk of bleeding. And a lot of people say, oh, mouth opening is fine, so I'll be able to put in a laryngoscope and do a intubation. But like Dr. Namrata pointed out, it could bleed, you could land up in a problem. And there are a couple of other red flags. It's crossing the mid, it's going towards the floor of the mouth, floor of the tongue. So, your laryngoscope blade may not even reach the base of the tongue, and ankylosglossia is present, which means the tongue is fixed and you may not be able to move it. So red flags, big tumor, and Dr. Namrata has given awake fiber optic as the first option, which is fantastic. And the next option is tracheostomy, so which I think both are the safest and best techniques that we can use. And so I think, thank you, Dr. Namrata, for those two very important lessons regarding large tumors of the tongue, especially those which are going towards the base of the tongue and, where there's ankylosglossia and so on. Okay. So any other queries from comments from any of the other panelists?
Sir, Dr. Manpreet here.
Yes, Manpreet.
Yeah. The approach by Dr. Namrata is very right. And but another thing I can add on is, yes, I will also prefer with the awake fiber optic. And but since it is a panel discussion, so we should have other alternatives also. So we should discuss that. I thought that if the growth is basically, if somehow, since the mouth opening is 3 fingers, if somehow we could insert the video laryngoscope blade like C blade or CMAC D blade, then somehow, not till the epiglottic fold or like that, just to have a view of the internal area, then we can also add on with the combination technique of video laryngoscope view and fiber optic. So this combination technique of two different techniques with both together can also be a good alternative to prevent the bleeding, because once the bleeding gets started, then even fiber optic alone will not work. So awake fiber optic is okay, but if we get the view with the video laryngoscope awake, then we can do also use the video laryngoscope as just to view that area. Secondly, we have to prepare all the other things of difficult airway caught also. Is somehow, if we get caught in area bleeding or something like that, then we have to change our technique also. The tracheostomy is the last choice, which is always can be used as a second choice here. It's the plan B.
Okay, so Dr. Namrata and maybe Dr. Sohan, would you want to say anything about doing a video laryngoscope, a combined video laryngoscope and fiber optic technique?
Yeah, sir. So if we use VL in this case, and even just for the checking, but if we end up having bleeding during incision of the bleeding, and this since this tumor is going up to the floor of mouth, so I don't think we'll be able to put video laryngoscope as far as we want to put. But the awake FOB is, I think, always the first choice, and I don't want to put this VL, because if we end up having bleeding, then we may not be proceeded with the FOB also.
Yeah, Dr. Namrata, your hand up.
Yes, sir. So what Dr. Manpreet is talking about, the hybrid technique that we will utilize only for cases when we want to see through, when we don't want to do blind pushing of the tube through the fiber optic. Here anyway, we are bypassing, when we are doing fiber optic, we are bypassing the lesion any which way. So we will not require the hybrid technique. And the concern with putting video laryngoscope, the bleeding is very high because you'll be doing in awake. If it's a paralyzed patient, you could have been little gentle, but here anyway, what I think Dr. Manpreet is talking about is awake video laryngoscopy, right, Dr. Manpreet?
Yeah, actually, I am just talking about the gentle video laryngoscopy, and it is just insertion of the blade, not with the force.
So
And
it was not
sometimes,
an ulcer-proliferative growth we could have thought of, Dr. Manpreet, but just because it's an ulcer-proliferative, I think we should be a little careful in using here.
So I think that video laryngoscope, a hybrid technique like Dr. Manpreet was suggesting, works well if you want to see where your tube is going over, how your tube is going over the fibroscope. But again, like Dr. Sohan pointed out and Dr. Namrata was suggesting, that in this sort of patient, where there's a large tumor which can bleed, maybe the hybrid technique may not be the initial choice, and maybe in some other case, it's a reasonable sort of choice. So I think we'll go with.
I think Indu Madam has something to say.
Yeah, Indu Madam. Yes, Dr. Sen.
Yeah, good afternoon, sir. I agree with Dr. Namrata that awake fiber optic is fine. If an ultrasound is available, I like to do the, mark the site and have a look at the neck also. There may be like lymph nodes may be there. So we need to mark the tracheostomy area.
Okay, so I think that's another good point, that if you might even want to mark the site for emergency neck access, whether it's a tracheostomy or the cricothyroid membrane or something, so locate it in advance before you go ahead with any of these sort of techniques.
So for that, sir, when we had given blocks, we can leave the cannula if we really want to, if you're giving intratracheal. So I think how ma'am said, we can put ultrasound guided and just leave it there after doing the block.
But then you'll have to put a nice 16 gauge cannula for your cricothyroid, for your transtracheal injection. Otherwise, the small needle that you use to instill local will not be good enough for as a transtracheal, as a cricothyroid airway, right?
We'll go to second.
Okay, so I think I think we'll move on to the next case. So I think we'll agree that for this patient, awake fiber optic would be the best situation. If you are not able to do awake fiber optic, then tracheostomy would be a sort of safest option in this sort of case. Yeah, and while there is a role for hybrid video laryngoscopy and fiber optic intubation techniques, in this particular case, because of the high risk of bleeding from the tumor and tumor reaching the base of the tongue, it might not be a good idea. And it's a good idea to mark your site and access for neck rescue if at all it is required, right? Okay, Dr. Govindraj, can we move on to the next case?
Absolutely, sir. We can move on to the next case. So I hope everybody can see the picture. We have a 45-year-old male with retropharyngeal abscess with cellulitis, usually a commonest case in the emergency department, with cellulitis of the neck extending to the anterior chest wall. So his examination says mouth opening more than 3 fingers. So we would like to know how would you go about managing the airway of this particular case. So we'll just wait in the chat box for our audience to take part. Whether your plan would be IV induction plus relaxant, awake fiber optic, inhalational induction, or you have another plan. Audience, let's make this interactive so that and then we'll go to the panelists.
So I think the audience is out at lunch or they are taking an afternoon siesta.
So I'll just move on to Dr. Manpreet. So if you could take this case, how would you go about it? How would you prepare the patient and go about, and why not the other techniques?
First of all, if I go with that, this patient is that was the consent and all those things which are essential. And
Absolutely.
psychological preparation of the patient is very important in this. If I plan for any awake intubation, and then because we need the patient's cooperation in whole of the intubation time. And then since the retropharyngeal abscess is very large, so our induction agents are also very important in this type of patients, because patient may be in septicemia, patient may be in having a high pulse rate, or the patient may be having the tachycardias and and then the patient needs a quick intubation, and then the patient needs a rapid sequence intubations type also, because we can't take much time in doing these, getting away with the intubation time. So I'll go there. Another one is a IV induction plus relaxant, because the important thing is that what I can see from this picture is difficult mask ventilation is not there much, because the patient's oral openings and nasal opening is okay. 3 centimeter, 3 fingers is the mouth opening. So this means the mouth opening is okay, and then difficult mask ventilation is may not be there, or because the right part is not visible in this picture. Secondly, the difficult laryngoscopy may be not there, what I can judge from this picture, because it is on the lower side only, in the neck and the upper chest, and there can be difficult intubation in this, which is when we lift the area there and we do the laryngoscopy. At that time there can be the difficulty, and rescue I can put the laryngeal mask airway if the pharyngeal abscess is not going inside, only as a rescue, not otherwise. And I can do the video awake fiber optic is the safest choice, one thing, because the trachea, how much is deviated is not mentioned in this. So maybe deviated, maybe not deviated, but even then the awake fiber optic with all the preparations pre-operatively, then that can be the best choice. Secondly, if the laryngoscopy is easy while doing that, I can see that then I can use the hybrid technique in this also, because it gives a better view inside, and gentle with that, with IV induction, and relaxant can be used as a short acting relaxant, like we have the Scolin.
Dr. Manpreet, if I can interrupt you.
Yeah.
What is your first choice in this? You mentioned
I'll be going be awake fiber optic, and if that will be my first and safest choice.
Okay, so awake fiber optic, right? Okay. Dr. Manoj, any opinion on this?
Sir, in this patient, my plan is also awake fiber optic. First plan is awake fiber optic, because sometimes there is distortion of the trachea and compression of the surrounding structure also. So we might get distorted anatomy in the neck or in the upper part of thorax. So I want to check this because mouth opening is good, 3 finger. So we are not expecting problem in the upper airway, but we might get problem in the neck. So my plan is also awake fiber optic in this patient.
Okay, awake fiber optic, I think we should take it. But would anybody like to, if mask ventilation is adequate, and would anybody like to do a gentle laryngoscopy and check?
Yeah, then another option is this, which I was.
Or you would not risk it?
No, we can do with the deepening with the inhalational agent. We can do after deepening, we can do a gentle single laryngoscopy with the most experienced person there, and then we can see whether we will be able to put the see the larynx or not, and then we can go with the further plan.
Dr. Sen, what are the dangers of giving anesthesia or doing a laryngoscopy? Are there any dangers that you foresee, and why are the experts suggesting an awake fiber optic intubation in this situation? Dr. Indu Sen?
Yeah. Can you say it again, sir? Sorry, I heard sing. I thought question.
No, sorry.
Yeah.
So
yeah.
no. Why are the experts suggesting awake fiber optic? What are the dangers of inducing anesthesia or doing a laryngoscopy or something in this situation?
Yeah, these are the conditions where the compromised airway is there, and if we give a relaxant, we might lose the airway. So we have to have a plan A, B, and C, and take a detailed history also, whether the patient, what happens when the patient lies down, is there any stridor, is there any difficulty, how much is the difficulty in breathing, and whether the patient is able to swallow or not. So we need to we don't want to lose the airway before we start inducing.
So you're also in favor of an awake technique?
Yes, awake technique, but in the controlled environment, I like to mark the area. We have ultrasound, we'll scan the area, have a backup available, like ENT person, if it is there. Definitely, they are going to drain the abscess. So they should also be ready. Because we should not wait time in the planning at that time.
Dr. Namrata?
So, I would go, before attempting intubation, I would like to see the imaging first. And then that would help me plan it better. So like if, and the way you have marked the chest area, are you thinking of that the abscess is so big that it can, compress the area below?
Yeah, so this is something like a Ludwig's angina, isn't it? It's going all the way down to...
So definitely if it's an elective case, we should have some imaging. So rather than thinking about what is happening, if we know before only how much is the lumen, how much is the trachea compressed, and what is the, flow of the, things would be better. Awake is definitely the safest. But if you don't have a fiber optic and you need to do something else, then I think you should plan it before.
Okay, so let's say you don't have a fiber optic. What's your option?
Then my option will be, sir, to do a chexoscopy. But then also I'm not sure if I'm putting the tube in the vocal cords, is the compression beyond much more? So, but definitely that would be the only.
So chexoscopy.
If you have, sorry, yeah, go ahead.
Chexoscopy in the awake patient, or with a little bit of induction with propofol, a little bit of SIVO, or what?
So, so if mask ventilation is good, I prefer chexoscopy with propofol. And
So, look at his face. He's got this big swelling under the chin, right? And under the jaw.
So a gentle awake scopy can give them some idea.
Well, as regards mask ventilation, if you look at this swelling over here.
So holding the mask will be a little difficult.
Yeah, it doesn't look very encouraging as far as mask holding is concerned.
So a gentle awake scopy. Because if we can't give him a gargle or give him a spray and then just do a gentle scopy and see, when we are talking about there's no fiber optic.
Yeah.
And
Dr. Indu Sen had something to say over here.
I trust.
So like attaching the nasal prongs, and if thrive is available, we can start giving oxygen supplementation should be there.
Yeah, I guess that's a great point that we should do in all difficult cases. We should be supplementing oxygen throughout the intubation sequence, whatever we are doing. Dr. Sohan?
Any comments?
Yes, sir. So I agreed with Dr. Namrata. I also want to see any CT scan or MRI done beforehand, because I can have an idea, good idea of like how the airway is beyond the vocal cord. So, and the scopy is not a good idea, because I end up having a problem inside the oral cavity, or I may rupture something. So an awake FOB, but I want to see the imaging before and for that case.
Okay. So
absolutely, I think awake FOB is the way ahead in this particular case, and sometimes even check laryngoscopy may rupture at times. And you may see or even smell foul smelling smell, and then you may see some yellowish discharge there, and then you'll end up in a big soup, I guess.
But so what is the choice if there's no fiber optic?
Then I think we can have a gentle video laryngoscope. I think if I have, I will just go with I may not be going too far into the oral cavity. I can just have a gentle video laryngoscopy if I don't have a FOB, maybe.
So Swan, in a setting where you don't have a FOB, you may not even have a video laryngoscope.
Then laryngoscopes are available. Now most of the hospitals, they have it.
Yeah, one thing what we need to remember, and somebody pointed it out, at all times you have to administer oxygen via nasal prongs or at 15 liters at least, and so that you can buy time.
Sometimes, if I can add one thing more.
Please, sir.
Sometimes what happens, we can use if the other side is okay, like it is going through one side and the upper part of the chest towards one side, the abscess, then I maybe, if you have retromolar scope, that can also work from the other side. Sometimes it happens that with the retromolar scope is also a good gadget, because it doesn't need much of the mouth openings, but here the mouth opening is very good. Secondly, we can use with the gentle laryngoscopy, and we can put the retromolar scope along with that also. It is just to add and complete.
Okay, so I think again awake intubation
is a good choice.
Way to go for this one. I think everyone's agreed on that bit, and then there are variations in what others would do. Okay. Okay. Go
Absolutely, sir. Yeah, we can go to the next case, if it's okay. Panelists. Yeah.
Anyone from the audience can please put in their comments in the chat. We'd welcome your comments or whatever in the chat. Okay, Govind, carry on.
Yeah, we'll go to the next case, sir. Okay, third one. Here we have a 32-year-old female who came to a casualty with alleged history of hot water falling on her, sustaining burn injuries over her face, neck, and chest and upper arm. The patient is conscious, oriented, and complains of difficulty in breathing. So her stats show a pulse rate of 130 beats per minute, a blood pressure of 100 by 60 mm of mercury, room air saturation of 90%, a BMI is 30. So in a casualty scenario, how would you go about handling this particular emergency? So first we'll give it to the audience, and then our panelists can take over. So she's got clear-cut complaint of difficulty in breathing. So we have the picture here. Audience. Okay, there is no response. So if Dr. Manoj, if you can take this case, how would you go about and explain? Generally, the postgraduates attend these calls, and what are they supposed to do? If you can just enlighten.
Because this is a burn patient, and as per look of the patient, the neck is very short, and there is huge swelling overall face, and patient blood pressure is also in lower range, 100 by 60. So in this, I am expecting there is distorted anatomy inside of the oral cavity and neck. So, and blood pressure is also low. So I don't want to use any anesthetic agent, or I don't want to use the supraglottic airway, because I am expecting that burn injury can cause the vocal cord edema. So I want to secure the airway with the endotracheal tube in this patient, and I want to use awake fiber optic again in this patient.
In casualty scenario?
Actually,
she is conscious, oriented,
but
and just complaining
short
difficulty.
And complain of respiratory distress. So I am expecting there is edema in the oral cavity structure on vocal cord. I can put supraglottic, but over a time edema will increase. So I want to secure airway in this patient with the endotracheal tube only.
Couple of audience, I think they just had their yummy lunch, so they have back and they're in full swing. So somebody is like chance of airway edema, deviation of trachea. So awake fiber optic is better, or video laryngoscope. and also somebody video laryngoscope is also better. So awake fiber optic and IV sedation. So any comments from the panelists? Anybody can take this in casualty scenario. So Dr. Sohan, yeah, please.
Yeah, so actually this case is a burn patient. So I will expect this edema of the airway, and you can see that this SpO2 on room air is 90%. So I don't think, although we can do this awake FOB in this patient, but again, I think that doing awake FOB, one problem is that we may not get in a casualty setting, and also that while putting this FOB, patient may further deteriorate. It can go, the SpO2 can further go down. So I can also do I will plan to do awake video laryngoscope with some local some installation or implantation, or otherwise I will go for an awake tracheostomy in this case.
Okay, so I just have a quick question for any of the panelists. Why do we want to secure the airway in this patient? I mean, it's because we are just why can't we just give oxygen for this patient if the SpO2 is low?
So this is an acute burn case, and here the resuscitation as well as the management has to go hand in hand. That is the first point. We should not waste time in securing the airway. Rather, the fluid management is equally important. Oxygen supplementation is important. But yes, we have to secure the definitive airway early because of the soot, carbon monoxide, inhalation, there will be damage to the airway, and it is going to worsen with time. So we have to secure it as early as possible, but not that we have to rush through it.
So I think that's a great point Dr. Indu Sen made, and I think if we heard Dr. Sandeep Sahu's lecture yesterday on airway in acute burns, this patient obviously has facial burns, and there is edema to the outside of the airway. I'm sure there's edema inside the airway.
Inside also.
She's got thermal injury to the upper airway and trachea. So her airway needs to be secured before things actually start deteriorating. So we need to do it sooner rather than later. And that is why we are discussing how we are going to go about securing this airway in the emergency department itself, rather than wait for some X number of hours or whatever it may be. Yeah. Okay. So, and you can see there's a lot of edema and on the neck and on the face, and the lips are swollen, and she's in pretty bad shape. So Sohan was suggesting awake fiber optic or tracheostomy, right? In the awake situation.
And so also that awake video laryngoscopy can be done with some local installation, because again with the doing this FOB in this case with the SpO2 of 90%, I don't know, patient may deteriorate while doing the FOB. I don't know.
He might deteriorate doing a video laryngoscopy also.
I doubt in this case that whenever these cases come into the emergency, and since now at this moment the patient is having tachycardia and borderline blood pressures, and SpO2 is just 90%, so anyway this patient will deteriorate within few minutes or few minutes, I can say. And yes, we have to maintain the airway, but I think the para-oxygenation can be done side by side. Then first we have to build up the oxygen side by side. We have to plan for plan A, plan B, plan C. There is some amount of time to intubate. So like 5-7 minutes we can do that, and then in our presence we can go with the quick laryngoscopy and intubation, which usually people do in the emergencies in the residents, because these burns patient, there is no availability of awake fiber optic. Even the awake fiber optic at that place is not available. Fiber optic is not available usually, and in the expert hands, usually the experts do not go to handle these cases in casualty in the reality. Because postgraduates are also listening to this, we have to be more.
Manpreet,
yeah,
you cannot slip out of this. You know, what has happened is that the emergency medicine resident has recognized this as a difficult airway and he's called you to help.
I want to add one thing, that is cricothyroidotomy can we have to be prepared for cricothyroidotomy here also, because suppose we get that.
Have a look at her neck. So,
no, but tracheostomy will be done later on also, no? So maybe we have to build the plan B also. What is our plan B then?
Okay, but what is the plan A? Plan A is like Dr. Indu Sen, and you are also suggesting oxygen and fluids to get the patient a little stable. But as far as the airway is concerned, what is the first plan and what is the next plan?
Intubation with relaxant.
Intubation, I'll go with the intubation first plan, and then in emergency, if the saturation falls immediately and I do not get the time, then I have to search for open the next access.
Okay, so now we are getting into a good space over here.
Namrata madam had to say something.
Sohan has suggested, and Manoj and Sohan have suggested awake fiber optic. Dr. Manpreet is talking of a plan B. Dr. Indu Sen is saying intubation relaxant. So you're talking of a regular induction, rapid sequence induction or induction relaxant, right? Dr. Indu Sen?
Yes, sir.
Okay, so
my idea, I've not seen from 25 years any burn patient, but what I'm saying is, if it's an emergency, it should be normal intubation. If failed normal intubation, first you head up, you give oxygenation, prepare the patient, as Manpreet said. Do try first intubation. If not, then do tracheostomy.
Okay, so Dr. Indu Sen, how would you go about doing this intubation?
So actually in burns, we know that depolarizing muscle relaxants are contraindicated, but in the initial 5-6 hours, they can be administered, though there's a controversy about it. But I like to intubate with the relaxant because I want my attempt to be successful. And will like to avoid tracheostomy as far as possible because a lot of infection, they are prone to infections. So it's better to do the endotracheal intubation. And gradually the edema will settle down and she should be fine.
So what would be an induction agent in this patient, given that she's probably very hypovolemic, she's tachycardic, the blood pressure is on the lower side?
So I assume that we have already secured an IV access and fluid is going on.
Right.
So as I said that if it's a real acute burn within for 2-3 hours, succinylcholine can be administered.
And the induction agent?
Induction agent will be thiopentone if it is available, or ketamine.
Or ketamine. Okay. So give oxygen first, try and get the oxygen up. Would you want to consider something like a nasal cannula or high flow nasal cannula if available?
Yes, sir. That should be there in all the cases, like para-oxygenation. As Manpreet said, that we should have oxygen going on at all the time.
Okay, Sohan, would you be very upset with what Dr. Indu Sen said? You said awake fiber optic and she's saying give a muscle relaxant.
No, sir. I don't want to give this muscle relaxant in this patient because there is a edema and I may not be able to put the FOB or whatever. And I don't know because until I see the opening and then I don't, maybe.
We can see with the patient's cooperation also at this moment. Whether how much patient is cooperative for awake fiber optic. That is another point.
I think we'll just make things worse for Dr. Sohan. So if you can just move the slide, sir.
Okay, Dr. Manoj, any opinion on this? You've been very quiet.
Sir, actually, right now I can see that patient is not needing urgent intubation. So simultaneously para-oxygenation and improving the hemodynamics, I want to shift this patient and getting this patient in controlled environment, and I want to use fiber optic in this patient.
So you're still going to go for an awake fiber optic intubation?
Because I have some time to stabilize this patient, and this is not an urgent situation that I should put endotracheal tube by any means within 1 or 2 5 minutes. So I have time. I can shift this patient and secure the airway in the ICU.
Yeah. So in couple of minutes. So everybody agreed that the situation is going to worse in couple of minutes. So in couple of minutes, the stats start dropping, and there is tachycardia amongst all the residents and the person who has come to rescue. And patient's DCS also deteriorates. How will you secure now? How will you go about with the managing this patient? Dr. Sohan?
In this case, I will tell that if some quick surgeon is available, I will tell them to do a tracheostomy, or I will go for that crick. Yeah.
Any comments from Dr. Namrata?
No, it will be similar. Once saturation is dropping to 80%, definitely surgical airway for this patient. That means progressively the edema has increased and the difficulty in breathing has increased.
Okay, agreed. So, Nivata sir, any comments?
No comments from any of the experts sitting in the audience?
Plan can be para-oxygenation all times, intubation, if not possible. If it is possible, it's okay. If not possible and such situation occurs 80% of situation, go with the crico if the facility of crico is there. If then side by side we plan for the surgical airway. Then I just want to ask one thing here along with my panelists, that if the situation is like this and we are not able to, tracheostomy sometimes take time also because the neck is not that comfortable for everybody. So can we put the second generation supraglottic airway somehow, and then we can do the further thing just to maintain the oxygenation?
Yeah, in fact, the question I was just going to ask, would anyone want to consider a supraglottic device or even an attempt at with a video laryngoscope at intubation with a small tube?
Even through the
that that the saturation is already dropped and the patient is already unconscious.
If he's unconscious, so it's very easy, sir. Then you can easily put the scope, video laryngoscope or any. If he's agitated, then it is difficult.
The GCS is 10, so he's not unconscious. Not completely.
Then definitely, sir. I didn't notice that.
Okay, and prepare for a tracheostomy or a cricothyrotomy at
Yes,
the same time.
We will save time.
Okay.
Absolutely.
I'll say that intubating second generation devices sometimes work as a rescue in these type patients. Like the surgical airway takes time, we are not able to put the tube, then patient is deteriorating. We can put the rescue device, and then we can oxygenate through the supraglottic airway device. And later on, when the patient is either the tracheostomy is done, or we can put through fiber optic with the intubating second generation, we can put the tube at that time.
Yeah, I think that's a great suggestion, Dr. Manpreet.
Yeah.
So
Dr. Sumalata Shetty has commented in the chat box, oxygenation with IG followed by tracheostomy. Agreed with Dr. Manpreet.
But I think even if you're able to do a fiber optic through the IGEL, that would save a tracheostomy for this patient if that it comes in the way of the surgical plan or whatever that may be. So once you have the IGEL, I guess your options are open and you can discuss with the surgical team as to what is the further management of the airway.
But definitely we should not shift the patient without securing the airway.
Oh, absolutely. Absolutely.
Absolutely.
I think even in
all agree.
Before the patient crashed, like Dr. Indu Sen had suggested, this patient needs the airway to be secured, right? Because of the way the injury is, there is definitely massive thermal injury of the airway, along with that of the face and of the chest and neck. Okay. Okay, so are we happy with to move on to the next case? Okay. Okay, so this is a 60-year-old female who was examined in the OPD, and she was worked up with, and she had this epiglottic tumor. Okay, she did not have obvious stridor at rest, and she seemed to be okay, but she was coughing and she definitely had airway sort of type of symptoms. And when they did a check, Hopkins endoscopy on this patient, this is what they saw. Okay, now they've done it in the sitting position. I've just turned the video so that turned it upside down so that it's more similar to what we see when we do a nasal fiber optic intubation. Okay, So here's the video. So this is a tumor. And so that's the tumor. It's in the vallecula there, you can see up front and base of the tongue. Right, and it's coming from the inferior and superior surface of the epiglottis, and that's the vocal cord, the larynx just below. Okay, and this patient was for a robotic transoral excision of this tumor. Dr. Namrata, how will you go about this one?
Sir, since it is for TORS, two choices are there. Either we do upfront tracheostomy or we do a hybrid or a gentle video laryngoscopy, 3.
Okay. So first choice is?
I wouldn't say first choice, it depending on whether tracheostomy is okay, then upfront, otherwise I would do a hybrid.
So as usual, the surgeons are not keen for tracheostomy.
Then sir, I can...
you can see that space below, no? You can do
so I can do an awake video laryngoscopy.
Awake video laryngoscopy.
I would not like to do fiber optic because if I have to blindly push the tube, I may push the tumor.
Okay.
So either it is hybrid or awake video laryngoscopy.
Okay. Great. Okay. Any other opinions from anyone, either in the audience or in the panel?
Actually, this is a robotic procedure. So it's being done in a center where robo is available. So they might be having like imaging for this patient. So we'd like to have a look at the like MRI and how the airway is and how much deviation is there. If the lower airway is normal, as Namrata said, we can go ahead with that.
Yes, the lower airway is absolutely fine. There's no problem in the lower airway.
Then hybrid technique, yeah.
A hybrid technique, yeah. Okay, Dr. Manoj?
I want to use hybrid technique in this patient.
Okay, great. Dr. Sohan?
Yes, sir. So this is this epiglottis tumor which may having some ball wall type of mechanism with the opening. So I would go ahead with an inhalational induction and a video laryngoscope because I don't want to give the relaxation, but I can give some like sevoflurane, and I will do with the video laryngoscope.
But if the tumor falls on the opening?
No, because in a spontaneously breathing patient, I don't think so. It will be fall, and we can lift.
In inhalational, you cannot judge all the time. So
no, so then so it's we will not make the patient apneic. We will give some sevoflurane, and we can give we'll do by video laryngoscope.
So we can prepare the patient fully like an awake patient, like how for awake intubation we had so many talks on.
That we can also do, but if you don't want to do awake, then we can also do under like
that's your second.
Yeah.
This is same. We can prepare like the awake fiber optic. We can prepare the patient like that. Then secondly, we can do the awake video laryngoscopy and a hybrid technique with the fiber optic. And third plan can be we can always prepare for the tracheostomy or crico at that times to have the carry over the time, because sometimes we are caught, like the madam said, that the tumor may fall on the vocal cords. Then we have a closed chamber downwards. We do not have any access at that time. Then we can always do with the fast cricothyroidotomy, emergency scalpel cricothyroidotomy or like that, if it is required. But otherwise, awake fiber optic and with hybrid technique of awake video laryngoscopy is okay.
Okay.
I still have a concern for fiber optic in this. If like we are doing awake fibroid and like fiber optic, why will we require fiber optic? I can, if I'm preparing the patient fully, I can just do with awake video laryngoscopy.
Yeah. Okay. So what we did was we actually did what most people suggested. We did a hybrid technique. And I think Dr. Malde also suggested in the chat that you should do a hybrid technique.
Yeah.
Right. And Avit Shah is also saying an awake hybrid technique. So we did a fiber optic, and we could not actually get under the tumor to get into the cords. So we also put a video laryngoscope and we tried to lift the thing. Unfortunately, at that point in time, she worsened. Okay, she became very distressed, and she didn't have stridor, but now she developed acute stridor and became very uncomfortable and just could not. She just became very obstructed. So now what is to be done?
So did you do tracheostomy?
Well, not yet, but because,
So
she was thrashing about, so it was not. We could not do a tracheostomy just like that on her. She was just so distressed and moving about, and so we'd had to sort of almost anesthetize her to do a tracheostomy for her.
So the distress was because of the tumor falling, or what is the
Probably.
How much was the saturation at that time, sir?
Saturation was maintained. We were giving her oxygen.
It was maintaining saturation.
It was maintaining. The saturation was maintaining.
So maybe a second attempt at intubation after ensuring adequate depth of anesthesia, and again in this patient pre-operative preparation, as Dr. Malde also wrote in the chat box, that nebulization and glycopyrrolate, we need to prepare the patient beforehand.
Yeah, I mean, that's the standard things were done, but unfortunately with both these things happening, this sort of thing happened.
Main concern in this patient is the tumor over the epiglottis, which may fall on at any time on the vocal cords. Then yes, awake fiber optic or fiber optic alone cannot lift the tumor. And lifting of the tumor with any device is very important. What I think is then because the weight of the tumor also will be there, and fiber optic cannot lift each and everything. And in the video, it is visible that vocal cords were visible when the patients this was done. So like we can do with the laryngoscope, video laryngoscope, we can lift it, and with that fiber optic we can push it.
Yeah, so I think the good point Manpreet said, that in the video we could see the vocal cords, but I think the one thing that we missed in our evaluation was that this video, which was taken by the surgical team in the OPD, was in the sitting position.
Yes.
Okay. When the tumor was slightly falling forward, and we were doing all our procedures in the lying down position when the tumor was probably falling down, and that was the difference why we were not able to get to the vocal cords very easily. Right. So ultimately what happened, I think we are running out of time. So what was done in this patient was, we put a cricothyroid cannula. Okay. And then we gave a shot of propofol so that we had access to the airway. And then with a video laryngoscope, we were able to lift up the tumor and put a bougie below the tumor into the vocal cords and get a tube in.
Sir, I still feel in such cases to do fiber optic we should think, because we were seeing anyway the vocal cord opening was visible. So and we had enough space to keep the blade of the video laryngoscope. If you see the whole video, if we just do awake, lift it little, and there are times when you can use a third hand, which can use a bougie or something to retract the tumor, which we have done it, which is very crude way, but when we didn't have fiber optics and video laryngoscopes, so in conventional we have done like that and intubated also.
So ultimately we went back to the good old method of just putting a scope and lifting the tube.
Yes. So instead of bougie, maybe we can use a airway exchange catheter, so that
it has to be little stiff, madam, so that
but we had a cricothyroid cannula, right, for oxygenation, so we were not worried about that at that stage. Fine. But so I think what we started off with a sort of hybrid sort of thing,
technique,
which actually unfortunately worsened the situation, and then somehow we went back to but what we did was we put a cricothyroid cannula, so we had access in case there was a problem. And I don't think there would have been, hopefully there wouldn't have been a problem with jet ventilation, because it was like a ball valve, and the gas would have hopefully come out with the flow of gas in expiration.
So that's true about airway emergencies. We have to be ready to change anytime. Plan may have to be modified.
Here to be just to be more precise, if we are doing the cricothyroidotomy and like the cannula is put there, and then we are giving the jet, then we can put the 23 gauge hypothermic needle with the side of the cannula, so that for expiration we can use that. Yes, because there can be a closed chamber from above.
Correct. So so that's in case there's an obstruction, then a good point. You can put a small cannula to vent the expiratory gas.
Sir, I want to ask, just discuss for half a minute that whether it is a possibility of lateral intubation awake, because I don't know about this tumor. Maybe in the lateral position, this tumor falls down and we get the access to that. I don't know. It's just I'm asking about this.
I have no clue about lateral intubation. Anyone has? They can comment. I mean, this is, yeah. So this is actually a central tumor. Someone is asking, why not a surgical airway as a patient who need post-op ventilator? Well, we wanted to avoid a tracheostomy, but ultimately, I think we landed up with a situation where almost tracheostomy may have been a safer option, but we were able to secure the airway at this point in time, right? And the surgery went on as planned.
Sir, I have a question for you. Sir, next time such a case comes, will you do upfront or you will use other?
Next time, I think if we have exactly something like this, I would take a chance with a video laryngoscope with a little bit of propofol and try and lift up the tumor. Now, my only concern here, a little concern here, initially was one is we got misled by the video, which was actually taken in the sitting position. So actually it became more difficult in the lying down position. Is this tumor was going a little bit, the valvular was almost free, so I guess we could have the base tongue and valvular almost free over here. So I guess we could have tried a video laryngoscope, but I was a little initially reluctant. I thought I would be able to get into this gap right over here. But we did use a hybrid technique so that we could see what was happening. Okay, I think
the take-home message here is like positioning is very important. In
yes.
what position? Yeah.
Yes, position is important, and fiber optic is not the solution all the time. And even when you think you're doing something which is very, very skilled hybrid technique, you still land up in trouble, and you still need to make up some solutions on the spot to help you get out of this while having a safe airway all the time, right?
Mm-hmm.
Okay, I think we'll move on to the next case in the interest of time. Yeah, go on.
Yeah. So we have a patient here with a large front of neck mass, and it was a long, difficult surgery, and the mass has been removed. And then trachea appears to be soft. At the end of surgery, would you like to extubate the patient if he has recovered completely from anesthetic, or would you wait? So what would be your plan for extubation in this particular case? We'll just wait. So surgery is done. You have a doubt because it's a large front of neck mass, probably large thyroid. So it's been compressing on the trachea. Appears to be soft. If the patient has completely recovered from anesthetic, would you go ahead and just plan for extubation, or defer, wait for 24 hours, extubate over a tube exchanger, or go ahead with elective tracheostomy? Okay, we don't. Yes, it's a large mass. Looks like there were pressure symptoms preoperatively. Josna madam is just put up.
So Dr. Anil Dicruz, ex-director and a very prominent thyroid surgeon, has joined, and he's asked, are the nerve functions post-op assured? And we think they were. So the cords looked okay. I mean, the surgeons assured us that the cords are okay. They're done neuromonitoring. Intra-op nerve monitoring was done. So I presume the nerves are okay. We won't know until we pull the tube out. Okay, Dr. Jyotsna Goswami asked whether there were any pressure symptoms pre-op, and the answer is no. Yeah, please carry on.
Yeah. So Over to panelists. Anybody would like to take this?
Yeah. So
since the trachea is soft and it was a difficult surgery, complex surgery, long surgery, I'd like to keep the tube for 24 hours.
What is the
And then
duration of
extubation is to be planned in the OT or in a setup where the facilities are available for the intubation.
what's the duration of surgery?
6 hours.
6 hours.
And history of the tumor, how long the tumor has been?
Long.
Very prolonged.
Yeah.
Long.
1 year.
Basically, the concern is of tracheomalacia, I think.
Yeah.
So usually what happens is we can do if such a prolonged surgery is there, then we can leave the tube for next 24 hours and then later on we can extubate in the ICU.
Okay.
With the all the extubation guides ready, and we can use over the exchange catheter.
Okay, great. I think we need to wind up in the next 2 minutes. So quick responses from any of the other panelists. Sohan, you would add?
So I would like to do a leak test after the surgery into the operating room. And if there is a leak around the tube and the surgery, and if I'm assured that there is no tracheomalacia at this time, I can extubate the patient, but with all the equipment ready to re-intubate the patient if I needed to re-intubate the patient into the OT. But if there is no leak around the tube, then I will definitely not intubate. I will intubate. I will not extubate. I will extubate next day morning or maybe after 24 hours.
Dr. Manoj?
Sir, I wanted to do leak test first, because a patient in preoperative, there is no sign symptom of some respiratory distress, and I assure that adequate reversal of neuromuscular agent or anesthetic agent is there, and nerve monitoring is also confirmed that there is no injury to the nerve during the surgery. So if I am able to do leak test and I get some leak from around the tube, then I want to extubate over tube exchanger, because if tracheomalacia is there, if after extubation there might be collapse of the trachea, so I want to put airway exchange tube, and if required, then I can intubate over that.
Okay. So what is this magical number about 24 hours? What happens after 24 hours that the trachea will not collapse and it will collapse now immediately after surgery? Dr. Indu Sen?
So we'll allow some time for the edema to settle down.
Okay, so you're okay.
Yeah.
Dr. Namrata?
Sir, we can actually, it depends on like a routine for us. What we do is if they are really huge thyroid, we are keeping. Otherwise, we can either tube exchanger or under now fiber optic is there under vision also, we can extubate. But our institute, we keep it for 24 hours. Then next day on tube exchange catheter, tube exchanger only we extubate.
So I think even in the chat, majority would have given that same option that you keep the tube in and extubate the next day over a tube changer. Dr. Amit has suggested what I think you were suggesting is observe over a fiber optic bronchoscope, and if there is no collapse, fine, just go ahead and extubate. Otherwise, put the tube back.
So it's the 24 hour or next day morning we can also extubate.
Yeah, so 12 hours, 24 hours.
Surgery ended at 6 p.m.
Next.
So I think the next morning also.
What if the patient has airway obstruction when you extubate after 24 hours?
And sir, we'll come to know only after the tube is out.
Right. So
even in the post-op period side, we should extubate over the tube exchanger.
Actually, what I think is that the body has already accustomed with the large tumor at that place for a long time. So when we have removed that, then how the structures will behave afterwards, that is the main concern. Like we have to maintain the airway for that situation, that the trachea should not collapse. So that's why some hours like next day morning or 24 hours, we can have this logic. And if it is everything is safe over exchange catheter with the leak test, we can extubate in the safe environment of ICU. But this is my opinion.
I think that's a good closing remark.
Yeah.
We have to end because we've run out of time. So,
Absolutely.
but I think at the end of the day, I think what all of us have agreed on is that safety comes first. Whatever technique you use, we need to make sure we don't lose the airway, and we are in control of the airway at all times. At times, we may have to be a little innovative, but always make sure the airway is in our control, whether it's with a tube exchanger, whether it's with the ability to ventilate or whatever it may be. Yeah. So.
Yeah. And for your help, we have published in 2016 guidelines for management of anticipated difficult extubation, and this is exactly what has been discussed here. So one of the S's, that is suspected airway collapse. So if it is there, you perform leak test and then extubate over AEC or FOB.
Okay, so thank you all very much for taking part in this lively discussion. Some differences, but overall consensus. Thank you very much for listening. Yeah.
Thank you, sir.
Thank you.
Thank you so much, sir. Thank you so much.
Thank you.
Thank you, Diwakar.
We move on to the next session.
Thank you, sir.
Thank you so much for such a wonderful session, persons and speakers. Moving to our next session, that is head and neck session, I would like to welcome our respected chairpersons, Dr. Anil D. Cruz, Director Oncology, Apollo Hospital, Mumbai, and former Director of Tata Memorial Hospital, Mumbai, Dr. Rakesh Garg, Additional Professor, AIIMS, New Delhi, Dr. Jitendra Bapat, Consultant Anesthesiologist, PD Hinduja Hospital, Mumbai. Over to you, respected chairpersons.
Good afternoon, everybody. Am I heard?
Yes, sir.
I'll take the prerogative to start the meeting because I'm the only non-anesthetist and I am in the head and neck, and this is the topic very dear to me. And I'm also introducing the first speaker, who's someone very dear to me. The session is on head and neck, and we are always concerned about the airway. And I think this entire session is very craftily put together. It's on oral cancer surgery, the commonest cancer in our country, tracheostomy versus delayed extubation. We have management of a thyroid bleed, and we have complications of a tracheostomy. So over to you, Sheila, for the first talk on oral cancer, extubation versus tracheostomy.
Hello, everyone. I'm Sheila Maitra, Professor of Anesthesia and Intensive Care, working at the Tata Memorial Hospital in India. Today, I'm going to be speaking to you about how we can decide whether to do a tracheostomy or delayed extubation following major oral cancer surgery. And I'm going to try to answer this question and give you some guidance based on our recent publication in Oral Oncology, where we tried to identify patients for delayed extubation strategy versus performing an elective tracheostomy following major oral cancer surgery. Now, before I start, I'd like to give you a little background about my hospital. I work at the Tata Memorial Center. This is one of the largest cancer centers in the world with a very high volume of head and neck cancer cases. This is for our hospital. And why do we have a lot of head and neck oral cancer cases in India? And this is because of a different challenge that we face, and that is smokeless tobacco. There is a lot of tobacco that's not only smoked as in cigarettes, but also chewed in the form of gutka that you're all familiar with this. And this results in a higher incidence of oral cancers as compared to the laryngeal cancers. And many of these patients present to our center being a tertiary cancer care centers with a very high volume of head and neck cancer cases. Now, this is our operating room where we do a high volume of head and neck cancer surgeons, and we have expert ENT and cancer surgeons and anesthetists who are dedicated to managing head and neck cancer, and also a center with very good research output from the oral cancers. And this is a paper which was published in NSJM from Professor Anil De Cruz, who's chairing this session on elective versus therapeutic neck dissection in node-negative oral cancer. And the reason we are able to perform this is because we are a high-volume center, and we are in the perfect position to be able to answer these questions related to oral cancer. Now, as you are all aware, there are several challenges in airway management during oral cancers. We are worried about actual or potential airway obstruction, airway loss, difficult ventilation, difficult intubation, and we're sharing the airway with the surgeon. So there are a lot of challenges. But one of the other challenges that we face is the post-op airway management. Once the surgery is over, and you have to decide whether this patient should, get a tracheostomy, or you're going to be comfortable performing a delayed extubation for this patient. We try to get an R0 resection, so you might have to go very wide, and there can be extensive resection. And in addition to this, for this extensive resection, there's a lot of flap reconstruction. So you may have bulky flaps that are present in the oral cavity that may compromise the airway patency post-surgery. So a lot of time you're left with no choice but to do a tracheostomy. Again, depending upon your infrastructure and what is the expertise and your comfort level post-operatively, many sites might choose to do an elective tracheostomy. However, there are selective group of patients in whom you can perform a delayed extubation, and we know that this strategy definitely can result in lesser morbidity for the patients. So let's look at the literature. Tracheostomy over overnight intubation. Now, what do we have in the literature? Very few prospective studies that have shown a benefit of delayed extubation over tracheostomy. And what they've suggested is, with appropriate post-operative care and careful selection of patients for following head and neck oral resection, they can be safely managed without doing a routine tracheostomy. So the question really is that which are these patients that we can avoid a tracheostomy in? We don't have any literature. There's a wide variation of practice depending upon where you present with. And what is the benefit of a delayed extubation? So a delayed extubation strategy, it maintains the patent airway while it allows time for the edema to subside, which is present after major oral oncology surgery. It prevents the airway compromise. Now, just in case there is an immediate post-operative surgical complication, some bleeding, you already have a patent airway and you don't have to re-intubate this very difficult airway. And in addition to this, the other benefits are it minimizes the risk of, some unidentified post extubation. So if you do an extubation late in the night and there's some airway obstruction, when there's less staffing, this may be a problem. So a delayed extubation strategy at the end of the day, when this case is over with the nasal endotracheal tube, you leave the patient overnight with some minimal sedation, and then you can extubate them in the morning when there's adequate staffing available. However, it's very important to understand that delayed extubation cannot be performed for all patients, because patients who have very extensive resection who cannot protect the airway will obviously need a tracheostomy. And what's interesting is this approach has never been prospectively studied in a large cohort of patients. And that is what we try to do at the Tata Memorial Hospital. And we published the results of this large trial that we did in oral oncology. And I'm going to give you a short summary of what we did and what are the important findings, and give you some guidance on how you could select patients for a delayed extubation. So this was a prospective observational study, and it was a large cohort of patients who all had oral cancer surgery. And what we tried to determine was how you could identify the safety of a delayed extubation. Now, what did we mean by a safe extubation? We meant one where the patient after post-extubation could maintain a patent airway, because that's the most important thing that you want after an extubation. So we used only adult patients, major oral cancer surgeries, and for the first time, we didn't take redo surgeries, and those who presented with curative intent. Patients who are undergoing minor oral surgical procedures, pediatric patients, or redo cancer surgeries were not included. And of course, patients who already had a tracheostomy were not included in this study. And, we also not only looked at complications in patients who had tracheostomy and overnight delayed extubation, but we also looked at the time to starting the post-operative oral intake, and also for return of speech, because these are very important quality indicators and may get compromised, especially in patients who undergo a tracheostomy. So this was a study we did over a period of 1 year, and large number of patients, almost 4,500 were screened. We excluded those which were not major surgeries or which were, not done surgeries other than oral cancer surgeries, and those in pediatric redo surgeries were excluded. And finally, we had 720 cases, and these were in two groups. 407 underwent delayed extubation, and 303 patients underwent a tracheostomy. And when you look at the patient characteristics and the surgical details, for some reason, patients in the tracheostomy group were of a lower weight. There were the duration of anesthesia, and also the anticipated difficulty in intubation was more, obviously in patients who had tracheostomy, obviously because they were probably had extensive disease. There were more T1, T2 lesions in the delayed extubation group, whereas the tracheostomy group had more than T2 lesions, so more extensive disease. And when you look at the surgical resection, there was more extensive resection related to the tongue, mandible, or the maxilla in the tracheostomy group. More bilateral neck dissection was seen in these patients, and much more reconstruction in patients who underwent tracheostomy. And this was more as was expected because these were patients who would undergo more advanced disease. When we looked at postoperative complications, and this is interesting, so if you look at overall complications, this was significantly more in patients who had tracheostomy. When we looked at only the airway-related complications, and these were like blocked fluke, cutaneous fistulas, bronchospasm, etc., it was significantly higher in patients with tracheostomy. Other complications like surgical and medical complications also were higher in patients with tracheostomy. One may argue it is also because these patients had extensive disease, so they may have more complications. What's interesting to see is the location of the complications. Now, all the complications that occurred, the 7 in the delayed extubation group, all occurred in the PACU, which was a highly monitored area, because you're extubating the patient overnight. So, if there's any airway obstruction following extubation, it will be picked up. However, the complications with tracheostomy, if you see, there were 26, but 22 of them occurred in the ward, and these were mostly blocked tracheostomy tubes. And in the ward, there may not be as much nursing and monitoring happening as in a PACU. So this is one of the issues with the complications related to tracheostomy, that they may occur even later when the patient is a ward, which is unlike to happen with the delayed extubation. And what we found was the time taken to start postoperative feeding, the oral intake, and the return of speech, as was expected, was shorter in patients who underwent delayed extubation. What were the factors associated with safe delayed extubation? We performed a multivariate analysis. So we looked at all the patients who underwent a safe extubation, and then we looked at all the factors that were responsible for this stage extubation. And we found no neck dissection or a unilateral neck dissection, tumor staging 1 or 2, no preoperative radiation, conservative surgical resection, primary closure or just a faciocutaneous flap, and a shorter duration of anesthesia was associated with a higher chance of having a safe extubation in these patients. And it was interesting to see that we did not even have a single patient who underwent extubation who needed a reintubation. And this obviously reflects the experience in the center and the practices that have evolved over the last 50 years, where we've become more and more bold in extubating patients and have kind of identified which patients are suitable for a safe extubation. Now, there are studies which have looked at which patients looked at tracheostomy, but this is more difficult to identify because there will always be some patients who undergo a tracheostomy, and then you cannot access delayed extubation in these patients. So we took a different approach by looking at which patients you could definitely perform a safe extubation in, and this is a more relevant endpoint for an anesthesiologist. So based on our multi-airway analysis, we came up with this algorithm. So if you have a major cancer surgery, and if you have all these characteristics, that means the patient has no neck dissection or unilateral neck dissection, and tumor staging is only 1 or 2, he has no pre-op radiotherapy, and an absence of extensive surgical resection, and either a primary closure or just a faciocutaneous flap, these are the patients that you could safely consider for a delayed extubation. And what we mean by extensive resection, that's point number 4, is for tongue crossing the midline, like either a near total or a total glossectomy. In mandibular cases where the genial tubercle was involved with extended and middle 1/3 mandibulectomy, and for maxilla, where it was crossing the midline, the excision, or extending onto the soft palate. So these were the simple anatomical criteria that we identified for considering patients for a safe extubation. Of course, there are limitations in the study. We didn't include patients who underwent redo surgery, so we don't know whether this is applicable for those surgeries. And as I mentioned earlier, there are some patients who underwent tracheostomy. In those patients, we could not identify whether these patients could have undergone a safe delayed extubation. Again, the decision to perform a tracheostomy or delayed extubation was purely left to the surgeon. This was a prospective observational study. So though there were patients, many patients, there could have been some patients in the tracheostomy group who could have undergone a delayed extubation. We will never know this. The only way to know this is to extubate all the patients and reintubate those patients who present with some airway obstruction. But this will be very unethical and it will be an unsafe approach. So it's better to err on the side of doing a few more tracheostomies and identify definitely those patients who you can safely extubate. And also the selection criteria for performing the delayed extubation, though is done in a very high volume center with very experienced surgeons and anesthetists, this definitely needs to be externally validated. The strength of our study, I would say this was a large prospective study conducted in a very high volume center with people with considerable expertise in the management of major oral cancer surgeries. The entire spectrum of disease was available. So if you go to centers where you have very early lesions, you will not have patients who need tracheostomy. But because, unfortunately, I would say, we have patients who present, it's a tertiary cancer care center, who present with very advanced disease coming from different parts of the country, presenting very late. We also had several advanced disease cases. And so we were in the perfect position to have the entire spectrum of disease to be able to evaluate an equivalent proportion of tracheostomy and delayed extubation. And we did a multivariate analysis. We didn't look at factors associated with performing a tracheostomy or a delayed extubation, because that, of course, would reflect local practice. What we looked at was patients with a delayed extubation, and then we did a multivariate analysis to look at factors that were associated with the delayed extubation. And what is very interesting is our practice has evolved over the last 50 years. So we've become more and more confident in extubating more and more patients. So our cohort actually is a very suitable data set to identify patients that can undergo delayed extubation compared to a less experienced center with a low volume of cases. In conclusion, I'd like to say that a delayed extubation strategy after major oral cancer surgery is a safe and effective alternative for airway management in select cases with faster return of speech and also oral intake as compared to performing a tracheostomy. Now, the tumor staging, that is a T1, T2 lesion, absence of extensive resection, a primary closure or just reconstruction using a faciocutaneous flap, absence of preoperative radiation, unilateral or no neck extension, and shorter duration of anesthesia are independently associated with a decision to manage the patients with a delayed strategy. So I leave you with the algorithmic approach with the 5 criteria, and if you have none of these criteria, you can consider a delayed extubation. Thank you very much for your attention. I'm happy to take questions. Dr. Akish, you are muted.
So welcome, thank you, ma'am. Welcome to the next speaker. We have Alan O'Sullivan. She is a consultant anesthesiologist at Sir James Hospital, Dublin, Ireland. She will be speaking on the topic, guidelines to manage post-thyroidectomy bleed. Over to you, Alan.
Hello, thank you very much for the kind invitation to be part of the All India Difficult Airway Association. I'd like to thank Professor Sheila Mayatra, Professor Shetty, Professor Bhatia, and Dr. Rakesh Kumar for the kind invitation to be with you today. I have no conflict of interest, but I have a number of affiliations. I am elected council member to the Royal College of Anaesthetists, and I'm past president of the College of Anaesthesiologists of Ireland. I'm also past president of Difficult Airway Society, but still involved as international liaison officer, and I'm the airway advisor to the College of Anaesthesiologists of Ireland and executive director of the World Alliance for Airway Management. We ran 2 WAM meetings and hope to run a 3rd WAM meeting in 2023. Now, I'm going to just tell you a little bit about where I work. I work in Dublin, Ireland, in St. James's Hospital, which is a large academic teaching hospital attached to Trinity College Dublin. And we have a big head and neck cancer workload in our hospital with a large maxillofacial unit as well and a national burns unit. So for that reason, I've been running an airway fellowship and simulation program for many years now at St. James's Hospital. Now, as part of our clinical workload, we do a lot of thyroid surgery, obviously a lot of cancer thyroids, parathyroids, and thyroids, more the bigger thyroids and the retrosternal goiters, because we have cardiothoracic and the thoracic surgeons are often on standby for these. So we probably do 200 of the bigger thyroids per year. Now, this was a study which looked at prediction of difficult intubation, which we talk about a lot in thyroid surgery. It's not the main topic for me today, but just to set the scene, difficult intubations occur in about 5.3% in this study, and that would be about, it would fit with international experience. Cancerous goiters are Cormac-Lehane 3 and 4 are independent risk factors for difficulty. Goiter size does not impact on difficulty, and this has been shown in numerous studies. Cancerous goiters, however, are a major factor predicting difficult intubation. So our first question always is this an invasive cancerous goiter? And that will make a difference and be obviously higher risk of a predicted difficult intubation. Now, this is a study looking at 573 patients undergoing thyroidectomy procedure at Aintree University Hospital in Merseyside, where I worked as a consultant, trained and worked as a consultant for a number of years. And this looked at these patients, 573 over 5 years. 34 were retrosternal goiters and 19 were deemed massive retrosternal goiters. And in this group, there was 1 case failed intubation, no sternotomies, and no post-op respiratory problems with tracheomalacia. And again, this does mirror our clinical experience. Now, patients with massive retrosternal goiters obviously may present difficulties with airway management, the concerns like mechanical ventilation or post-op tracheomalacia, but opinion on the optimal anesthetic management is completely divided, and that's something I will mention again. Now, a technique of IV induction, direct laryngoscopy and tracheal intubation was successful in 18 of these 9 that were deemed massive retrosternal goiters in this study. Now, post-thyroidectomy tracheomalacia has been looked at and can occur after goiter surgery, but its reported incidence varies. In this series, I'm showing here 62 of 334 patients had tracheal compression, but there were no cases of tracheomalacia. And tracheomalacia after thyroid surgery is rare in contemporary UK and Irish practice, in fact. Now, I'm just mentioning this case because it was interesting. This was an airway obstruction caused by retrosternal thyroid mass, which was reported by Tim Cook and his colleagues. And it was interesting because they wanted to get an opinion on how to manage this case, which I will tell you about. It's a 59-year-old female with inspiratory stridor. She's a BMI of 30. A large retrosternal thyroid mass, compressing the trachea in the midlab, but dividing the trachea into 2 or 3 lumens. On nasendoscopy, there was nothing abnormal to the vocal cords, and the pretracheal mass went from C5 to T2, and this patient was for urgent total thyroidectomy. And I think Tim and his colleagues wanted to know what a group of experts would do. So they wrote to about 12 internationally well-known, real experts in this field. Now, this is the case, the images that they shared, and you can see the kind of the tracheal lumens there, and the size of the pretracheal mass. And they wanted their opinion prospectively and to see what they would all do. And only eight responded in detail. And as I say, these were all experts, and they varied very much in what they suggested they would do at induction and intubation. Some would do an IV induction, some would do inhalation, and awake fiber optic, almost evenly divided, and one would do sedation using a rigid videoscope. So that was what they did. Their plan B was mainly rigid bronchoscopy, but again, various offers, and extubation strategy varied also quite a bit. So what was actually done by the people managing this case, Tim and his colleagues, awake fiber optic intubation with the entry intubation catheter as a kind of a rigid stiletto in case, I suppose, they couldn't get the tube in, and then ILMA tracheal tube, the intubating LMA soft tracheal tube over the intracatheter, and this was successful. So they didn't proceed to their plan B, which was an intravenous induction, neuromuscular blockade, and intubation with a rigid bronchoscopy, obviously, as the scope if needed. They extubated this patient by inserting a proceal LMA and a fiber optic inspection then to exclude tracheomalacia because of the size of this huge retrosternal goiter. But I think what their comments were, for every expert, there is an equal and opposite expert opinion. And it's a very interesting article to read, in fact, because they discuss what would have happened if this hadn't worked and their technique had failed and there was a morbidity. The experts would obviously all have given different opinions. So I think this was an interesting case. Now on to the guidelines I want to present today. These new guidelines are straight off the press in anesthesia in September 2021. They are concerning management of hematoma after thyroid surgery. It's a systematic review and multidisciplinary consensus guideline, led by one of the trainee members of DAS, and Karim and Imran Ahmed from DAS are also in the authorship, as are representatives of the British Association of Endocrine and Thyroid Surgery and the British Association of Otolaryngology, Head and Neck Surgery. So why did they write these guidelines? Post-op hemorrhage is a well-recognized complication of thyroid surgery, occurring between 0.45 and 4.2% of cases. 25% of these result in airway compromise. So guidelines are aiming to improve patient safety by training people on how to manage it, recognizing it first, obviously. And no previous multidisciplinary team consensus guidelines have been published on this topic. And remember, every compromise usually occurs within controlled environments like recovery and theatres and ITU. How obstruction, it may present in a more remote area with higher patient to staff ratios. So like back on the wards, maybe 24 hours later, not as frequently monitored, and lack of immediate access to appropriately skilled staff. And sadly, we did have a case on the ward that succumbed a number of years ago in our hospital because of that. So there's a risk of rapid clinical deterioration if there's a small hemorrhage, especially obviously if there's backward edema and laryngeal edema and obstruction. So these principles and these guidelines may apply to other types of neck surgery, such as parathyroid, cervical spine, or vascular surgery. So monitoring hemorrhage, and how long do you monitor for? Hemorrhage and hematoma usually occur within the first 24 hours following thyroid surgery, with approximately half occurring within 6 hours. This begs the question of day case thyroid surgery, I suppose. But routine patient observation should be carried out hourly for the first 6 hours post-op. Following the initial 6-hour period, the frequency of observations may be tailored according to individual patient risk. Patients are usually discharged 1 day following surgery because, I suppose, of the risk within the first 24 hours, but also there is a move towards day case thyroid surgery. It's something we could discuss later maybe. But these are the 8 major recommendations and the infographic that comes with these guidelines. And I'll just go through them in a little bit more detail. Number 1, monitor for DSATs at least 1 hourly every hour for 6 hours. And DSATs stands for difficult swallowing or discomfort, news, swelling, anxiety, tachypnea or difficulty breathing, and stridor. And this is an acronym which helps to pick up early signs which need urgent senior clinical review. And not the desaturation, increased oxygen requirements will be a late sign. Remember, the desat is to help pick up early signs. And this is, and at this point, you should be doing close post-op observations. And if you review this patient and they reveal any one of or more of the above, you should proceed with oxygen. If nurse them head up, and then evaluate and arrange for immediate senior surgical review. And this is very important. And if there's any signs of airway compromise, you evacuate the hematoma and request immediate senior anesthetic review. So senior surgical and senior anesthetic review. And again, this is a team effort. Number 2, inspection. Look at the wound. Early warning and pain scores must be observed, and with subtle signs, agitation, anxiety, difficulty breathing, and discomfort are the minimal monitoring. And you may at that point give IV dexamethasone, tranexamic acid, and maybe even do a flexible endoscope to see if there's any edema. Number 3 and 4 is the post-thyroid surgical emergency box. And this should be at the bedside during transfers. And this is a change of practice that we have introduced. With an artery clip, the guidelines for treatment and for scoop, which we'll discuss, a scalpel, a scissors, and a staple remover if you have staples, and then sterile gauze and a wound pack. And ephone equipment at hand. Remember, it's always at hand, hopefully in your anesthetic departments, but where there are thyroids as well. If you're concerned, then following that, you must seek immediate senior surgical review and senior anesthetic review. And again, I said there was morbidity in our hospital, and it was related to not calling senior surgical personnel and senior anesthetic personnel. Oxygenate and evaluate. That's important. If airway compromise, open the wound at the bedside with scoop. And this is scoop. It's management of the acute hematoma following thyroid surgery, and it is the evacuation protocol. Scoop stands for skin exposure. C is for cut the subcutaneous sutures and push fingers into the wound. O is to open the skin and expose the strap muscles. Then open the strap muscles. So O is to open the muscles and the strap muscles to expose the trachea. Then you pack the wound, cover the wound with a pack. Now, post-evacuation, if the patient is stable, the surgical team must discuss with the patient, offer referral for psychological support, and support the team involved to maintain and attain and maintain skills. So that's the scoop protocol. Now, this guideline comes with excellent supporting materials to implement and to help you implement these guidelines, and here they are. And remember, if the clinical presentation is airway compromise, it might be appropriate to do a wake tracheal intubation if you're very experienced. But if life-threatening airway compromise is imminent, tracheal intubation should be attempted after opening the wound and evacuating the hematoma. So follow on then with airway support. A smaller ET tube should be used as well as a bougie, because you will get some edema. And successive tracheal intubation confirmed, obviously, with capnography, particularly if there's edema there. If they further deteriorate, emergency tracheal intubation must be considered regardless of patient location, so even on the ward. Experienced anaesthetist should attempt tracheal intubation as per the DAS guidelines, having no more than 3 attempts and progressing to plan B, supraglottic, and then front of neck. VL at first attempt. Remember, this is an emergency airway. Always use VL at the first attempt and limit the number of attempts, as it says in the guidelines, to 3. Early progression to phonia should be considered, and this is grade 3 evidence, but important because these are deteriorating, very difficult airways. And if you cannot intubate, you cannot oxygenate. Scalpel cricothyrotomy, again, is the preferred to cannula because of the high risk, and also those of us who follow the DAS and the Indian guidelines go straight to surgical airway. And the equipment must be immediately available. A scalpel size, remember number 10, and remember not a plastic scalpel, metal scalpel, a bougie, and a tracheal tube size 6. So continue oxygenation, though, either with a supraglottic, even though you're not 100% sure, it's a continue oxygen above, declare CICO, and ensure neuromuscular blockade, and position the patient as much as possible to extend the neck. Here's the equipment. As I say, I would use a metal size 10 blade, standard bougie, and a small size 6 or some size 5 fit over the gum elastic bougie. Now, I contend that all anaesthetists should be able to do scalpel bougie tube, whether it be in theatre or in the emergency department or on the ward. So we need to have this as a technique we are happy and willing to do and have practiced. We keep it on all our anaesthetic machines, but now also it's going to be with the scoop box on the wards where thyroids are going back to. And it's a core skill. We teach it on all our airway courses, and for our trainees, training in this skill is mandatory. They cannot CCST complete their training unless they have attended some of these airway courses. Cognitive aids, I mentioned the scoop and I mentioned the aid, the other aid that comes with these guidelines. They improve communication by flattening the hierarchies and structuring interactions. So if people are familiar with this, anybody in the team can speak up. During stressful critical incidents, we all know that human factors are overloaded with facts, cognitive load of the user, and it's much easier if you have a structured approach practiced. And these cognitive aids are designed to be used by any member of the MDT team. So any MDT staff potentially interacting with the patients following thyroid surgery should be trained to recognize and manage hematoma, right from the recovery staff to the ward staff. And training should reference the post-thyroid surgery emergency box used. And you should practice with it, know what's in it, and be familiar with all the contents. And teaching should ideally prioritize simulation. Now, the risk of hemorrhage following thyroid surgery is about 1%, 1 in 100, and the risk of hematoma is poorly defined, but studies suggest it leads to acute airway obstruction in 1 in 400 thyroids, and these are ones who need emergency bedside intervention. Patients should be warned of this as part of the surgical consent process, and particularly if they want to be done as day cases, this is a very important point to make. Reoperation after thyroid surgery. This was an interesting paper in 2000 recently. It was a retrospective cohort study of all consecutive patients who underwent thyroid or parathyroid surgery over a 7-year period. There were 1913 patients in this study, and 1.3% of these had reoperations for bleeding. More common in total thyroids, bleeding after thyroid than partial thyroidectomy, and more common in total thyroids than in parathyroid surgery. And 24% of those 25 who bled needed reopening in the operating room. 68% within 6 hours of surgery, 4% within 4 to 24 hours, and 4% after 24 hours. Now, these patients who had reoperations for hematoma had longer length of stays, with similar rates of recurrent laryngeal nerve palsy, wound infection, and hypothyroidism. New protocols were created to reduce the risk of bleeding and for early bleed management, and this was published in the World Journal of Surgery. Now, I always say beware of the oozy Graves' disease thyroids. Again, we do quite a few of these, and these are very juicy, the blood loss is often quite significantly more than you had for your normal thyroid. So Graves' disease thyroids can be oozy. Post-op communication. The potential risk of hematoma should be highlighted during the sign-out. Should be cascaded through explicit handovers from the recovery room to the ward when you're transferring them either to the PACU and the ward. Direct surgical handover on any concerns should be communicated to the PACU and the ward nurses so they're aware of it, and again, increase their monitoring. I mentioned the thyroid hematoma emergency boxes. You can use these sort of lunch boxes and make them up, and you can see with the guideline here, the scoop guideline, your scalpel bougie technique, and your scissors and so forth. These are slightly more expensive ones, which you can take to the ward and return. So you only have to make them up and keep reusing them. So the cost is minimal. But the important thing is multidisciplinary training. This is St. James's Recovery, and we did multidisciplinary within, I think, a week of the guidelines being published. And this is a multidisciplinary team in the recovery room in St. James's doing a simulation on a post-thyroid bleed. And in our college simulation, where we do training for all our trainees, we have this mock-up of a bleeding thyroid, and we teach the scoop technique here. So thank you very much for your attention, and I'd be delighted to take any questions you might have at the end of this session. Thank you.
Thank you so much. We'll take up the question at the end of session. Thank you so much, Arun.
Thank you so much, Dr. Allen, for such a comprehensive sharing of recent guidelines of management of post-thyroidectomy bleed. Next with us, we have Dr. Jyotsna Goswami from Calcutta, and she's going to speak on complications during and after tracheostomy. Over to you, Dr. Jyotsna.
Good afternoon. In the outset, I'd like to thank the organizers for making me part of this grand event. And my topic today is complications during and after tracheostomy. Tracheostomy, a life-saving procedure, and it is being used as different emergency conditions like upper airway obstruction, airway protection, pulmonary toilet, prolonged mechanical ventilation, and also as part of a surgical procedure. And like any other technique, tracheostomy also has got its own complication, and it is estimated up to 30% worldwide. Indian authors also reported complications, various complication incidence rate. And while discussing about the complications of tracheostomy, it should be discussed in 3 phases: early, or which occurs during or immediate the post-procedure period, and intermediate, which occurs within 7 days post-operative period, and the late, which occurs after 7 days of post-procedure. So late complications are not in the scope of my talk, so I will discuss only the significant complications of early and intermediate complications. And early complications include hemorrhage or bleeding leading to aspiration of blood, apnea, injury to surrounding structures. And intermediate complications include tube blockage, tube displacement, surgical emphysema, infection, delayed hemorrhage, and tracheoarterial fistula. So if you see the early complication, hemorrhage or bleeding is the life-threatening situation, and the cause should be established as early as possible. And we should assess the effect of anticoagulation or any clotting abnormalities are present or not, and then it should be corrected immediately. Then again, if there is bleeding, blood clot can block the airway, so we should assess for the airway obstruction. And if anything is there, then we should ask for expert surgical help. There may be some rare causes like tracheoinnominate fistula, aberrant right subclavian artery, which also can give rise to severe intratracheal bleeding. If there is a localized bleeding and superficial bleeding, it can be controlled by suction followed by external compression, cauterization, application of surgical clips, and also by the packing with gauze piece soaked in adrenaline and tranexamic acid. But if bleeding occurs deep into the stoma, then it is a problem, and it has to see that hyperinflating the tracheal tube cuff can have a tamponade effect on the bleeding vessels. And in that case, we have to inflate the cuff with around 35 to 50 ml of air, depending on the size of the tube. And if there is uncuffed tube, it should be replaced with a cuffed tracheostomy tube. Once bleeding is controlled, then surgical exploration and repair can be done. The tracheoinnominate artery fistula, or TIF, is a rare occasion. Incidence is 0.1 to 1%. Here, the innominate artery, or right decuspable artery, it crosses the trachea in the front, and the TIF usually develop between 3 days to 6 weeks of post-tracheostomy, and there can be a severe sudden tracheal hemorrhage, which should be controlled immediately by endovascular stenting and surgical intervention. Due to the anatomy of the trachea, all vital structures are close by, so it can cause injury to the recurrent laryngeal nerve, the dome of the pleura, and then esophagus. Pneumothorax is a rare but life-threatening complication. It can be caused by direct tracheal injury, paratracheal false passage, spontaneous rupture of the pulmonary bully, and also the negative interthoracic pressure created due to the upper airway obstruction can lead to air leak. So to prevent the pneumothorax, we should be careful to avoid any direct injury or false passage. Then the loss of airway can be prevented by a proper securing the tracheal tube with stitch and tape around the neck. Then every tracheal tube exchange should be checked with the bronchoscope. A fast tracheal tube exchange should be done by the surgeon because it is done after 48 hours. That time tracheostomy tract is not yet matured, so it can cause injury. But if the pneumothorax has been detected, it should be treated immediately by large bore needle insertion or chest tube insertion. Coming to intermediate complication, which occur within 7 days of the procedure, that time tract formation is not matured. So we can have multiple complications. Tube blockage is one of the commonest complication. It can be blocked by mucus plugs or blood clots. Usually it doesn't happen due to the proper suction and adequate humidification, frequent cleaning up and changing of the cannula, etc. But if it happens, then there may be signs and symptoms of airway obstruction, such as breathlessness, noisy breathing, use of accessory muscles. There is no or limited air expiry from the tracheostomy tube, and deteriorating gas exchange. And most importantly, there will be difficulty in ventilating using ambu bag and difficulty in passing a suction catheter through the tracheostomy tube. Tube displacement is another complication, and rate is around 0.8% in the first postoperative week. And it can cause by several factors can be responsible for tube displacement, such as if the tracheostomy tube is not secured properly, then it can be displaced. In the immediate postoperative period, the tract is immature, so that also can cause the displacement. Then any type of strain, if patient can have a cough or patient movement or turning, anything can also dislodge the tube. And if the tracheostomy tube is connected with a ventilator tubing, which is heavy, that can have a dragging effect on the tube and can be dislodged. Then prior radiation or surgery in the neck can cause damage to the tissues, and which also can hamper the tube securing. Then goiter, short or thick neck, or morbid obesity, all these things can cause tube displacement. So once tube dislodged, it can go form of pseudotract, then can lead to subcutaneous emphysema, pneumothorax, loss of airway, stomal stenosis, tracheostomy fistula, and sternoclavicular osteomyelitis. So again, signs and symptoms of tracheal tube displacement will be similar noisy breathing, increased work of breathing, voice change, subcutaneous emphysema, malposition of the tube, you can see, visible cough in the tracheostoma, then inability to hear breath sound on auscultation, change in respiratory dynamics in the ventilated patient, and also the inability to pass a suction catheter through the tracheostomy tube. So it can be prevented by proper securing the tube. And in morbidly obese patient, you need a longer tube. So appropriately sized, soft, flexible tube with a adjustable flange and an extra long proximal portion is better for fixation. Then if a dislodged tracheostomy tube is identified, it should be replaced immediately. But the procedure is risky if the tract is new, that is within the 7 days of post-procedure, and when the tracheostomy is done due to upper airway obstruction. So in that case, you should have a most experienced person that handling the tracheostomy tube. And in case of difficulty to reinsert, orotracheal intubation should be done. If the tract difficult to visualize, then tracheostomy tube can be placed over the suction catheter or Cook catheter, which allows the jet ventilation. Flexible fiber optic endoscope is very, very helpful because it helps to visualize the stoma as well as the tract. But if the tube cannot be inserted, then orotracheal intubation is the only result. And tight stoma, then we need a smaller size tube. In case of goiter, neck mass, obesity is there, then we need an extra long tube. If the stoma started narrowing recently, then graduated tracheal dilators with a lumen should be passed serially after lubrication. And all these manipulation can cause bleeding, so we need to have one experienced intubator and emergency airway equipment ready. Head and neck cancer poses a great challenge because radiation and surgery can increase the friability of the tissue, and that with manipulation it can cause bleeding, wound breakdown, then there may be separation between the trachea and the skin. And also if the treatment is ongoing and treatment is failed, the tumor will be there and it can obstruct the airway. So endotracheal intubation also even cannot be very, very difficult. Surgical emphysema is another complication which can occur due to through and through tracheal puncture leading to gas tracking into the paratracheal tissues or mediastinum. Then coughing or positive pressure ventilation against tight closure of the stoma or packed wound, use of too short or fenestrated tube, all these things can give rise to surgical emphysema. Usually it is managed conservatively with the treatment of underlying cause, and if the tracheostomy tube malposition is detected, it should be exchanged immediately. And you should, in case of surgical emphysema, we should also look for the pneumothorax because usually that can occur simultaneously. So to manage an emergency situation, we should have a help from the airway expert. Then look, listen, and feel for the breathing, both at the mouth and the tracheostomy wound. You can also assess the breathing by using water circuit, capnograph, etc. If patient is breathing, then it's well and good. We can apply high flow oxygen to both the face and the tracheostomy wound, and then assess the tracheostomy patency. But if patient is not breathing, then we should give a call to resuscitation team for CPR if needed, and then assess the tracheostomy patency by removing the inner tube and passing the suction catheter. If it can be passed easily, then it's okay. Tracheostomy tube is still patent. But if cannot be passed, then again you have to deflate the cuff and again assess for the breathing. And simultaneously also observe the patient whether the patient is stable or improving. If it is so, then it's good. But if patient is not improving or deteriorating, then we have to remove the tracheostomy tube and reassess the breathing. If patient is not breathing, then it's real emergency. We have to go for urgent oxygenation. And this emergency oxygenation primarily you can do with oral bag mask and supraglottic airway device. But please close the stoma or block the stoma to prevent the air leak. You can also ventilate through the stoma with using pediatric face mask and LMA. And then simultaneously you should go for the secondary emergency oxygenation by securing the airway. You attempt the oral intubation, prepare for difficult intubation with all intubation aids, and also you can attempt intubation through stoma by using smaller size tube, entry catheter, fiber optic scope, bougie, air exchange catheter, etc. So this is a mask ventilation with occlusion of tracheal stoma. This is the mask ventilation with tracheostomy ventilation with LMA. And this is the orotracheal intubation with a tracheostomy mask ventilation. Thank you.
Thank you very much, Dr. Jyotsna. The floor is open to the questions and comments. In chat box, I don't see any questions. How about Rakesh?
So there is just one question. I think Dr. Sheila can explain about this. regarding the extubation part when she was talking about the leak test. So usually we have qualitative and quantitative leak tests. Should we perform them usually for testing the leak, or they have some limitations? So can you just, one of the, Dr. Karthik wants to know about this part.
Yeah, is this specific to the previous one, that is thyroid surgery, or generally in leak test?
I think we can take it on thyroid surgery, head and neck surgery, and thyroid surgery.
Okay, so in that previous case that was discussed, I would not perform actually a leak test, because I don't think the leak test has any value in this setting. Because when you're looking at a large thyroid and a soft thyroid, you're worried about tracheomalacia, the problem is dynamic airway collapse. And when you have dynamic airway collapse, a leak test will not help. A leak test will help if there's airway edema, laryngeal edema. So what you really need to do if you plan to, when you plan to extubate, is put a bronchoscope inside and deflate the cuff of the tube and keep on pulling it out, and keep your bronchoscope distal to the tube and observe the airway. If you're seeing any dynamic collapse, you should re-intubate the patient. And this will avoid putting a tube exchanger, extubating, and then again re-intubating. So this is a safe approach that we follow, and we usually keep these patients 24 to 48 hours post-op, and not for any edema to settle. But when you have tracheomalacia or suspecting tracheomalacia, when you have that much time, and you don't need to ventilate these patients, it helps stabilize the trachea, because the fibrosis that sets in, can stabilize this trachea and probably avoid this dynamic collapse. So that's the rationale. Yeah.
I think this is very point. Dr. Katoch also mentioned, I think, to Dr. Sheila only, that we should be looking for any nerve injury or vocal cord palsy before extubating these patients. I think this side, and this is being done very routinely. Can I have the one? Yeah.
Yeah, Professor Allen, you want to add something?
Yeah, I just want to ask the surgeon in our midst, please, if he sees much tracheomalacia in post-thyroid surgery, because as I mentioned in my talk, we're seeing very little, we're seeing a lot of big thyroids, and I wonder is it the same in your practice, or maybe they're bigger goiters? I'm not sure.
If I can answer, I presume I'm the only surgeon in the audience. It's largely historical. I totally endorse what you're saying. I mean, you see a few, I haven't seen one in more than 2 decades. And generally, if you have a trachea that's malaysic, that means it's going to collapse, re-intubating is not going to solve the problem. You have to go in and do a trach. So what we do in all these difficult thyroids is, and this is just a clue, I know you're all anesthetic surgeons, leave the strap muscles just above the trachea where you want to sight the tracheostome apart and tag it with 2 large sutures. So when you need to go in again, just open the 2 stitches between the 2 large sutures and you bang on the trachea, cut down and shove the tube in. It's faster. Sheila, I want to ask you a question in the presentation. I know I'm a co-author, but there's no conflict to ask you this question. The guidelines of a delayed extubation vis-a-vis tracheostomy, I know you said 3 times in your talk, I'm in an excellent center, high volume center. Are these guidelines or the conclusions applicable to you, or for other people like us who work out in smaller centers may not have that high-end backup?
Right. I think, sir, this is an excellent question. And this was asked by a lot of the journals to whom we sent. And they, it's not only about having done this study in a high volume center and a large number of patients. If we just looked at patients who got extubated and who got a tracheostomy, and then we looked at reasons for a tracheostomy and extubation, then it would reflect our practice. But what we have done is a very different approach. We left the decision to the surgeon, but those patients who got extubated, we looked at those which had a safe extubation, that was not having airway obstruction after an extubation. And then we did a multivariate analysis to find out which were the factors. So this would apply to any institute, anywhere in the world. The reason why we are in a better position to answer this question is because we have more and more patients in our cohort who have undergone a delayed extubation. Like I mentioned, if you've got a tracheostomy done, you'll never be able to answer that question. So we have the perfect data set to answer this question, because no patient who we extubated got reintubated. But if you ask about the applicability, I would say it's universally applicable, because we've taken a large data set of patients who got extubated safely, and then we looked at the characteristics for the safe extubation.
Sheila, may I ask you one thing? It's a fantastic study and large cohort, but many times the extubation strategy or the decisions decide upon the comorbidities also. It's not only the extension and extensive surgery versus airway compromise. Take a patient who is elderly with a post bypass with an ejection fraction of 25, and what do you do it? I mean, it's a extensive surgery versus non-extensive surgery, and I think that is a very crucial decision-making factor, I think, apart from the extensive surgery, isn't it?
Right, absolutely, absolutely. Again, there will be, this was just looking at anatomical factors, track versus endotracheal tube, but the decision to extubate, whether you want to electively ventilate, all that of course depends upon the condition of the patient, and that will of course have to be taken into consideration.
So I think one small query from Professor Allen, and Professor Anil de Cruz is also here. When we were talking about the post-thyroidectomy bleed, you talk about the box, the surgical box needs to be kept in the with the patient in the post-operative area. So I think whom should we train for? Is it for anesthesiologists, or we need to have call for surgeon to be trained? As we are talking about the surgical access, we say that everybody should be trained for surgical access. So do you think that surgical box should be applicable for critical care people taking care in the ICU or the post-recovery area also?
Yes, I think that's the point, that this can happen in the recovery room where we were. We had the whole team there. We had the anesthetic nurses in our simulation. We had the ward staff, because we've had one morbidity, severe morbidity with a thyroid about 2 years ago now in our hospital on the ward, 24 hours later. Again, what happened was a more junior ENT staff were called. They didn't evacuate the wound, and by the time the patient became stridorous and then arrested, there was a junior anesthetist and a very junior ENT surgeon. So I think we stress the fact that you call senior people, but also the nurses hadn't observed the patient correctly, because this was gradually evolving. So I think you need to teach the ward staff, the ITU, and the recovery staff as well.
Thank you so much. Thank you. So I think I would request Dr. Anil de Cruz to give a concluding remark. We are with time. So, sir, Professor Anil de Cruz, to give a concluding remark, please.
Thank you.
Time, actually, we have about 8 minutes for questions. If
oh, we do. The clock on the screen showed us like we had time up. Anyway, then we'll open it for some more questions on tracheostomy to Jyotsna. Anybody? What happens to the delegates? Do they type on the same chat box, Sheila, or is it only among?
Yes.
It is coming in the same chat box.
Same chat box.
Okay, I don't see any questions.
So there is one query for Dr. Jyotsna. Sometimes we do a fresh tracheostomy or maybe an emergency cricothyrotomy for these patients. Sometimes there is an risk of getting an accidental removal of these tubes. So can you, with your experience, what all precautions, because reinserting the tube into a fresh tracheostomy stoma is always difficult because false track, bleeding, and so on and so forth. So what suggestion, Dr. Jyotsna, you want to give so that once the tube is not accidentally removed, and what all precautions should we take while reinserting these tubes in the fresh stoma?
Yeah, in fresh stoma is always a very risky procedure to reinsert the tube. It's better to take the prevention, so proper securing the tube. While securing is stay sutures, they always is better. That's a stay sutures, and also the string tape around the neck. So if those things can help in securing the tube properly. And but if it happens, it's really a problem. In that case, we need a expert for senior people or surgical help. We need to that time to put the tube back into the tube system.
So if I can just elaborate on the point that I totally agree with what Jyotsna said, but this is a head and neck session, and anesthetist, whenever you'll put a tube in, don't put those tapes, because sometimes you strangulate the pedicle and our flaps go. So you have to know if that pedicle is coming in the way of the tape.
Yeah.
But But taking sutures has a downside as well. Sometimes you stitch the tube so securely to the skin. If it gets blocked, it's disastrous. It's so difficult to remove it. So you really have to have a fine balance between safety and strangulating the pedicle. Maybe to Elaine and Jyotsna and Sheila as well, whenever you have complications and you have to rush a thyroid back into the OR, these are difficult thyroids. You have problems then to intubate. You may have cord vocal, that's the recurrent nerve damage. Very often, the parathyroids are gone in these patients, and you may sometimes have, severe hypocalcemia in some of these patients. Any precautions? Do you all screen for this before you rush the patient in? What kind of thing do you do for these other comorbidities which are surgically induced, and then you have to go in as an emergency?
Yeah. Well, we do calciums in recovery, in all our thyroid patients. So we should have that result. We know if they're hypothyroid. The surgeons, we monitor, they're paranoid about monitoring the recurrent laryngeal nerve. So we don't, we have full relaxed patients intraoperatively. So the surgeons are always almost certain they haven't damaged the nerve, but equally there can be neuropraxia, obviously. But they are very difficult, particularly if they're bleeding, they are very difficult reintubations, and there is a lot of backward edema. And we tend to do RSI, rapid sequence intubation. Difficult to do fiber optic on these patients because they're usually deteriorating very quickly. And we also have my ET surgeons, and I'm sure you're the same, they are very good at rigid bronchoscopies. And my plan B is sometimes, give them an RSI. If we struggle, they would do a rigid bronchoscopy because that'll push the edema out of the way a little bit. And I'm sure we're lucky that we do have surgeons who are expert at a rigid bronchoscopy, and they have occasionally helped us out, because a laryngeal mask in a patient with a lot of edema, if they have a huge bleed, they don't really work. They don't work very well. And then, as you say, you can open the wound, and then you can do a tracheostomy very quickly if you want to as well. But we try and avoid that. We usually try and intubate, and then they resolve the problem.
I'd just like to add that excellent presentation, Ellen, and I think that's a great idea to have this kind of box ready after thyroid surgery. I think that's great. Your guidelines have talked about it. We don't really keep a box, but our trainees know that post-thyroid surgery, if you have these kind of symptoms that you mentioned, or any neck swelling and there is airway compromise, the first thing that they do is open the incision or take out the staples, because that's very important. Another word of caution, because it's a venous system, a very low compliance system, you will see laryngeal edema. And when you're going into reintubate, visualization of the cords is not difficult with a video laryngoscope, but there you need a smaller size tube. And a lot of time people keep the same size tube as they use for the primary initial surgery. And this is something that you have to be very careful about. And about the calcium that you mentioned, a discussion with the surgeon is very important. In our setting, usually post-operatively, it is, calcium supplementation is given. But yes, we do monitor the levels of these patients. And one more point about the, tracheomalacia that you mentioned, we get one-off case in a year, when we have very big thyroids coming from remote locations, very advanced disease. So it's a rare thing that we see. But if you have this kind of setting, it's very useful to have a conversation with the surgeon, because they tell you the thyroid, it's very soft, and they will also communicate with you. Like you mentioned, there could be neuropraxia, even though we're using neuromonitoring during these cases using big thyroids and, even redo surgeries. So I think this dialogue it really is very helpful, especially when you're doing such complex cases.
So we have one comment from Professor Divitya. I'll request him to unmute and speak, please.
Yeah, Rakesh, thank you. So just a couple of quick comments. One is on the reintubation, or when the tracheostomy tube pops out after a fresh tracheostomy. I remember as residents, we used to always be told that one is you must be ready to reintubate if it's possible. And if you want to try and put the tracheostomy tube back, do it in the same position as in which the tracheostomy was done. So put the bolster under the shoulder and extend the neck and do that. Otherwise, it's almost impossible to be able to align your hole in the skin and the tissues with that in the trachea. So I think it's always tricky to put the tube back and you'll get into a false passage and all that kind of stuff. The second is, if you're going to intubate someone with a thyroid hematoma, I would suggest that you don't do it unless the wound has been opened and the hematoma has been let out and released. And if it's, especially if it's a huge hematoma, we actually had that case for the case discussion, but we ran out of time. Especially if it's a big hematoma, you might find even the swelling on the neck, it's difficult to hold the mask and ventilate the patient. And you need to let the hematoma out. And like Dr. Tikku said, get the surgeons to take the hematoma out and be on the trachea, and then you attempt to intubate, maybe with or without some sedation or propofol or whatever it may be. But unless you do that, it really helps if you let the hematoma out.
Yeah, that's a very good point. And I had this discussion with one of my head and neck surgeons who does, I think he does 300 thyroids a year. He's kind of the expert on thyroids. He wasn't sure about that. He said he had one immediate bleed in recovery, I think, where it was an arterial bleed. And he said the anesthetist wasn't happy to intubate. He thought he was told take down the thing. And when he took the sutures out, it absolutely, he said he got 2 liters in the floor without blinking. Then the anesthetist was trying to intubate, and then he was trying to take control. He actually would have said, because it was an early bleed, and he said there was probably very little edema at the time. I think it was in recovery, in fact, and I don't know what the RENT expert says, but he said in that situation, I would have preferred a reintubation. And when they did reintubate, it was easy because there wasn't enough time for edema and swelling to. He wanted that patient intubated, and then he could control, because he was trying to stop a bleeding. He couldn't find the vessel with the blood, so he wanted the patient intubation controlled, and then he managed to get the artery. So he was in disagreement with our guidelines on that. And this was only in the last week or two we had this conversation. So it's interesting, isn't it? I suppose it's only if it's an arterial rather than a slow venous ooze, as opposed to, which happens over 12 hours, maybe, and there's a lot of edema. So I don't know what Anil de Cruz would say about that. Yeah.
I was going to make exactly the point you said. To see a hematoma that's extending from the skull base down into the mediastinum, the ward nurse has not done a job and should be given marching orders. It's very rare, unless it's an arterial hematoma. And if you open that arterial bleed, it'll bleed like hell, and absolutely the what you said, 2 liters on the floor in a minute, and you don't have a intubated patient, you don't have an anesthetist. How are you going to manage this patient? So I think first distinguish between an arterial and a venous, and then take a call. It's very theoretical. I've not seen these kind of bleeds in years. I mean, I've just not seen it in years.
We were waiting for you to leave the hospital.
Maybe you can give your surgeon. Say that again.
We were waiting for you to leave the hospital. We saw it last month.
Yeah, but I promise you, I didn't take the cauteries away. I didn't take the cautery away with me. But Jiggy, the tip is to tell the youngsters not to close the neck too tightly. If you close the straps too tightly, then that hematoma is going to push onto the airway and cause it. In fact, sometimes it's good because it forms a tamponade and it doesn't give you that ghastly big bleed because it's there. And the trachea, it's got its integrity. It's not going to collapse. These were things in the 50s and 40s and 30s. I don't know. We hardly see these things anymore. But anyway, the point's well taken. I think we're shooting over time. Great presentations, all three of them. And I guess the message that I would give, all three are topics dear to my heart as a head and neck surgeon. All three are very important to us as a head and neck surgeon. But the message is be safe, be prepared. You can have your box. It's not only, Elaine, on your talk that we need the box, but we need the box for Jyotsna as well, for a tracheostomy that may get dislodged. You should be prepared at all times. You don't go hunting for a tracheostomy set after the tube's out. And exactly the same for Sheila's delayed extubation. So I think I'm going to end by saying, keep your boxes ready, at all times. Be prepared. That's the important message. High degree of alertness, caution, because you need to go in and you need to go in very quickly. And for Jiggy, the message is operate with safe thyroid surgeons. If you're seeing these big hematomas, skull base down, I'm sending you my business card. You know where to get me for safe thyroid surgery. Thank you so much. It was a pleasure being on this
Thank
panel.
you.
Thank you.
Pleasure
Thank
meeting
you,
you.
sir.
Thank you.
Thank you, sir.
Thank you.
Thank you very
everybody.
much. Thank you,
Thank you,
everybody.
everybody. Thank you, everybody. Thanks. We'll move to the next session now.
Welcome, everybody. We move to the next session on airway management in the critically ill patient. And I'm very happy to welcome my co-chairs. Dr. Rakesh Garg is over here already. And we have Dr. Neeta Bose. Dr. Neeta Bose is here. And Dr. Rakesh is, of course, from AIMS, New Delhi. And Dr. Neeta Bose is from Vadodara, the Government Medical College. And I welcome her. And we have a very interesting session that is planned today on airway management in the critically ill. And we have some very good speakers who are lined up for this session. We have some landmark papers that were published this year also going to be presented. We have the Intube study. We also have the stiletto trial that is going to be presented, and 2 other papers that are related to tracheal intubation in the intensive care unit. And I will start with the first speaker, Professor Vincenzo Risotto, who's going to be speaking on critical airways, critical patients, critical airways, and he's going to present the results of the Intube study. I was very fortunate to be a part of this paper along with him. Over to you, Professor Vincenzo, to speak about critical patients, critical airways.
Thank you for this presentation and for the invitation to this nice meeting. My talk is on airway management in critically ill patients. I have no conflict of interest to declare. Tracheal intubation in critical ill patients is associated with a higher risk of adverse events compared to the anesthesia setting due to a number of reasons, such as underlying hypoxemia, shock, metabolic acidosis, a higher risk of aspiration of gastric contents, but also operator experience and equipment availability may play a major role. Until now, the evidence on pain intubation adverse events was available from single center studies or national level studies, and this is probably the most relevant report of airway-related complications, the National Audit Project 4 published 10 years ago in UK, which for the first time highlighted how airway management may be associated with a high morbidity and mortality. And another important observation is that when a complication occurs in the ICU patients, this is associated with a much higher risk of deaths or brain damage compared to the operating room. So we wanted to measure what happens around the globe because we consider it relevant in order to plan future studies or identify research priorities of intervention to mitigate these peri-intubation risks. And this is the rationale behind the Intube study that we published in March of this year in JAMA. The Intube study was an international prospective observational study that we completed by the end of July 2019, so before the COVID-19 pandemic. We involved almost 200 sites around the globe, and this is a major value of this study because for the first time we take a picture of what happens around the globe. We included adult critically ill patients undergoing intubation in hospital intubation, and we excluded those patients without hospital tracheal intubation or those patients intubated for the only purpose of general anesthesia or under cardiac arrest. We had a really important success for this study, and this was possible also thanks to the enrollment of many scientific societies that endorsed the study, including the Indian Society of Critical Care Medicine. The primary outcome of the study was a composite outcome. So one of these 3 events occurring by 30 minutes from the start of the tracheal intubation procedure. These are the most commonly observed and reported events in critical care, such as severe hypoxemia, SpO2 below 80%, cardiac arrest, and cardiovascular instability. But we also collected relevant information on secondary outcomes, such as ICU mortality, or the incidence of pulmonary aspiration of gastric contents, or airway injuries, which are also relevant outcomes. By the end of our study, we enrolled almost 3,000 patients that we follow up until ICU discharge. And these are the baseline characteristics of our cohort. We had a patient with a median SOFA score of 7, so quite critical in population, with an SpO2 to FeO2 ratio 165, so hypoxic, while the hemodynamic variables, as you can see here on systolic blood pressure, were quite within normal range, and this is an important information that deserves further discussion in light of our results. According to the place of intubation, the most common place of intubation was the ICU in almost 70% of our procedure, and the reason for intubation was respiratory failure in more than half patients, followed by neurological impairment, 30% of patients, and cardiovascular instability, 9% of patients. This is the primary outcome of our study. So the first important information is that in 45% of our cohort, at least one major event occurred, and this is the first relevant information. So peri-intubation adverse events are common in critical care. But the second important information is that if we look at the type of complication, the most important one is the cardiovascular instability occurring in almost 43% of patients, followed by severe hypoxemia in 9% of patients and cardiac arrest in 3% of patients. Looking at secondary outcomes, esophageal intubation was observed in almost 6% of patients, difficult intubation that we define as more than 2 attempts required to achieve success of intubation, 5% of patients, and the aspiration of gastric contents occurred in almost 4% of patients. An important information of our study is that if you fail the first attempt of intubation, the risk of complication increases from the second attempt. And this is true for the overall major complication, but also for the single outcome of cardiac arrest and severe hypoxemia. And of notice, we have a first pass success rate of 80% in our cohort. Another important information is that if a patient experiences a peri-intubation adverse events, he or she is at increased risk of both ICU and 28-day mortality. And this is a major outcome of our study. And this is again true not only for the major composite outcome, but also for the single outcome of cardiovascular instability and cardiac arrest. While this association was not reported for the outcome of severe hypoxemia. For sure, this is an observational study and many confounders may play a role, but if we perform an adjustment for underlying patient severities or comorbidities, we still observe an increased 28-day mortality in those patients with the peri-intubation adverse events with an odds ratio of 1.44 compared to those patients without peri-intubation adverse events. In this table, we describe the factors associated with adverse events during the peri-intubation period. For sure, we have patients-related variables such as older age or the presence of heart failure or hematologic malignancy. So these are non-modifiable variables, but we have many variables such as the hemodynamic parameters that maybe can be improved before intubation in order to reduce the peri-intubation risks. we observed a signal of increased risk of complication with the use of video laryngoscopy with the administration of a fluid bolus before tracheal intubation. An increased risk was observed in the hypoxic patient. But instead, if you have a success at the first attempt of intubation, the risk of complication is reduced instead of having more than one attempt. These are the factors associated with the first pass intubation failure. And for sure, we have the well-known variable that are associated with the difficult anatomy of airway management, such as the Mallampati score, reduced mouth opening, neck stiffness, the presence of bird, or the risk of aspiration, but also the past surgery or radiotherapy of the neck. While the use of a video laryngoscopy, as you can see here, with a lower odds ratio, was associated with the first pass success. Also, patient operator characteristics may play a role, because if a consultant compared to a resident perform the intubation, probably the success is higher. And also the field of training may play a role, because if an operator has an anesthesiologist background compared to other field of training that are involved in airway management around the globe, the possibility of success is higher. We also collected relevant intubation on the procedure, which are still important also to observe what is the real practice around the globe. For example, the pre-oxygenation method, it is quite interesting to observe that the leading pre-oxygenation methods today is the Bag valve mask, observed in 62% of patients, while other methods such as non-invasive ventilation, high-flow nasal cannula, or CPAP, as you can see from these numbers, are seldom used in real life. Another important information comes from the induction agent, because as you can see here, the leading agent that is used for induction of critical ill patients is propofol, which has been used in approximately 40% of patients, while other agents such as etomidate or ketamine, which probably have a more friendly hemodynamic profile, are seldom used in real practice. Another interesting findings comes from the observation of the video laryngoscopy use, because in only 17% of patients, the video laryngoscopy was the elective, let's say, methods of intubation, and in most cases, difficult anatomy was present. So this is not a device that is today routinely used in the ICU. But what is probably the most impressive finding comes from the methods to confirm intubation, and so the monitoring applied during intubation, because in only 25% of patients, the success of intubation was confirmed by wave of capnography. And this is quite impressive information, because we know that from the National Audit Project 4 that the misinterpretation or the lack of use of capnography was associated with the higher risk of complication and adverse events in the ICU. If we look at the place of intubation, for sure, in the ICU, we have a higher use, but 40% of all procedure, but this number are still in any case well below what we consider the standard of care. And also in the emergency department, we have a really poor use of capnography, as you can see from these numbers. So why capnography is so underused and why the clinicians fail to implement the safety measure? We ask this and try to provide an answer in this nice editorial that we published a couple of weeks ago with Tim Cook in BJA. The answer is probably complex, and many factors may play a role. In some hospital, it is simply a reason of equipment in unavailability that is the main reasons for capnography underuse. But probably it is still important other factors such as the identification of capnography such as a priority of the intubation bundle, and this may not always happen in real life. And also many clinicians still have an inappropriate reliance on clinical signs such as auscultation to confirm the success of intubation. But we know from literature that this is not true, and especially in critical care. So we have an ideal world coming from the evidence that is incorporated in guidelines, and what is instead the real world practice that is illustrated by our study. Another important, interesting finding is that we have a patient that need intubation, which have a poor oxygenation in many cases, but also a poor hemodynamic, and hypoxemia and hemodynamic impairment have a major role on perintubation adverse events. But during the perintubation period, we apply positive pressure ventilation, we administer induction agent, and probably in case of prolonged intubation attempt, the development of hypoxemia also occurs. So at the end, we have a worsening hypoxemia and a worsened hemodynamic that is behind the high risk of adverse events that we register in critical care. But while in the peri-oxygenation period, we have already different trials that investigated which methods is the best solution to optimize perintubation oxygenation in the hypoxic population. The intervention on the hemodynamic counterpart of the problem are really few. And this is the only trial that has been published today, the prepared trial that investigated the use of a crystalloid bolus in critically ill patients undergoing intubation. And as you can see here, the authors did not find any difference between those patients randomized to a crystalloid bolus compared to patients not receiving any bolus before intubation. And the trial was unfortunately interrupted for futility. But if we look in this sub-analysis on the pre-oxygenation methods, for example, in those patients receiving a positive pressure ventilation, probably there is a benefit of fluids, as you can see here. And this is what is the authors are investigating in the prepared 2 trial, which is trying to provide this answer, the use of a bolus of crystalloids in those patients receiving positive pressure ventilation. So in conclusion, major perintubation adverse events occur frequently in critically ill patients in 45% of our cohort. The hemodynamic collapse is by far the leading complication that occurs during the intubation of critically ill patients, 43% of patients. So the hemodynamic optimization should represent the focus of our intervention, both at the bedside, but also in our research agenda in order to mitigate these numbers. Thank you.
Thank you very much, Professor Vincenzo Risotto, for this excellent presentation. I would like to invite my other 2 co-chairs as well for this session, Professor Mrityunjay Kumar from All India Institute of Medical Sciences, New Delhi, and Professor Moeed Ahmed from Aligarh Muslim University in Aligarh. Professor Moeed, please go ahead with the session.
Good afternoon to all of you. Welcome back to this session, and it's on critical care session. My next speaker will be Dr. Kunal Karamchandani, and he will be speaking on airway management outside the OR, and he is an associate professor, and he's affiliated to the University of Texas Southwestern Medical Center. I welcome Dr. Chandlani, please.
Good evening, everybody, and a warm greetings from Dallas, Texas, USA. I would like to thank the organizers for this opportunity. And as part of the session, I would be talking about emergency airway management outside the operating room. I have no disclosures and no conflicts of interest. As part of the talk, I would be discussing the various challenges that we face as we go about managing these emergent out-of-OR airways. We'll move on and talk about how we can best optimize outcomes in this at-risk population. Specifically, we'll talk about patient positioning. We'll talk about pre-oxygenation. We'll talk about personnel and device selection, hemodynamic optimization, as well as pharmacologic management. Now, we could be asked to manage these airways at multiple locations. It could be the intensive care unit where the patients are critically ill with poor physiologic reserve. It could be the emergency department where we could be the first responders to the airway, or we could be a backup for the ED providers in case they fail to secure the airway. It could be the regular nursing floor or ward. It could be the radiology suite or the endoscopy suite, especially in hospitals where anesthesia is not involved in the endoscopy procedures. Now, these emergent out-of-OR airways are considered a very high-risk procedure. In fact, they have a 1 in 40 rate of cardiac arrest and a significantly high risk of both in-hospital and 28-day mortality. In fact, the number of attempts that we take to secure the airway is directly proportional to the morbidity and mortality associated with the procedure. In a recent study, which kind of looked at about 3,000 patients from 197 sites across 29 countries, the authors found that almost 45% of the patients who underwent this procedure had some kind of a complication. The most common complication that they found was cardiovascular instability. They estimated that the overall mortality rate with this procedure was about 33%. Now, as we go about managing these airways, we're faced with multiple challenges. We could be dealing with anatomical challenges, physiological challenges, or logistical challenges. And let's talk briefly about each one of them. When we talk about anatomic challenges, we have to be very careful. Now, the incidence of anatomically difficult airway in these situations has been found to be as high as about 50%. In fact, the same airway management is more difficult in an out-of-OR scenario versus in the OR for the same patient. This was shown in a study which was published in Anesthesiology, where the authors looked at about 200 patients who underwent direct laryngoscopy in the OR and were subsequently intubated in the ICU within the next month. What they found was that the ICU intubation was associated with a worse clotting view, lower first-time intubation success rate, and they found that the complications were much more common. Now, airway assessment can be pretty tricky in these circumstances, and sometimes they're not even possible because of lack of time or if the patient is uncooperative due to encephalopathy, delirium, and so on. Now, along with that, the various bedside screening tests that we have a poor sensitivity and specificity in these situations. There probably is a potential for artificial intelligence-based automatic face analysis approach to overcome some of these shortcomings. Moving on to the physiologic challenges that we face. Now, a lot of these patients tend to have a physiologically difficult airway, wherein the physiologic derangements that the patient has places the patient at a high risk of cardiovascular collapse with intubation and conversion to positive pressure ventilation. So essentially, even if you're able to place the tube past the cords, you still might have a bad outcome. Now, here are some of the situations where you might end up with complications because of a physiologically difficult airway. Patients who are severely hypoxemic, significant hypotension, patient with severe metabolic acidosis, right ventricular failure, those who have a full stomach or significant gastroesophageal reflux disease, patients with neurological injury or raised ICP, and those with an anterior mediastinal mass. Now, along with the anatomic and physiologic challenges, I think we also have to take into account the various logistical challenges that we face in these uncomfortable and often unknown circumstances that we lend ourselves into. Now, infrastructure-related challenges are common. Often these spaces are pretty congested. There's so many people in there, there's barely any place to stand. Now, you might have limited access to the airway, and monitoring is often inadequate. We might be limited by the equipment that's available to us. For example, additional airway equipment may not be there. Oxygen delivery equipment in the form of high flow nasal oxygen, non-invasive ventilation may not be readily available. Similarly, we are also challenged with the personnel. They may have limited training. They're all operating under a lot of stress. Inadequate communication, fixation errors are pretty common in these situations, and we have to be very careful about them. So in a sense, in order to counter all these challenges, it is extremely important that we prepare and plan as we go about managing these airways. Now, here's a nice, graphic that I found in one of the reviews that was published recently in Canadian Journal of Anesthesia, where the authors kind of enlist all the preparatory methods that we can undertake before we go about managing these airways. So the next question is, how do we optimize ourselves and the patient for success? What are the steps we can take to improve the outcomes in these unfavorable situations? So let's talk about patient positioning first. Now, it's extremely important that the patient positioning helps us optimize both anatomic and physiologic parameters. Now, the options that we have are the sniffing position and the ramp position. As we all know, with the sniffing position, we're able to better align the oropharyngeal and laryngeal axis, which makes the glottic visualization much easier. Hence, for an anatomically difficult airway, this might be a preferred mode. With ramp position, we improve our pre-oxygenation, we reduce the risk of pulmonary aspiration, and this may be a better position for physiologic optimization. Now, let's look at a few studies that have compared these two positions. So this was a study that was done in a MICU with pulmonary and critical care fellows, where they compared ramp position with sniffing position in about 260 critically ill adults. What they found was that they did not see any improvement in oxygenation with the ramp position. In fact, they found that the ramp position was actually associated with a worse glottic view and increase in the number of laryngoscopy attempts. Now, in another study, this time this looked at ED scenarios. So there were ED residents who were involved in this study. Again, they were looking at first pass success rate in various positions, supine versus incline versus upright. And what they found was that there was a significant difference in the first pass success rate between the supine position and the upright position. In fact, they said that there was an increased likelihood of first pass success for every 5 degrees increase in angle. So what we can say about patient positioning is that it should be individually tailored to each and every patient's characteristic, as well as the training history of the intubating provider. If we feel like the anatomic challenges are the ones that are more likely to have issues for us, I think a sniff position or a sniffing position is more appropriate. Whereas if we feel like the physiological challenges are the ones which are more overpowering, then I think a ramp position may be a better position. Now let's talk about oxygenation. Most of these patients have hypoxemic respiratory failure. They have low physiologic reserve, extensive atelectasis, and a lot of intrapulmonary shunting. So in these patients, pre-oxygenation is extremely important. It increases your safe apnea time. Now, there are various modalities by which we can provide the supplemental oxygen. Now, nasal cannula or non-rebreather masks are often ineffective because they're unable to meet the high inspiratory flow requirements that these patients often have. So we're limited to our choice between non-invasive ventilation and high flow nasal oxygenation. Now, let's look at some data. So this was the Florali-2 trial that was conducted in France, about 28 ICUs, a multi-center open label trial where the authors compared non-invasive ventilation versus high flow nasal oxygenation during pre-oxygenation in adult patients who had acute hypoxemic respiratory failure with a P/F ratio of less than 300. Now, what they found was that there was no difference in severe hypoxemia during the procedure. However, when they looked at patients who had severe hypoxemia, in the sense that their P/F ratio was less than equal to 200 millimeters of mercury, they found that non-invasive ventilation was slightly better. So what we can say about pre-oxygenation is that non-invasive ventilation or high flow nasal oxygen are better as compared to the conventional oxygen therapy. If you have a patient who has moderate to severe hypoxemia, non-invasive ventilation may be better than high flow nasal oxygenation. And we shouldn't forget that apneic oxygenation should be continued during every attempt at intubation as far as practically possible. The other question that comes up is, who should be doing these intubations? Now, in the United States, there's a lot of specialties that are involved with airway management. It could be the emergency department, it could be the pulmonary and critical care fellows, it could be anesthesiologists, and so on. Now, without getting into the politics of it, I think it is universally accepted that there should be a dedicated airway team for these out-of-OR emergent airways. Providers should be proficient in airway management. Now, that's another controversial and debatable topic as to whom should we consider as proficient. Anyways, that's a discussion in itself. We'll leave it for another day. Now, some people recommend that there should be 2 operators doing all these airways as part of an intubation bundle. Now, another question that often comes up is whether we should have the most experienced provider do this intubation, or should we have the trainees take an attempt at that? I think this should be patient specific, and this should depend on the level of training of the trainee that's available to you. And again, it should be related to a specific situation and circumstance. The other question that often comes up is, what should be used to secure this airway, right? And another controversial topic is video laryngoscopy versus direct laryngoscopy. We all know that video laryngoscopy gives you a much better view, but there's always a difficulty in negotiating the endotracheal tube past the vocal cords. It does have an easier learning curve. On the other hand, direct laryngoscopy needs proper alignment of all the axes in order for successful placement of the breathing tube. It has a steep learning curve. Now let's look at a few meta-analyses to see what they show. Now, this was a systematic review and meta-analysis that came out in BJA in 2018, where the authors included about 32 studies with 15,000 emergency intubations. What they found was when they compared VL versus DL, there was no overall difference in first pass success. What they found on subgroup analysis was that video laryngoscopy may be better when emergency intubations are performed in the ICU or in the hands of less experienced providers. Now, another meta-analysis that came out around the same time, which was published in Critical Care, included about 9 RCTs and about 2,000 patients. What they found was that video laryngoscopy did not shorten the time to intubation, nor the first pass success rate. And again, this was irrespective of the experience of the operators, the setting, whether it was the ICU or the ED, or in fact, the model of video laryngoscope used, whether it was the hyperangulated blade or the non-hyperangulated blade. So again, talking about this VL versus DL debate, I don't think the answer is available yet. It should depend on the provider's preference and competence. And in all these situations, both video laryngoscope and direct laryngoscope should be available. Now, there are certain situations, for example, special pathogens such as the COVID airway, where probably video laryngoscope is slightly better as you're further away from the field and your chances of getting aerosolized particles on yourself is much lower. The other part to this is the hemodynamics. Now, as we have seen before, that hypotension and cardiovascular collapse are probably the most common complications that are associated with this procedure and are linked to a lot of morbidity and mortality. Now, we do have a lot of ways by which we can counter the changes in hemodynamics that happen. We could provide some fluid loading, push dose pressors, pressor or inotropic infusion, and so on. But again, I feel like this should be tailored to each individual patient and scenario. And there, I think there is a definite role of point of care ultrasound. Before we embark into these airway, it's about, get 2 or 3 views with your focus machine, see if they're fluid responsive. If they are, you can give them some volume before we embark on this procedure. And you look at their myocardial function. If you feel like they need some inotropic help, you can start that inotropic infusion before we go into airway management. So these are things I feel like should be individualized to each patient. Now, the last topic that we're going to cover is the drugs or the pharmacologic management for these patients. And we can broadly divide that into induction agents and paralytic agents. Now, we have a few induction agents that are available to us: propofol, etomidate, ketamine, and the new kids on the block, the ketofol and the propodate. Now, again, it all depends on what your patient's hemodynamics are. Again, be careful about using propofol in these patients. But as I said, it should be based on each individual scenario. Now, the other debate which we get into is whether we need to paralyze the patient or not. Again, there are only specific circumstances and situations where spontaneous ventilation helps. For example, someone with an anterior mediastinal mass. But in all other situations, I think paralysis improves our ventilation and it makes our job much easier. Now, when we talk about paralysis, we again have 2 options. We have the depolarizing neuromuscular blockers and the non-depolarizing neuromuscular blockers. Again, I think it would probably depend on the availability of Sugamadex and the presence of contraindications to use of succinylcholine in each of these situations, which would then lead you to use the muscle relaxant, which is appropriate for that condition. Now, it is very essential that you have rescue plans. You need to have a plan A, B, and C, because often these airways do not go in the direction that you want them to go. So here's a flow chart that we recently published in ANA, which kind of brings everything together about how we should go about managing an emergency out of OR airway. So in conclusion, out of OR emergent airways are associated with significant complications, which are associated again with high morbidity and mortality. We face anatomic, physiologic, and logistical challenges as we go about managing these airways. And it is very important to plan and prepare before we embark on these airways. On that note, I would like to thank you for your time, and I'll take questions at the end of the session. Thank you again.
Thank you, Dr. Kunal. Dr. Kunal is an old associate, and it was so nice to have you here. Our next speaker, she is Dr. Audrey De Jong, and she is going to talk about the Stillet trial. Dr. Audrey is from the University Hospital, France, and she's her areas of interest are airway and obstruction, and she's going to talk about Stillet trial, and which is a comparison of multicentric trial involving intubation in emergency scenario with tube and with the help versus with the help of Stillet. Over to you, Dr. Audrey.
Hello, everybody. I'm Dr. Audrey De Jong. I work in the south of France, and I have a topic of airway management. I work with Professor Samir Jaber, who is my head of department. And I'm very, very glad to be here and thank the organizing committee for the invitation. Thank you to Professor Sheila Mayatra, to Professor Sumalata Shetty, to Dr. Rakesh Kumar and Professor Pradeep Besha for the invitation. It's a real honor. I have no conflict of interest related to this talk. And why are we talking of challenging topic of intubation in ICU? because the incidence of cardiac arrest during intubation in ICU is quite high, around 2.7%. And the overall complication of intubation in ICU are also high, with severe hypoxemia or severe collapse occurring in half of intubation in ICU. We had identified the baseline characteristic associated with cardiac arrest in ICU, but also factors that can be avoided as arterial hypotension, hypoxemia, or absence of pre-oxygenation. Difficult intubation is especially challenging in ICU and associated with complications related to intubation. We identified the Mark-Ocha score, which was a score composed of 7 points, factors related to patient, 4 points, factors related to disease, 2 points, and factors related to operators. Finally, what is difficult intubation? It is failure of first attempt intubation. And first attempt failure is associated with higher complication related to intubation in the intensive care unit. We show recently in Intensive Care Medicine Journal that more the attempts, 1, 2, 3, 4 attempts, more the number of attempts, more the rate of hypoxemia was elevated. As you can see here, at one attempt, you had almost 20% of hypoxemia during intubation procedure. And when using 4 attempts or more, you had more than 50% of hypoxemia. So first attempt success is a good endpoint for assessing the usefulness of a device to prevent difficult intubation and associate complication related to intubation as hypoxemia. That was we choose this first attempt success as the primary endpoint in the Stiletto trial. In the Stiletto trial, to further improve the intubation procedure, we decided to study the stylet. The stylet, the malleable stylet that we introduce in the tracheal tube, as you can see in the picture. There was no recommendation about the use of a stylet for the first attempt intubation. In the last American recommendation, it was reserved to difficult intubation, and also in the French recommendation for intubation in ICU, its rule was not very clear between patients not predicted difficult to intubate with a Mark-Ocha score less than 3, and patients with difficult predicted intubation with Mark-Ocha score more than 3. The use of a malleable intubation stylet was left to the discretion of the operator. Indeed, when we looked the comparison endotracheal tube plus stylet and endotracheal tube alone, we saw that there were no studies until the Stiletto trial in the ICU. No study, so no data. The stylet had some potential advantages. It is a rigid malleable introducer which fits inside the endotracheal tube and allows for manipulation of the tube shape and can facilitate the passage of the tube through the laryngeal inlet. There are also side effects that can be associated with stylet as perforation, sore throat, or mucosal bleeding. So should we use a stylet for first attempt intubation in the ICU? The main objective of the Stiletto trial was to determine whether a stylet introduced in the endotracheal tube increased first attempt success during intubation procedure over endotracheal tube alone in ICU patients. The main hypothesis was that yes, the stylet introduced into the tracheal tube increased first attempt success compared to endotracheal tube alone. The study design. we included all patients who needed invasive mechanical ventilation. Then we randomized the patient into two groups, endotracheal tube alone and stele introduced in the endotracheal tube alone. We performed the standard pre-oxygenation, and then we had the primary endpoint just after the intubation, as it was first attempt success during intubation procedure. The main secondary endpoint was recording during the hour following intubation, severe and moderate adverse events related to intubation. And then we had other secondary endpoints and outcome endpoints until 90 days of follow-up. During all the intubation procedure, the operators were advised to follow the update of the Montpellier intubation protocol. Briefly, this protocol included pre-intubation, 2 operators, a fluid loading and an introduction of early vasopressor, and an accurate pre-oxygenation. Then per-intubation, a use of rapid seconds induction, and then post-intubation, the use of capnography and of low airway pressure ventilation. We also advise the operators to follow the good practice of stele tubes. First, we take an usual tracheal tube. Then the operators had to lubricate the stele with a lubricating spray to help the insertion and removal of the stele. Then the operators had to insert the stele into the tracheal tube and manipulate the tube shape, usually into a hockey stick shape, to facilitate passage of the tube. After they checked that the stele was not out of the tracheal tube to avoid laryngeal trauma, and then when entering the tube into the trachea, they were advised to remove the stele when the tracheal tube is just in front of the glottis to avoid also tracheal trauma. The sample size needed to show a difference in first attempt success of 10% from 17% to 80%, with an alpha risk of 5% and a beta risk of 95%, was 140 patients. As you can see, we chose to include more than the sample size needed, 970 patients, to anticipate loss of data. That was, we chose to include 1,040 patients. Finally, we had the patient analyzable in less than 1,000 of cases, and we include 199 patients. So it is the largest study performed in the field of intubation in ICU, the largest randomized control trial, with almost 500 patients randomized in each group. 33 centers participate to the study. There were French centers and also a patient from Caribbean French islands. What was the main result, the main outcome? As you can see here, you have in blue the patient who received tracheal tube plus stele, and in orange, the patient who received tracheal tube alone. The patient who received tracheal tube plus stele had a significant higher first attempt intubation success rate than the patient who received tracheal tube alone. However, there were no difference in complications related to intubation. Regarding the forest plot, who compared the first attempt success rate in several predefined subgroups, there were overall an efficacy of the tracheal tube plus stele in improving the first attempt success rate. And as you can see, this result was found in all the subgroups analyzed. So there was a consistency of effect. The results were also confirmed after multivariate analysis although the groups were already well balanced after randomization, as we included 500 patients in each group. To conclude, what is the effect of the use of an endotracheal tube and stele versus an endotracheal tube alone on first attempt intubation success? We had presented here the result of a multi-center randomized clinical trial, the largest in the field, performed in 999 patients. The study design was nicely summarized by the Intensive Care Medicine Editorial Office. Here, tracheal tube only group, and here, tracheal tube plus stele group. A very simple comparison. The main result, or the main endpoint, was that first attempt intubation success was increased in the group with endotracheal tube plus stele. There were an absolute risk difference of 6.7%. However, there were no difference in complications related to tracheal intubation, and there were also no difference, which is reassuring, in serious adverse events related to tracheal intubation, as tracheal trauma, for example, as you can see, 4 versus 3.6% of patients. So I thank you very much for your attention, and I think more than everybody, and the Professor Samir Jaber, which was at the beginning of the study, and who did the major of the work during all the trial to allow the inclusion of almost 1,000 intubated patients. Now, thanks again, and thanks for the invitation.
Thank you very much, madam. Now we go ahead. I would invite Dr. J.V. Divyatia, Professor and Head at Department of Anesthesia, Critical Care and Pain at Tata Memorial Hospital. He's been the past president in ISCCM as well as in the AIDA, and he's a mentor to many, including me. Sir, please take over.
So today we'll speak on tracheal intubation in the ICU beyond the AIDA 2016 guidelines. Now, we have recognized that there is a physiologically difficult airway in critically ill patients that makes pre-oxygenation difficult. And when you're doing a rapid sequence intubation and creating apnea, because the patient is sick and may have has respiratory failure, he could be having problems with optimal pre-oxygenation, which makes the airway physiologically difficult. In addition, you could have intubation difficulty, and the combination of a physiologically difficult airway and a technical difficult intubation can have the potential for causing serious hypoxia or even hypotension, which can lead to either death or permanent brain damage. So we need to ensure safety of our patients who are critically ill patients who are being intubated. And the literature has shown a large number of proportion of patients who have significant severe hypoxemia to the extent of 26%, difficult intubation to the extent of 13%, esophageal intubation is almost 10%, aspiration, and even cardiac arrest to the extent of 3%. And therefore, intubation in critical patients in the ICU is life-saving, but also potentially life-threatening situation. And therefore, the All India Difficult Airway Association brought out the first international guidelines on tracheal intubation in the intensive care unit to guide practitioners on how to prevent intubation complications in critically ill patients and perform a safe tracheal intubation. These were the first international guidelines that were published in 2016 December. And we focused, based on the literature available at that time and our interpretation of the literature, to optimize pre-oxygenation using non-invasive ventilation with PEEP. In addition, giving high flow nasal cannula oxygen or ordinary nasal oxygen at 15 liters per minute, bag mask ventilation after administration of muscle relaxant, and during laryngoscopy to continue nasal oxygen either standard nasal oxygen at 15 liters per minute, or if available, high flow nasal cannula oxygen. And we also advocate the use of direct or video laryngoscopy, depending on the availability and the expertise of the operator, and confirming tracheal intubation using capnography. Okay, and we focused on peri-intubation oxygenation to be maintained, whether you're using a supraortic airway device or face mask ventilation, by using nasal oxygen, including the use of high flow nasal oxygen if available. Right. We also called for help when all attempts to secure the airway and ventilate the patient were not working. And for surgical rescue, for rescue airway, we advocated either surgical cricothyrotomy or a wide bore needle cannula, wide bore cannula cricothyrotomy or needle cricothyrotomy. So it is important to prevent hypoxia developing in critical patients. Essentially, based on the literature that has been published after that, and of course the literature that we've read before, there are two major sort of approaches to prevent hypoxemia during tracheal intubation in critically ill patients. One would be to improve peri-intubation oxygenation. So that would be improving pre-oxygenation by using non-invasive ventilation and high flow nasal cannula oxygen, which is already there in our guidelines. Okay, then to give face mask ventilation after muscle relaxation during the period of apnea, which is also there in our guidelines, and during laryngoscopy to provide high flow nasal cannula oxygen, okay, so as to maintain oxygenation throughout the intubation period, thus to improve peri-intubation oxygenation. And there is literature now on all these aspects, which we'll briefly go through. The other approach would be to improve the speed and reduce the difficulty of intubation, and that would probably mean the use of devices like video laryngoscopes, and also the use of bougie or a stillet to aid intubation. And there is literature, there are now randomized controlled trials on many of these aspects, and we'll briefly go over some of them. So what is the optimum pre-oxygenation or the peri-intubation oxygenation technique? Now, there have been studies which have compared face mask pre-oxygenation versus high flow nasal cannula oxygen. And so this was the pre-oxy flow study and the PROTRACT studies. Both were done in hypoxic acute respiratory failure. The PROTRACT study focused on less severely hypoxic patients, right? And the difference in face mask versus high flow nasal cannula oxygen was that the face mask group got pre-oxygenation via face mask, but did not get any oxygenation during the period of laryngoscopy. But both these studies found that there was not much difference when you used high flow nasal cannula oxygen versus face mask ventilation in patients with hypoxic respiratory failure. The FLORALI-2 study looked at non-invasive ventilation for pre-oxygenation versus high flow nasal cannula oxygen. And this study again found that there was no difference overall, but what this study did find was in moderate to severe hypoxia, pre-oxygenation with non-invasive ventilation was better than high flow nasal cannula oxygen. The difference is between these two arms is that high flow nasal cannula oxygen is given throughout the intubation, whereas the non-invasive ventilation group did not get any oxygenation during laryngoscopy. But despite this, the pre-oxygenation was better in moderate to severe hypoxia compared to high flow nasal cannula oxygen. The OPTINIV study was an interesting study, a small study, but an interesting study, because this looked at non-invasive ventilation for pre-oxygenation versus non-invasive ventilation for and high flow nasal cannula oxygen for pre-oxygenation, and the high flow nasal cannula oxygen continued during the laryngoscopy. So these patients were oxygenated throughout the peri-intubation period, and they did find that there was less hypoxia in the group which got non-invasive ventilation plus high flow nasal cannula oxygen. Okay, so maybe it appears to be that if the hypoxia is not very severe, then probably face mask ventilation and high flow nasal cannula oxygen are roughly similar. And maybe if you add bag mask ventilation after the period of apnea before you do laryngoscopy, then you might be okay. But as the hypoxia gets worse, it is worthwhile keeping the nasal high flow oxygen cannula on during laryngoscopy. And as the patient is sicker, non-invasive ventilation seems to be better than either face mask ventilation or high flow nasal cannula oxygen for pre-oxidation. So probably in the sickest patients, you're looking at non-invasive ventilation with PEEP for pre-oxidation and adding high flow nasal cannula oxygen during laryngoscopy. Should you give positive pressure ventilation after the muscle relaxant prior to intubation? Now, in a classic rapid sequence intubation, you don't do that. But this study actually looked at face mask ventilation after relaxant versus no face mask ventilation. And what they found was that in the group that got face mask ventilation, they had a much higher oxygen saturation and fewer patients who had severe hypoxia. So I think this study shows clearly that with face mask ventilation, oxygen is better. This study was not powered to look at aspiration, but it does appear to be that you definitely get better oxygenation when you give face mask ventilation. Should you use a bougie or a stillet with an endotracheal tube? And this group found a higher success rate with a bougie as compared to using a stillet with an endotracheal tube. It did not have a control group which did not have either a bougie or a stillet, but this is a single center study which was always using bougies. So maybe in this is a slightly skewed as far as the expertise of this group is concerned, but they did find that the bougie was slightly better than the stillet. The stiletto trial, which you've just heard about and which is very recently published, it compared use of an endotracheal tube with stillet versus endotracheal tube without a stillet for intubation in critically ill patients. And they found that the use of a stillet with the endotracheal tube resulted in a significantly higher first attempt intubation success rate. So definite evidence to suggest that in patients, critically ill patients, we should be routinely using a stillet or perhaps a bougie to guide endotracheal intubation to improve the success rate of intubation. What about video laryngoscopes? Now, intuitively, we would believe that video laryngoscopy would be much better and would improve the laryngoscopic view and would help us intubate faster and more certain and with less failed intubations and more first attempt success rate of intubation. However, this has not been somehow borne out in randomized controlled trials. And these are two randomized controlled trials, both showed a similar first attempt success rate with McGrath versus the McGrath or versus direct laryngoscope. And here they used either McGrath or the GlideScope or the Olympus. And this study, actually, the Bachmann study from France, actually showed a slightly higher rate of complications using the McGrath video laryngoscope. Meta-analysis of various trials, again, does not seem to conclusively demonstrate a difference in favor of video laryngoscopy, either in terms of time to intubate or the first attempt success rate, again, showing a trend towards better results with video laryngoscopy for both outcomes, but not showing a conclusive difference. And similar, this recent meta-analysis in emergency intubation that outside the OR that included the emergency room and the ICU, again, it seemed to show no clear benefit to the routine use of video laryngoscopy, except that in less experienced clinicians, it seemed to be better as far as first attempt success rate was concerned, which is a good outcome because many intubations are done outside hours by residents, by trainees who are not necessarily experts in intubation. And also it showed a better success rate in intubation ICU, so which is again what we are talking about. It was associated with fewer esophageal intubations, which is again an encouraging outcome, but there was more hypotension. So the data on video laryngoscopy probably tends to favor video laryngoscopy for intubation ICU, but has not conclusively shown benefit. However, I think most of us would agree that video laryngoscopy is probably the way to go, and we just need to wait and hope that a trial shows that difference. Should we use checklists for intubation, and do checklists make a difference? And again, conventional wisdom would suggest that checklists would make a difference and improve care, the process of care. This study was done in 9 academic centers in the United States, and this seemed to show that compared to usual care, a checklist, use of a checklist did not make a difference in intubation in the ICU as far as the lowest saturation was concerned and the lowest blood pressure was concerned. There was no difference in the number of laryngoscopy attempts. If you look carefully at the data, this is, if you see the difference in the checklist group in red and the usual care group in blue, there's not much difference in the different elements of the checklist that were performed. What made a difference in the checklist group was they were called out, but actually these things were being done anyway. So there was a reasonably high concordance, except in a few sort of things between what was usual care and what was done in the checklist. Also, many items in that checklist were not, which would improve physiologically the oxygenation and so on, were not included in the checklist. For example, the method of pre-oxygenation or non-invasive ventilation, or the use of hemodynamic optimization prior to intubation, or the use of stillets or video laryngoscopes. So again, the utility of a checklist depends on what is in the checklist, and maybe some of the elements that we think could have made a difference were not included in the checklist. So I don't think the word is out, and I don't think we should conclude from this study that you should not be using checklists in the in critically ill patients. And again, intuitively, we would still think that checklists seem to make a difference. And now, what about hemodynamic decompensation? Now, patients are sick. Patients do get hypotension for various reasons after you intubate them. And this is the INTUBE study, which is recently published. It covers intubation practices and adverse events in critically ill patients from 29 countries. Dr. Sheila Maitra was the second lead author from this of this study. And this is a very nice study. And what this study showed was that hypoxemia was not such a big problem. Only 9% patients had severe hypoxemia, but severe cardiovascular instability was the major problem, and it happened in almost over 40% of patients. So cardiovascular instability is a problem now. Maybe we sort of come around this hypoxia problem, but cardiovascular instability is a major issue after intubation in critically ill patients. And maybe we need strategies to prevent severe hypotension after intubation ICU. We've been talking about a fluid bolus, which is there in our guidelines, or maybe you need prophylactic vasopressors with or without fluid. There was this study called the PREPARE study. Again, it was a randomized controlled trial from 9 academic centers in the United States, and they were randomized to receive a 500 mils crystalloid bolus or a no fluid bolus prior to intubation. And this study overall found no difference in the incidence of hemodynamic compromise after intubation, even after a fluid bolus. However, when they looked at the data more carefully, they found that in patients who got positive pressure prior to intubation, either bag mask ventilation or non-invasive ventilation, they found that those patients who had received positive pressure ventilation actually had a better response and less hemodynamic compromise with a fluid bolus than without a fluid bolus. So now these investigators are doing the PREPARE 2 randomized controlled trial, and they are going to do this in patients who have received non-invasive ventilation or bag mask ventilation prior to laryngoscopy and intubation. And we'll wait for the results of this study. But hemodynamic compromise is a significant problem which we need to tackle in the future. The INTUBE study also showed us that, in multinational study with many high-income countries taking part in this study, 34% of patients were intubated without a protocol for intubation. Non-invasive ventilation, which has been proven to improve pre-oxygenation, was used only in 11.6% of patients. Apneic oxygenation was used only in 10% of patients. Patients received propofol for induction in 41.5% of patients. Right now, propofol is known to cause hemodynamic compromise, and our guidelines and other guidelines suggest the use of either etomidate or ketamine to prevent hemodynamic compromise. But this was propofol in almost 40% of patients. Video laryngoscopy was in only 17% of patients, and waveform capnography to confirm intubation was used in only 1/4 of patients. So despite the knowledge, the guidelines, the scientific data and evidence, it appears that the penetration of this knowledge and data and guidelines does not seem to be translating into practice. And therefore, we need to improve not only our guidelines, not only our data, our skills and training, but also dissemination and implementation of guidelines. So thank you very much for listening.
Thank you very much, Professor Diwatia, for the excellent talk. And now the floor is open for questions. We've had 4 excellent talks on airway management in critically ill patients, and from 4 expert speakers. I'll start. Mohit, if you can just track the questions in the chat. So I wanted to ask this question first to Professor Risotto. So it's very interesting. We have a high incidence of hemodynamic complications compared to the respiratory complications after tracheal intubation in ICU. And as Professor Divatia emphasized, that perhaps we've got better at peri-intubation oxygenation, and perhaps we are managing this better. But considering this, what is the way forward? Because we have, Jan's trial with fluid loading showing no difference. The Intube study actually showed harm with giving fluids. And we also have the intubation bundle from Professor Jaber, which recommended giving fluids. And patients also need, high number of them needed vasopressors. So what do you think is the way forward? And did you look at the data of those patients who in the Intube study who got positive pressure ventilation? Were fluids better in those patients?
Thank you for the invitation and for this nice question. Well, probably the answer is quite complex, and as has been described in other talks, the personalization probably is the solution. So probably fluids may be of benefit in those patients receiving positive pressure ventilation. We are currently working on sub-studies of the Intube database, and we are focusing also on this question. But perhaps according also on the pathophysiologic patterns that occurs during the induction, in some other patients, a preemptive administration of vasopressors probably is maybe of more benefit than fluids. But as has been suggested, also personalization may also mean that an assessment of the pre-induction status with also the echocardiography may help to identify those patients that are fluid responsive, where the fluids may be of benefit, and in case of not responsiveness, probably the administration of a vasopressor may counterbalance the effects of vasoplagia that even those agents such as propofol for sure, but maybe also midazolam and the other agents may play a role for these numbers.
So you're saying perhaps there may be a role for both fluids as well as the vasopressors, either of them, and perhaps we need to individualize, and further data analysis will show us. Just one more quick question to you. Majority of the patients were using propofol for induction of these patients, despite knowing that these patients have a physiologically difficult airway, they're hypovolemic, often in shock. So was that a surprise finding? And what do you think? Was there a difference between using propofol or using ketamine on etomidate as is recommended in most guidelines?
Yeah, it was probably one of the most surprising findings of our study, along with others, such as the poor use of capnography that we observed. There is also an association, the operator background plays a role, and we identified, for example, that the anesthesiologists more frequently use propofol compared to other operators, such as the pure intensivist or emergency physicians. So it was a quite surprising findings, because from Intube study we noticed that even in those patients with baseline good hemodynamics, that may suggest the use of to pay less attention to the selection of induction. Probably at the end they have the more common disasters at hemodynamics. So this is probably one of the most striking observation, and as I try to explain, there is this discrepancy between what is the ideal word and what the guidelines suggest, and what is the current practice around the globe. And this is one of the nicest things that we observe with observational studies, because from a randomized trial we codify everything, and probably the place where randomized trial are performed are the best place for airway management,
But when you do an observational study, you take a real life snapshot, and what is a real life is different from a randomized trial.
Absolutely. So I think this study, this is a real world study, like you said, and it reveals a very important point that anesthesiologists may be very skilled at anatomically difficult airway, but the ED and the critically intensivists are more familiar with the drugs to be used in a physiologically difficult airway. So perhaps we need a combination of the two things to make to improve the safety of airway management in the intensive care unit. Congratulations on your publication in JAMA, and thank you very much for making me a part of it.
Thanks to you, Sheila.
Any questions from the other co-chairs?
Sheila, can I ask a question or a sort of inquiry to Professor Divyatia, please? Sir, as you said that face mask ventilation at times has shown better result as pre-oxygenation in critically ill patients. There are some studies which you said. Do you think that the patients who are already, most of the patients in critically, in the ICU, they are already on a trial on NIV. So, and where they're already on a high pressure. So converting them to face mask ventilation and ventilating them would be a better choice, or just keep them on the same mode what they are and then oxygenate them.
Yeah, thanks, Dr. Mohit, for asking this question so that I can make this clarification. I think as far as pre-oxygenation is concerned, NIV is by far the superior mode of pre-oxygenation, especially in patients who are more hypoxic. Right. So if the patient is on non-invasive ventilation, should certainly carry on with non-invasive ventilation. If the patient is not on non-invasive ventilation but is hypoxic and you need to intubate the patient, maybe you should stick them on non-invasive ventilation before you go ahead and intubate them. The face mask ventilation, which I was referring to in one of the studies, was that after you've given pre-oxygenation, after you've given your relaxant, if you give bag mask ventilation prior to intubation, as compared to those whom you don't give face mask ventilation, which happens in some rapid sequence intubation. So bag mask ventilation after administration of muscle relaxant has better oxygenation as compared to those who do not receive face mask ventilation. So ideally the sequence should be, especially in the sicker patient, should be non-invasive ventilation, induction, muscle relaxant, face mask ventilation, continue high flow nasal cannula or apneic oxygenation, and then go ahead with laryngoscopy and intubation.
So one more point is regarding your video laryngoscope. We know that video laryngoscope, obviously it is a choice for the intensivist most of the people are using it, but some of the studies they showed that probably negotiating the tube is difficult when you're going with a video laryngoscope. So does that type of video laryngoscope play some role there? Because we are much more acquainted in using Macintosh plate, especially CMAC Macintosh plate does good because we are using in direct laryngoscope as Macintosh plate. So, but CMAC has a Macintosh plate. Do you think that type of video laryngoscope will play a role? For delaying your intubation or negotiating a tube? Because there are so many tubes which are preformed, like for instance, King's Vision and AirTrack. They're also video laryngoscope, but then probably in those cases you might take much time than with CMAC or those people who are using the Macintosh plate. What do you say? At what point do you have any suggestion on that?
Again, that's an excellent point that you bring out, because when we say video laryngoscopy, it's a very generic term, and there are all sorts of video laryngoscopes. You've got the standard Macintosh type video laryngoscopes. You've got the hyperangulated or the D blade in the CMAC. So you've got the hyperangulated blades with the channeled video laryngoscopes versus the non-channeled video laryngoscopes. So I suggest that if you're looking at the literature, you need to figure out what video laryngoscope was being used. In the randomized control trials that I mentioned, they use the McGrath, which is and the Macintosh blade in many of the trials. So I would say that if you're using a hyperangulated blade, you definitely need to have a shaped stillet, right? And I would suggest, again, now based on the stiletto trial and the other, we should use a stillet anyway. And whenever you're going to intubate patients with well, stiletto trial, I think was Dr. Audrey's here, but I think most of the patients were intubated using direct laryngoscopes, the standard direct laryngoscope.
All of them.
All of them.
Yeah.
So, but I guess the same principle would apply even to video laryngoscopes, where it's even more important because in video laryngoscope, your view is indirect and you need to you need to shape your stillet to get your tube in. You could get a brilliant view, but you need to shape your tube with the stillet to get the tube in. So I guess we are moving towards using shaped stillets and video laryngoscopes if you're using video laryngoscopes on the intensive care.
I think just a point here, like probably the training with video laryngoscope is also important. It is a very underused equipment in the ICUs. People would not place their hand on a video laryngoscope first. It's a matter of training, I guess. If the intensivists and the resident doctors are given that much of training, probably this will be one of the equipment they do pick up.
I entirely agree. I guess even direct laryngoscopy, you need training, and maybe the training is a little more difficult with direct laryngoscopy. But even with video laryngoscopy, although it looks easy, you still need some training and some education.
But as far as the literature says, the learning curve is much more better with that of a video laryngoscope than with the direct laryngoscope.
But there is a learning curve. There is a learning curve.
I think there's a learning curve for everything, and I think the right place for video laryngoscope in the intensive care still has to be established. It's very well established in the operating room. I have a question for
Sheila, before the lesson, I think we need to emphasize that with video laryngoscopes, you must use stillets, right? That must be part of the training.
Right, absolutely. So firstly, Professor De Jong, congratulations. This is the largest randomized controlled trial, I think, in airway management, and congratulations for being the first author and the publication in intensive care medicine. Please unmute yourself. I have a question for you. So you found better first pass intubation success using a stillet, but not with the just going in without a stillet. However, there was no difference in complications in the two arms. So one would argue if the complications were the same in both the arms, then does it really matter? That's one. And secondly, would you change your practice in ICU now for stillet and direct laryngoscope, stillet with all direct laryngoscopic intubations?
Yes, thank you very much again for the invitation, the very nice questions. First, I agree with Professor Divasya that with video laryngoscope, we should use a stillet. And the stiletto study was focused on patients intubated with direct laryngoscope. And we found a difference in first attempt success with stillets with a higher rate, but no in complication. And I think we did not find a difference because the study was underpowered to conclude on complications. And the absolute difference in first pass success was only 6.7%, so quite low. It's not a huge difference. And that's why it was not translated into complications, I think. And in my practice in ICU, when we were using direct laryngoscope, we were using always stillets. And that we want to design the stiletto study with video laryngoscope, as now in our practice, we are always using in Professor Javert unit video laryngoscope for all intubation in ICU. But
that's very interesting. Sorry, yeah.
Yeah, but when we talked with friends from France, we realized that they do not use a video laryngoscopy as a first attempt device, but they all use direct laryngoscope. So that's why finally we moved the study to direct laryngoscope only and not video laryngoscope to have a homogeneous cohort. But now the video laryngoscope are clearly taking the lead in intubation in ICU. I totally agree.
That's a great point you make, but I think your study is very relevant, though people might say, why didn't you do it with video laryngoscope? Because if you see the result of the Intube study, and I'm sure Professor Vincenzo will agree, that less than 20% of the people across the world are using video laryngoscopes in ICU. So the message that if you're using direct laryngoscopy, please use a stillet with the tube and it can improve your chance of first pass success. I think your study has beautifully demonstrated that, and it is a practice changing paper. Congratulations.
Thank you very much.
Professor Audrey, I just wanted to know a little thing like, was there any group of, patients where you found difficulty in introducing with the stillet?
Yes, no, when we analyze subgroups, we have no difference between subgroups, except it may be in the patient predicted very difficult to intubate. maybe in those patients, style cannot help if, for example, the coma grade is 3 or 4. Maybe we will not succeed with style, but rather with video laryngoscope or over long intubating stylex. It was only a trend, but not demonstrated because of not enough power again.
Right.
But yes, it's a very good question. Thank you.
Thank you.
Yeah, go ahead, Prasanjay.
Yes, ma'am. My first question goes to Dr. Audrey. Actually, we have been talking about this stellate all the time, and this is dilemma faced by most of the junior anesthesiologists. That actually, what we talk about it as a hockey-shaped stellate that we should make. We have not standardized any particular angle and at what distance this angle should be made. So, any comment on that?
Yes, absolutely. The angle is very important, and we have to pre-shape the tube with a sharp angle. So it is about 30 degree, and it is the end of the tube. So yes, this is very important. And then we have to put the style in the right place, not too far, but also not too close to the move, at the right place, as I showed in the schema. Yes. Do you agree?
And I think that should be going to the recommendations also. Actually, what is happening? Like many people end up making shapes like there'll be U shape. So it makes things difficult many
Right,
times.
people say J shape, hockey shape,
Yeah.
but what's important is you need to pre-shape it, because if you keep the same shape and put the stellate, it's not going to serve the purpose. So
Yeah.
we have Dr. Karam Chandani here. I'd like to ask you, in the operating room, anesthesiologists are there, pretty much controlled conditions. In the ICU, you have your ICU team. But when you're doing this outside the operating room, the situation becomes really complex. So it's not only about the complex patient and the anatomy and everything, but the whole environment. So how do you kind of overcome these complications? And in every setting, it's variable. So, what are your recommendations for this? If I go into some gastroscopy school suite, it's different. If other places are different. So how do you coordinate all this in such a setting?
Thank you, Sheila, for the question, and thank you for the opportunity. So you're right. I mean, I think these out-of-OR airways are complex, not just because of anatomic issues or physiologic issues, but with logistical issues as well. And, one of the big things that we need to do is take control of the situation. So when the airway team goes in, there's so much chaos already there. Someone has to, take control. And what a lot of institutions here have been doing, for example, where I am now, when we go into the codes, we're handed an orange Buffon cap. So the code leader or the person who's in charge wears that cap or the hat, and immediately they recognize that this is the person that we're going to follow the cues from and the lead from. So one of the ways that you need to do that is, like closed loop communication. If I ask them to do something, I need to make sure that it gets done and it is reiterated back to me. And again, most of the times people are operating under stress. You have people who have no idea what airway management is. So again, having 2-person team, I think that's what Audrey's team said, the Montpellier bundle, where you have 2 people there for your airway teams. I think that is an essential step that needs to happen. Plus, having a dedicated airway team, which a lot of institutions have, is, we have these bags with drugs, we have these bags with airway stuff that we carry with us when we go for these airways. So, as I said, we have logistical issues where the equipment may not be there. So if it's not there, you carry it with you, because ultimately you're the one who's responsible for managing that airway. So you have to be prepared as you go in. So, again, it's a free for all. And it depends on circumstances. Like, in India, things are very different. I was at AIMS when I did my residency there, and the setup at AIMS is much different from what I have here now in the United States, good or bad. I mean, there's some bad parts too, by the way, as Vincenzo's study showed. I mean, I've been fighting a battle here to not use propofol for out-of-OR intubations, but the anesthesiologists want to do it all the time. And so there's no way from capnography in a lot of institutions here. So I think it's very institutional dependent too.
Right. So you've raised some very important points. So airway management in critically ill patients, anatomically difficult airway, physiologically difficult airway, and like you said, situationally difficult airway. So you have to prepare for all these things because you can have a critically ill patient even coming to the operating room who may need physiological support. So in the interest of time, I will wind up the session. Thank you very much to all the 4 speakers for an excellent presentation and for a great discussion. Thank you very much.
Thank you, Sila.
Thank you.
Thank you very much.
Thank you.
Thank you so much for such an enlightening session. Moving on to our next session, that is COVID, extubation and human factors, I would like to invite our respected chairperson, Dr. Amit Shah, Director and Consultant Anesthesiologist, Wings Hospital, Vadodara, and Dr. Shweta, Professor in Charge Anesthesia and Consultant Pain Physician at SAFE GSMC and Kane Hospital. Over to you, respected chairpersons.
Yeah. Good evening, all. Thank you very much. We are near to our last session, and as expected, we have a current situation, COVID, something which we do at the last extubation, and also very important human factors in airway management. So with the first lecture, first topic is airway management in COVID-19 patients, how practice evolved, by Dr. Professor David Brewster. He's from Cabrini Hospital, Monash University, Australia. Welcome, Dr. David Brewster.
Good evening, and thank you to Sheila and the organising committee for inviting me to talk at this wonderful event this weekend. I've been asked to talk to everyone today about the airway management during COVID-19 and how practices evolved through last year and into this year. Today, I'll talk to you about how clinicians in Australia and New Zealand prepared for the airway management of patients with COVID-19 and what guidelines were developed in our country, in both our countries, and what guidelines were developed elsewhere. We also will focus on what was actually done by our clinicians at the bedside during the original pandemic. I'll take everyone back now. If we can try and recall what we were doing in December of 2019, it does seem like a lifetime ago for many of us. And it was when we'd first just heard the first few stories about a new virus that was occurring in China. And then a few cases occurred in other countries, eventually the United States, South Korea. And by March, we realized quite quickly that we had a new illness that we all had to combat, one that had a significant transmissibility, a respiratory virus that was very similar to what we'd heard about with SARS more than a decade earlier. And by the first week or so of March, we'd had about 100,000 or so cases internationally. And at that stage, the Safe Airway Society in Australia, we got together and said to ourselves, well, what are we going to do about this pandemic? It's obviously had arrived in Australia at that stage, and it was obviously one that had significant impact on healthcare workers, both in the operating theatre and the intensive care. And we decided at that point to write a quick statement, and you can see there's from one of our WhatsApps amongst the board members was dated on the 11th of March. It's fair to say we didn't get much sleep over the coming days, because 5 days later we had our first statement published online in the Medical Journal of Australia, which was on the 16th of March, after much collaboration, not only between the 14 or so experts on the authorship group, but also those overseas through Andy Higgs as one of our authors, sharing his role at the Difficult Airway Society in the UK, as well as all the specialty colleges with an interest in airway management within Australia and New Zealand. Our statement, which some of you may be familiar with, was the first international guideline for the airway management and the intubation of patients with COVID-19. And it really, I guess, was well received, partly because of the collaboration that we underwent in order to to put the statement together, and you can see the list of endorsing societies in our countries there, but we collaborated with those from not only anaesthesia, but intensive care, emergency medicine, paramedicine, surgery, etc., just to get something out that was relevant to all of us. The Safe Airway Society focused on the guiding principles for the management of airways in COVID-19, described potential aerosol generating events as we named them at the time, and probably became better known as aerosol generating procedures throughout most of last year. We looked at the team, equipment and processes that were required for a safe intubation, not only for patient safety, but also staff safety. And we developed some cognitive aids, which were distributed throughout our countries to those on the front line to help with the safe practice of intubation and airway management. The guiding principles that we focused on were those around intensive training of staff, early intervention for patients who had severe COVID, meticulous planning not only of the environment but also the equipment that was required and the staff, vigilant infection control, efficient airway management processes, clear communication and a standardised practice. We looked at institutional preparation and how to avoid the risk to staff. We mainly focused on the use of checklists to prepare the team and then the use of cognitive aids as well. Both checklists and cognitive aids were used to ask the staff to use safe, simple and familiar practices, reliable techniques that they were already familiar with, rather than inventing new processes which would require a higher cognitive load on the staff during what was already a stressful time. We decided to focus on doing what we knew well, the use of video laryngoscopy, the use of a proper rapid sequence induction with high-dose rocuronium, and in the event or the unexpected event of a failed airway, falling back on a CICO method that was already known and well trained into the staff. And we asked the individuals involved in airway management to do regular training of themselves and their teams around how to become familiar with the new COVID-19 processes. Aerosol generating events were listed, and many of these, I think many of you have seen over the last 18 months ad nausea, but we did describe them, including everything from high flow nasal oxygen and CPAP, which have been well debated ever since, to coughing and sneezing and obviously CPR. We recommended pre-oxygenation to be vigilant, to use a vice two-handed grip, to use a mask with a viral filter. We recommended the use of video laryngoscopy to maintain a safe distance between the airway operator and the patient, a high dose of rocuronium, using the best airway operator to perform the intubation, using checklists and cognitive aids to help with team performance. We recommended pre-packing intubation trays with disposable equipment that once entering the intubation room would then be thrown out at the end of the procedure. We asked for the use of PPE spotters or designated staff members to check that the PPE was not only put on and taken off properly by staff, but also remained intact during the airway management. And for negative pressure rooms to be used for intubations, as well as a specific team structure to be employed. Here's one of our training videos that we put together just on a fast loop, that you can see how the airway management of these patients looks different from your routine intubation, either in theatre or in the intensive care. Throughout the pandemic, I think we realised that patients with COVID-19 desaturate quite quickly. We realised pretty early on that hypoxia can be extreme. So although early we recommended against face mask ventilation, quite quickly we revised that to say gentle face mask, bag mask ventilation if required. Communication's clearly the key, as well as vigilant attention to detail, particularly around avoiding putting yourself at close proximity to the airway. You can see there that in that example video, the PPE is a significant barrier to communication, and so communication needs to be clear with closed loop and people speaking clearly as well as quite loudly for everyone in the room to be sure of what is being said. These were the cognitive aids that we put together. Some of you may have seen them already. The first one is really one for the airway trolley, which goes through the 6 Ps of planning and preparing, as well as PPE, pre-oxygenation, performing the tasks and post-intubation tasks. And then we had another one that was for not just the airway operator, but the nursing staff, which showed where the people, team members were, how the team was to be configured and where the team members were to be situated between the negative pressure room and the ante room, what were the suggested contents of an intubation tray, and how a circuit would be set up, including the position of the end-tidal capnograph in relation to the viral filter and the face mask. We had a checklist that was to be read out before entering the room, and also a final check during the 6 minutes of pre-oxygenation if that was able to be done, depending on the patient's cognitive state. Aside from us, there were some excellent guidelines written all around the world, particularly both in India and the UK. Tim Cook and Kareem and the rest of the team in the UK published their guideline in anaesthesia, some within a week or so of ours being published, and many of the organising committee here published the wonderful guideline in the Indian Journal of Anaesthesia some weeks after that as well. All of these guidelines have had a wonderful uptake in various parts of the world and contributed greatly to the safety of staff as well as the safety of patients with COVID-19 during intubation. There's many similarities that appear between all the guidelines, particularly the need for staff to prepare through education, a discussion on aerosol generating procedures, recommendations such as the use of the most experienced intubator or the use of video laryngoscopy, a real focus on staff safety such as negative pressure rooms, PPE and viral filters to be used in all intubations, two-handed grip for a mask pre-oxygenation, and early on everyone did discuss avoiding mask ventilation, but as previously mentioned, that was revised. Over time, advice evolved. There was more research into aerosol generating procedures. There's been some change in attitudes towards high flow nasal oxygen, mask ventilation, and CPAP in particular. And there's been some good research into the safety of healthcare workers and the importance of appropriate PPE use. No better papers than, I suppose, than Intubate COVID, which was in anaesthesia last year. Were others doing things differently or thinking inside the box, as I've said before? This was a photo taken of myself with Jonathan Begley, who was one of my fellows at the time at Cabrini, and we did a study on the aerosol box together, which some of you may have seen in anaesthesia last year. This was a great paper. It was a simulation study with consultant anaesthetists performing 36 intubations. It was a crossover study looking at intubation times between either no box or the early first and second generation boxes, showing a significant difference in intubation time. And as we know in the hypoxic patient, that can correlate to significant morbidity or hypoxic cardiac arrest. We also demonstrated that PPE was damaged by the use of the aerosol box, even in the experienced hands. Just a couple of quotes from an editorial I was asked to write about the aerosol box recently. It is entirely understandable that clinicians sought to create the use of these novel devices from a genuine desire to reduce their risks at a time of unprecedented anxiety. And I think that really sums up how they came about. They came about from a good place, from people wanting to help. But the problem with MacGyvering during a pandemic, which many of you may have discussed or read some good articles from others such as Laura Duggan or Stu Marshall before, is that we really need time for these devices to be tested appropriately. And just because the idea sounds good, it doesn't mean it's safe or it's appropriate. In the first half of 2020, there were thousands of centres around the world that were distributed these boxes, and quickly hospitals around the world obtained an emergency use authority from from America, from the FDA, which was later revoked following both our paper and then a second paper that was also published out of Melbourne by Joe Simpson and friends. What was actually done during the pandemic was interesting. We looked at this 6 months after the guidelines were released, and we focused mainly on the intensive care staff, as they'd had the significantly greater experience with COVID-19 airway management in our country. This was an article we published early this year that looked at 69 ICUs across the nation, found that 97% employed the simulation-based training recommended in our guidelines, 94% employed video laryngoscopy at all COVID-19 intubations, and the use of checklists. As you can see there, and the intubations were predominantly performed by intensive care specialists versus anaesthetists, but the use of guidelines was adopted widely, and this paper demonstrated not only was there a fairly universal practice that occurred in our country, but also that the guidelines were very helpful to the staff as the uptake was so high. And I think this was a great validation of all of the work that we'd done in the months before, not only writing the guidelines, but the effort to get the message out to everyone through promoting them through not only social media, but conferences and podcasts. So finally, where does that leave us now? I think post-pandemic, what should airway management in the critically ill look like might be something that we discuss on the panel coming up. The use of video laryngoscopy, and I guess through the publication of our, with Vincenzo and others here today, our in-tube study in JAMA, that has also prompted a debate about the use of VL and whether trainees and specialists should be intubating and what should be the balance in the critically ill. I guess cognitive aids and checklists have become very popular in our country and have added that layer of safety or that perception of patient safety to the airway management, particularly in the critically ill, and what will be the expanded role for them post the pandemic. The other thing to talk about would be the importance of team training and simulation, which really came to the fore during COVID-19, and hopefully we can springboard off that in the future. Thank you very much again to Sheila and the organising committee for the invitation. It's been a pleasure to talk to you, and I look forward to a good discussion on the panel. Thank you.
It was a very informative lecture, and we move on to the next speaker. He is our own Dr. Rakesh Garg. He's an additional professor from AIIMS, New Delhi, and he's the most active member of IDA. So over to him. The talk is about the extubation of the difficult airway, extremely important topic for all of us. Over to you, Dr. Garg.
Now we'll come to a very important topic of the extubation on difficult airway. In the previous sessions, we have talked various aspects of securing the airway and various strategies and options for that. Equally important will be to sail through to have a safe extubation as well once a difficult airway has been managed successfully. I bring greetings from my institute. I work at IRCH, All India Institute of Medical Sciences, New Delhi. Now we usually get these patients who are operated for various head and neck tumors or head and neck procedures, and even at the time of completion of surgery, sometimes the airway may become simple, or at times they may become more difficult. And hence, when we talk about airway management, securing airway with whatever techniques and strategies well managed, but it is not ever, still we can have a successful extubation as well for these patients. As you mentioned, for the various airway management strategies, we need to have a systematic approach for better success, lesser morbidity and mortality. We also need to plan for these type of procedures, having plan A, B, C for the optimal success. Same thing would be applicable for extubation also, because extubation, which is usually defined as purposeful removal of the tracheal tube and transition from an established airway to a normal natural airway. But at times, we have a failure, which is extubation failure, defined as inability of the patient to maintain a patent airway with effective spontaneous ventilation after purposeful removal of the previously placed tracheal tube within a specified time. And we are concerned because we do talk of the difficult airway, but extubation failure is also seen. The reported incidence in the operating room is 0.1 to 0.2%. And in ICU, it could be 6 to 25% because of variable regions. And these extubation failures leads to more increased morbidity and mortality. And we are more concerned because majority of time, extubation is an elective procedure, and hence many of the aspects can be easily avoided. But what we need to do is we need to have plan and strategies to avoid these extubation failures. And for this, we need to not only to understand various techniques available to us, but also we need to develop a strategy, an algorithmic approach to these patients based on the patient assessment. Now, there are various factors that has been reported in the literature that affect the successful extubation in patients who may have predicted difficult airway. These patients may have exaggerated airway reflexes that can lead to breath holding, the coughing, the laryngospasm, and that can lead to various events related to the hypoxia. These patients can also have reduced airway reflexes that can happen primarily because of the residual effects of various anesthetic agents, like inhalation agents, like opiates, or maybe the use of neuromuscular blocking agents as well. Also, the extubation would depend upon the airway injury that could happen because of the surgical insert. They are undergoing the head and neck surgeries, oral surgeries, and they could have some surgical edema because of the dissection, which is inherent. Also, in case of difficult airways during the initial airway securing, because of various airway tools and techniques that we have used, they can cause airway injury, and with time, they can lead to more of edema formation. Also, the physiological cause also needs to be understood for extubation failure. There could be decreased FRC, atelectasis. There could also be hypothermia and electrolyte imbalances that can have leads to extubation failure because of the inappropriate, inadequate efforts in these patients, respiratory efforts in these patients leading to the extubation failure. And also, we will be discussing in more detail in the subsequent session, but the human factors also needs to be considered because variable human factors are responsible for the events that can happen during the airway management, whether it is during the intubation or during the maintenance of airway or even at the time of extubation. And hence, understanding them and nullifying them becomes one of the very important aspects. Now, when we say extubation, we usually have a lot of parameters for assessing the difficult airway. We use them to assess these airways for predicting the difficult airway. Similarly, we need to assess for the potential difficult airway for extubation also. We need to look for various parameters. Those are primarily based on the initial assessment, but they should be added on various surgical insert that has happened that may lead to potential difficult airway for extubation. Also, there could be concerns with neuromuscular, respiratory, or cardiovascular compliance. Now, if you assess all those parameters and if you find everything is acceptable, we don't have parameters for difficult extubation, we can go ahead and do a regular awake extubation as we do conventionally, wherein we antagonize the residual neuromuscular blockade, let the patient recover from the anesthetic drugs, have the spontaneous efforts, perform awake extubation, and supplement them with oxygen and monitor the patient for any events. In case if there are any parameters that are characteristic of difficult extubation, the All India Difficult Airway Association has given a guideline, a three-limb approach for management of anticipated difficult extubation, which becomes very, very useful. Now, these guidelines is a recommendation and they may be modified as per the individual need based on available equipments, expertise, and individual limitations. But this guideline covers most of the aspects that would lead to the extubation failure, and hence this stepwise approach would help us to prevent these type of extubation failures. These extubation strategies may be planned based on the initial assessment, as I just mentioned, with regards to difficulty in airway and predicted concerns at the time of extubation. Now, this three-limb approach identifies various concerns of the airway assessment, and based on this, we can take a decision which limbs to follow. Now, these decision making for choosing the correct limb of the anticipated difficult extubation in these patients are primarily based on, though patients may have a normal airway, but they have conditions requiring suppression of hemodynamic responses, as can happen in ocular surgeries or neurological surgeries. The second limb comprised of 4 Ds. In this, the patient had difficult mass ventilation or difficult intubation or intubation. That can be pre-existing or they could have happened because of a surgical procedure. The patient may have a delayed recovery because of anything, surgical insert or the drugs or any technique that we have used, or the patient have some pre-existing disease which leads to difficulty in having an optimal extubation, a normal extubation for these patients. The third limb is primarily focused on 3S, which is because of the surgical cause for airway compromise that can happen in head and neck surgeries, the oral surgeries, the thyroid surgeries. These patients may develop suspected airway edema. Also, these patients may have suspected airway collapse, as can happen in case of long-standing thyroid, leading to thyroid tracheomalacia. Hence, this limb will be used in this group of, or this subset of patients requiring extubation. Now, in this 3-limb approach, let's look for the first limb of difficult extubation, wherein the patient may have otherwise a normal airway, but we need to obtain the extubation responses, especially the hemodynamic responses for these patients. These patients could have required the ocular surgeries, or they may have the intracranial surgeries, wherein we provide to obtain any hemodynamic response that can lead to bleeding, oozing, and can lead to a surgical failure. The options available for these type of patients requiring extubation is either a choice between awake extubation with the use of pharmacological attenuation of the hemodynamic response, or deep extubation to obtain again the hemodynamic response. When we talk of the awake extubation, we can use various drugs like topical lignocaine, IV lignocaine, fentanyl, dextromethorphan before extubation in appropriate dosages to obtain these responses. For deep extubation, we have 3 options we can use for these patients using a supraglottic airway device exchange, wherein we can remove the tube and insert the SAD, or the SAD is inserted followed by ETT removal, or remove ETT over AC and then insert or railroad SAD over AAC. And once the patient has appropriate effort, the supraglottic airway devices can be removed. All the patients should receive oxygen supplementation once the airway has been removed. Now, coming to the second limb, which talks about the 4D, we have to keep difficult airway cart as we did for during the airway secure. Again, the difficult airway cart should also be available at the time of extubation. Once the patient is fully awake and obeying commands, we can recruit the lung and then start supplementing the oxygen to these patients. And then these patients will be extubated using some adjuncts, which could be airway exchange catheter or fiber optic bronchoscope. You can insert the airway exchange catheter to a tube, and then over this airway exchange catheter, the endotracheal tube can be removed, and the patients can be looked for any issues in the airway management. And this airway exchange catheter can be kept for some time till the patient has appropriate efforts. And once the patient starts having appropriate efforts, this airway exchange catheters, if there are no signs of airway difficulty, can be removed after some time. The duration or the timing for airway exchange catheter removal is very variable in the reported literature, and hence needs to be individualized as per the patient requirement. Now, coming at this point of time, these patients must continue to have continued oxygen supplementation. Sometimes these patients may require support using CPAP, or now we are very well aware of the high flow nasal cannula oxygenation also, in case if there are any issues. Now, coming to the third limb, which is called about the 3S that we have discussed earlier. These patients, because of these surgical procedures, can lead to difficult airway and difficult extubation. Again, we need to have a difficult airway cart ready for these patients when we are extubating them. And once these patients are being weaned off from the ventilator, we have to think of the leak test. Now, this leak test is to assess the airway edema or collapsibility, because we are having this limb which is primarily focused on the airway compromise because of surgical regions or edema or collapse. The leak test, the options available are qualitative or quantitative test. The All India Difficult Airway Association suggests that the quantitative test should be used, wherein a difference in axial tidal volume with the cuff inflated and deflated should be 10 to 25%, or 110 to 130 ml, which is considered to be significant for saying that the leak test is present or absent. In case it's equivocal, consider it's absent and take the subsequent steps. Now, based on this assessment of leak while the patient is still on ventilator, if the leak is present, this means the airway edema is not of much concern. The collapsibility is not much of concern. We need to recruit the lungs with 100% oxygen so that the reserves becomes better. And these patients can be extubated, as we mentioned in the second limb, over an airway exchange catheter or even a fiber optic bronchoscopy. Fiber optic bronchoscopy or endoscopy gives an advantage that we can actually see the tracheal collapsibility or edema while the tube is being removed. All those procedures should be done in a monitored environment. It could be in the operating room or the IC or a high dependency unit where you have the facilities. And as I mentioned earlier, the difficult airway card should be ready. Now, in case the leak is absent or equivocal, then those patients should be delayed for extubation because there will be a possibility of extubation failure. The patient needs to be continued on ventilator, and we can give steroids to decrease the airway edema primarily in case if there is suspected. And then subsequently, if the thing settles down, reassess the leak test, and then take a decision whether to extubate or not. Now, in case if there is a suspicion of airway compromise or collapse, then they should be done in the operating room under deep inhalation anesthesia with patient breathing spontaneously, and the tube should be removed over an airway exchange catheter or fiber optic bronchoscope. And in case if there is a difficulty of the airway obstruction persist while this is being removed, the patient should be re-intubated immediately, and then subsequent decisions should be taken for the surgical access as there is concerns about the collapsibility of the airway leading to the compromise extubation, and hence a tracheostomy may be warranted in these patients. This is a device which is COVID has made more popular, the use of Thrive or HFNOs. So the oxygen supplementation should be continued in these patients after extubation so as to give you sufficient time in case if some extubation failure happens in these patients. And hence, it is very, very important to continue oxygenation as we talked about during the initial part of airway management. Also in extubation, we need to continue oxygen for some time. Now, this is a very, very important aspect because the post-procedural care after extubation, especially a difficult extubation, they should be very, very careful. They should observe for airway compromise in a controlled environment, in a monitored environment. We also need to take care of any complications that these patients can have. In case these patients have airway edema, we should continue them. There is some reports which suggest use of the adrenaline nebulization for decreasing the airway edema that can be done for these patients. Also, when these patients have a difficult extubation and we're looking for awake extubation, they may have some psychological issues, and hence these patients needs to be counseled appropriately for these type of difficulties. Also, it is very, very important to document difficulties in the records. At times, these patients may require airway management subsequently for whatever reasons, and hence the difficulties and the strategies that we have used for these airway extubation plan for these patients must be documented. And it's also a good idea that not only the patient, but the responsible person should be informed, and use of airway alert form is very, very good option for these patients. Now we are seeing a lot of patients can have report possibility of long-term airway complication. Hence, especially those patients who have difficult airway, even at the time of intubation or extubation, they should be followed up for any potential complication of difficult airway management that can be taken care of. So the crux of the extubation is we need not to have panic in case we have done proper planning for our patients. We have a planned strategies, we have the expertise, follow a structured approach, and all the airway armamentarium are kept with good expertise remains the important tip for a successful extubation. Thank you so much.
Okay. Thank you, Dr. Rakesh Kar. Very excellent, informative lecture. Next, we have Dr. Philip Urdaneta. He is the professor in anesthesiologist from the University of Florida, and he's going to talk about the most important topic, human factors in airway management. That is what decides the patient outcome ultimately and our behavior in the crisis situation. So over to Professor Philip.
Well, to me, it's an honor to be here. I've been invited to speak in this prestigious event, and it's an honor to be here. Unfortunately, it can only be done via teleconference because of the circumstances that we all know and have been living for the past year and a half or so. So my name is Felipe Urdaneta. I'm an anesthesiologist from the University of Florida, and also the president of the Society for Airway Management. And what I'm going to be speaking to you today is about a topic that is very important, dear to my heart, which is human factors in airway management. And the question that I want to be addressing here with you, all of you today, is, are we bridging the gap? I first have to declare that the only conflict of interest that I have is that I'm human and that I've made errors. And I will continue to make errors, but I will try to learn from them. In all seriousness, I'm part of the advisory board for a company and consultant for another one, but had nothing to do with this talk today. And I'm speaking to you today from North Central Florida, which is an area that is well known for the alligators. In fact, my area is called the swamp, and that's where I'm coming from you today. Hope to see you soon in person someday. So I am fascinated by the duality of humanity and by us in general. We're very smart. We have tremendous capabilities. Things that come to mind, for example, there are many, but the International Space Station and the CERN Super Collider, they're amazing wonders of human intelligence and capability and cooperation. But there are times where our judgment, it also can come into question, and things don't always seem as right, and we make mistakes, and we made some very dumb mistakes, especially when we're under stress. Now, we all know that airway management, specifically airway management emergencies or difficulties, are high stress situations with very limited time settings, and therefore demand the best of us. So in order to understand, to improve our responses and to increase that basically our patients are going to have better outcome and we're going to be able to do better, we must understand the way we respond to such circumstances in order to improve and therefore can actually do better as a system. And that's my interest here today. It's a wise man who knows where the courage ends and stupidity begins. And unfortunately, all too often, we've actually have ignore that part, and we sometimes have made mistakes. Let me illustrate this with a real case that happened recently, not so close by. This is a patient that was scheduled for ambulatory surgery procedure. He's 68 years old. He's 232 pounds and has some mild medical issues, reflux, and that's why the team decided to do this procedure under general anesthesia. They decide a general rapid sequence intubation, and they start at 8:10 in the morning. At 8:15, they report failure, and basically they had failed 3 times at direct laryngoscopy. They claim that they had difficulty then face masking the patient because they suspected the patient had laryngospasm. So a second dose of succinylcholine is administered 7 minutes later. What they report is then they attempted a first generation supraglottic airway. The patient aspirates. There's commotion in the operating room. At 8:26, that is 15 minutes later, resuscitation efforts were ongoing because they still could not be able to establish an airway. At 8:31, 20 minutes later, they finally, with bringing some other equipment from nearby, an indirect laryngoscope, they're able to intubate the patient. And unfortunately, you know the outcome of this type of event and scenario, and the patient has to be transported to the main hospital for ICU admission, and the outcome is not good. All too often, we see similar cases like that. The pattern is very similar: persistence, delayed in calling for help, et cetera, et cetera. And what I'm interested in speaking today about and discussing is non-technical factors of airway management. That is, from the individual point of view, from the team, from the job description, from the organization, from institutional factors that can lead and affect our performance in airway management. If you think about it, when you look at what happened in this particular case, you probably identified many errors or gaps or holes in the Swiss cheese, if you want to call it. At the individual level, we can question the competence, the knowledge, etc. At the team level, did they identify roles? Did they have flexibility? Did they share knowledge? Did they have the proper resources? Did they have applied adequate communications? Well, probably not. But if you think about it, underlying to most, if not all airway emergencies, all airway mishaps, there's an underlying common denominator, which happens to be the human factor. And this is what I'm interested in speaking about today, because the more we understand it, then we can basically then train it better and harness our strengths, decrease our weaknesses, and perform better as individuals and as teams, which is what we all want when we're dealing with airway management. So what I'm talking to you today is about what's called mental ergonomics. That is the interactions of humans, that's us, and other elements of systems of work. In this case, particular case happens to be about airway management, which is our area of interest. And it basically deals with human-to-human interaction, human to system, and perhaps can lead to issues of mental workload, decision-making, performance, and reliability. What we want is basically to decrease the mental workload of the different members of teams or individuals, so improve the decision-making, improve the performance, and make them more reliable. Because if we don't do that, this is what's going to happen, is a mental explosion in which we did not do one or many things right, and therefore, basically, we collapse as a system. And I can tell you from personal experience, this actually happens if you do not have a proper system established. Now, I'm not talking about knowledge gaps. Knowledge gaps will always occur because most of our literature is limited. We don't have enough randomized control, multi-center, multinational studies. In fact, most of them, if you think about it, our evidence is not that robust because studies are very difficult to conduct. But basically what I'm talking about is non-technical issues, non-knowledge based issues here. Think about, or the way I approach airway is I think about it being a maze or a puzzle. And whether you work, as in cartoons described there, whether you work in the operating room or you work outside the operating room, for example, in the ICU or emergency department, or you're in a helicopter ambulance or car ambulance for that matter, what we do is when we're confronted with an airway, we have a limited amount of time to deal with the airway because we know that oxygen is limited. We have to assess not just the patient, but the situation at some point and many points during the management of the patient. We have to plan, and basically we have to implement our planning. The problem lies on the fact that if we have less time and we lost all time because of a variety of reasons, we go from planning to reacting. And that reaction, if it's not properly channeled or educated or has not been trained properly, can be catastrophic. Because let me explain something to you that perhaps is no surprise to anyone. Our response, specifically in high stress situations, such as airway management difficulties, is not always that great. Our stress, we are humans, therefore our performance is not always that great. Think about what happens right now. We have normal heart rates. I think we are all relaxed, and you're listening to me at this point, hopefully, and we're okay. But if we're stressed for some reason and time has become an issue, our heart rate may go up, and therefore the decrease in fine motor skills may happen. But if it goes further, if the stressor continues, then complex motor skills will deteriorate, and then our senses will begin to deteriorate. Auditory, peripheral vision, central vision, and then our cognition will be completely deteriorated. So if we do not have adequate control of ourselves, then more than likely we will have a bad outcome when we're dealing with a stressful situation. You see, we are the sum of two complementary parts and systems. One of them is the rationale, and basically it's a reflective, slow, conscious mechanism in which we basically analyze data, we study, we read, we looked at statistical differences, et cetera, it's conscious, and we are basically dealing perhaps at this moment. But the other one, especially in emergencies, we deal with more intuitive, reactive, fast, automatic responses. And those can be affected by a variety of reasons. And a variety of reasons that basically range from basically even fatigue. If we're fatigued, if we're hungry, et cetera, our response might not be adequate. Let me point out something, a quote of fatigue that actually deals, it's in general, but it deals a lot with what we do with the airway. McKay said, the fatigue may fools of all of us. It robs us from our skills, our judgment, and blindness to our creative solutions. Well, how much more do we need during a difficult scenario that we need all that, and fatigue may actually take away from that. But it's not just fatigue. I'm just bringing it up because that's something that happens, and this picture actually illustrates what we've all been living this with COVID-19. It's also our cognitive biases that happen, and we all have them. But if not properly trained or harnessed or coached, it may actually influence our proper responses and deal with negative consequences. But it's not just individuals that we need to talk about, it's also about our organization. How is your communications at work? How is your dealing with other colleagues, et cetera, et cetera? Have you formed a teamwork? Is your teamwork cohesive, et cetera, et cetera? How is your work design? Resources, do you have adequate resources? If you, for example, work in the ICU, do you extubate in the middle of the night and elective patients? It might be so that you do so, but when you do that, you know that you perhaps don't have the same resources if you were in the middle of the morning. So things to think and consider, and also deals with equipment when we talk about airway management. When we talk about airway, we always think about airway management guidelines. And one of the things that I think at this point we haven't made much progress is, which side are we appealing with? Are we appealing with the intuitive or the reflective one, the rationale, or basically the one that's more reflective, kind of automatic? And I think we have to appeal to both, but we have to understand that the information needs to be given differently. And I think that right now we don't have that well structured. What we need is basically, this is completely my opinion, is to be able to be given patterns in a context situation. And I think the most important thing that I've distinguished and that I try to teach is that there's two types of airways. There's the elective, in which we have time for planning, for preparation, for personnel, for equipment. And there's the emergency ones, in which we basically have to think about reacting. We have to define, declare, and we need to establish a clear path for an exit strategy. And to me, the most common thing and something that we deal on a daily basis is a traffic light signal. So at some point or another, I always assign red, yellow, and green, and basically stop or go at each situation. And basically, depending if I find certain patterns and certain context, then I will continue or go. And I think that's one of the things that if I was presented that way, or we need to present that better for other people. See, to me, the stable patient allows me to use mitigation and optimization plans if possible, and you can see them there. I don't want to get into each of them because I don't have enough time. But this is what we do on a daily basis. However, if we failed, or if plan A failed, or plan B failed, or C, or all three of them, and our patient's destable, we need to plan for an exit strategy. And that exit strategy should be clear to everyone in the room, in the team, or wherever you are, in the emergency room, ICU, et cetera, et cetera. On the other hand, the critical airway gives us even much less time. And for that, we have a red light, as you can see there from that cartoon that you see there on the screen. And basically, everything has failed. Mitigation and optimization plans have failed. So at this point, we need to declare failure and be clear about this to everybody around us. And at that point, we need to have an exit strategy, which is obviously the invasive option. There's no other time. If we continue to hesitate, our patients are going to be harmed. My point to you is that we need to think about a crisis ergonomics to increase our proficiency. We need to have simple options so that we can act fast, and because we know that we are pressed on time, we might not have any time at all. If we hesitate, we're going to have a bad outcome. I don't need to, in the middle of an emergency, some complex mathematics analysis of data or statistics. I don't need that. I only need kind of a 3-point or 3-option corner, so to speak. Yes, no, and depends. And depends, obviously, because each situation is different. One size does not fit all. It may be from different populations, different contexts, whatever it is. But that's the only thing I need that's going to help me respond adequately. Safety is something that happens between your ears, not something you hold in your hands. And that's very important, because if we don't have our mind trained to respond to situations, no piece of equipment is going to be able to get us out of the jam that we're in. This also includes equipment ergonomics. And what do I mean by that is, what if we look at it, if we're presented in the middle of a crisis, or if they were, for example, in that example that I showed you, they were presented with a clear set of pictures of methods to get out of the jam that they were in. So a card comes to mind, but it can be a bag, whatever it is. But as long as presented in a sequential, logical fashion, each time the same way, likelihood is that you're going to be able to have an adequate response. I don't have time to go over the card, but that's the principle that is being proposed around the world. And by the same team, the team ergonomics is very important. If each of the members of the team has a specific role, and there's one clear pathway of information, emission, revision, et cetera, then likelihood is that we're going to have an adequate outcome. Every time that I see this is basically is not organized fashion, and that only leads to chaos and more harm. Something that I want to leave you with is a clear example, as you see in New York City, and the partnership that happened in that January of 2009 between the Captain Solberger and Jeff Scali, his co-pilot, is they were able to land that plane safely in the Hudson, but because they developed a partnership. One was in charge of finding a solution, the other one was in charge of trying to restart the engines. And by working in tandem, both together, they were able to unload one of another. Sully was able to find a solution, while the co-pilot Scali was trying to work on another solution, a different one, but they were working in tandem. So that way they were able to do that. So what you have to consider is every step of the way for airway management, we need to consider our two complementary parts, the rationale thinking part and the automatic reflective part. And by harnessing both, by giving information differently at different times to both, we'll be able to perhaps be more efficiency. So the human factor is one of the most important, if not the most important factor, and basically what we call the basic building block in airway management, but also the basic building block that if not harnessed and properly trained, and can also lead to negative consequences, as we saw on that image. And I'm pretty sure that you guys have similar examples to what I do. So hopefully in the future, we will understand more this human factor. We will be able to work on this a little bit more, even though it's difficult to measure, it's difficult to study, et cetera, et cetera. I think is one of the most important and the next frontier in airway management that we need to solve. So with that, because of lack of time, I have to leave you. Thank you very much for the invite once again. And it was a pleasure to be here. Looking forward to seeing you in the future again. Thank you very much.
Thank you, Dr. Philip. Excellent talk. Dr. Amit, you can continue with the discussion. Yeah.
Thank you very much. We've had 3 excellent talks. Over to you, Amit.
Yeah, thank you. I think I'll start with, we'll see. I don't think right now there are any questions in the chat box. So to Dr. David Brewster, now, you know, by the time we realized that we were having troubles and we developed all the guidelines, but things have changed substantially now. We don't want to, like, the mask ventilation is now safe, high flow nasal oxygen, NIV is present. You can use supraglottic airway, you can use, yes, intubation, you need to use video laryngeal. So can we just assume that, suppose tomorrow if I have a patient, I need to be prepared, like I have to have a proper PP, but rest all, all team members should have PP, but all rest should come to almost normal or same what we were before? All other part of management?
Yeah, thank you very much for having me, Amit and Sheila, and for the questions. I think a lot has changed since the publications of the guidelines 18 months ago. The staff are much safer through vaccination, and as you've mentioned, some of the aerosol generating procedures are not considered to be as dangerous. I think that PPE is still probably the most important thing, as well as video laryngoscopy, and keeping the team processes consistent, making sure those who are part of the intubation have a clear understanding of what their roles are, and making sure we have the most experienced operators to secure the airway as fast as possible. There is still risk. There's still risk from multiple modes of transmission. So it's not something that I think we should start to take lightly, just because some of the procedures are considered a little bit safer. And probably what the guidelines that we wrote back in March are probably still the right way to do things, and probably don't need to be changed much. I think pre-oxygenation is one thing that we can address. High flow oxygen and CPAP are considered much safer, and in certain patients may be considered for modes of pre-oxygenation. You may have patients with concurrent disease such as pulmonary edema or airways disease where non-invasive may be beneficial, and there may be patients with airway anatomy where high flow oxygen or apneic oxygenation should be considered before and during intubation. And given the quality of PPE, and now that we have vaccinated staff, I think that is something that is safe. And then there'll be certain patients where we should put the safety of the patient at the forefront of how we plan our airway management now. Whereas in March of last year, I think there was a lot of phobia around being in the room with a patient with COVID, and there was a lot of healthcare anxiety that we were dealing with as our primary motivator for our airway plan.
Thanks, David. I agree with you that our understanding about various procedures have changed over time. Practices have evolved, but if I understand correctly, you're saying that even though we're vaccinated and we have adequate PPE and that will be protecting us, we still need to, as far as possible, minimize the exposure and try to avoid too many aerosol generating procedures unless it's going to be beneficial to the patient. Am I correct in saying that?
Yeah, 100% agree, Sheila. I think there'll be certain patients, those with a known difficult airway, where you may now consider high flow nasal oxygen before and during intubation, but you should still distance yourself from the airway through video laryngoscopy and wear appropriate PPE and have the most experienced airway operator in charge of securing the tube quickly.
Yeah.
In fact, some of the guidelines, some of the points which we actually covered in the guideline would probably remain with us forever. In the sense, we have developed something which is better and good, and we may not change that even when probably COVID is not there. Okay.
Yeah, and I think Philippe touched on some of the more important things now around human factors and how we all interact as airway teams now in performing the task of intubation, and those may appear more in the guidelines of the future. I think it'll be exciting to see what Puma comes out with in the next year or two, but certainly COVID brought checklists and team structures and communication to the forefront of how guidelines were written and how they were disseminated to all of our healthcare workers.
Thank you, David. So Rakesh, Dr. Rakesh, suppose there are two limbs, limb 1 and limb 2. One is for the where you need smooth extubation, and one second is probably you have difficult airway. So if the others are for difficult airway, suppose if they have a combined, a neuro patients were done for the brain surgery, and you want to actually now want a smooth extubation as well as you want to be safe. So then how do we proceed in such a situation?
I think a very important question. In fact, practically it happens also where we want to optimize the hemodynamic response. But as you mentioned, both the options, depending upon, as I mentioned in one of the slides also, the individual assessment, you can do it. For example, say we want to have an intubation on an airway exchange catheter, and simultaneously we can think of giving some drugs which can optimize the hemodynamic response, like we talked about the lidocaine, we talked about the beta blocker. So we can use the combination techniques here. But the point here is when we're talking about awake versus deep sedation, or when we're talking deep extubation in these patients, we should be careful, and based on individual assessment of that particular patient, we can take a decision. As you mentioned, it's a difficult airway, so we cannot think of a deep extubation in this patient. So a combination of drugs would be a better option. And second thing is, important aspect is we need to have a backup of a difficult airway cart. And these extubations should be done under monitored areas. They should not be done in a recovery area where we don't have facilities or in the ward. It should be in the ICU or a high dependency unit or a recovery area which is fully equipped, or preferably maybe in the operating room itself, wherein we can use combination of these limbs.
Can we use, I think we have described in guideline probably that we can combine use of supraglottic airway and airway exchange catheter, like you remove airway exchange, remove endotracheal tube over airway exchange catheter and then railroad supraglottic over that, so that things are now different. Now you are actually extubating over supraglottic airway and as well you have airway exchange catheter in place, so that in case if you need to re-intubate.
Absolutely, I think that's a very important aspect. But let's say, let me give an example. Say a base of skull surgery from the maxilla and going to the base of skull. So it's a difficult airway, difficult extubation because of surgical distortion, and it's an intracranial surgery also. So in this, putting up a supraglottic device may not be a good option. But yes, exactly you're right. Based on individual assessment, if a supraglottic airway device can be put over an airway exchange catheter, very good. If you think that a supraglottic device is not a good option, especially like after head and neck surgical procedures, in this you have to be safer enough, and you can make them awake, but simultaneously obtain the response using drugs and then extubate over an airway exchange catheter subsequently. And then as we discussed in one of the session by Dr. Sheila also about delayed extubation. So that could be one option till the things are settled down. And during this, again, we need to use the pharmacological agents to obtain the responses.
Thank you very much, Rakesh. You've explained this very beautifully. I'll move on to you, Professor Udinita. Now,
Sheila, can I ask one question to Dr. Rakesh? Yeah, basically, we are always talking about awake and deep. Don't we have anything in moderation where we are doing something like a glide extubation? Why are we looking at only the two extremes? I'm sure every extubation should be a smooth extubation. And we are talking about all other drugs, but are we including inhalational agents when we are looking at, extubating the patient smoothly, controlling the hemodynamics? And secondly, when we are talking about extubation here, always it is that the stepwise approach. Are we failing to identify something, and failure to identify few things is leading to your re-intubation or extubation failure? Because we are talking about all the future things, but where are we going wrong in identifying correctly? Can we a little bit discuss about that?
Dr. Shweta, I think your points are very, very well taken. This is, I think, very practical points. When we talk about sedation, it's not so easy to say that I'll put a Ramsey sedation score at this, because they become variable. So that's why we say deep extubation versus awake extubation. Even awake extubation has to be smooth. It should not be very stormy extubation. For all patients, it should be smooth. That's why we have to use a combination of various agents, which Dr. Amisha was also mentioning. Second thing is, we also have to predict the things. I think in last 3 days or so, we have been talking about if we can predict and prepare ourselves for the future things happening, then we can avoid them. At times, we may not be able to predict them, and that's why we are keeping everything ready for any event that happens. And I think that's the success and mantra of extubation. So be prepared. Be prepared.
Okay, one more question then. Then when do you start your reversal? I think that's a very critical point where we start our reversal for our neuromuscular blockade.
I agree. I think in all difficult cases, I think that was not preview for today's session, but yes, we need to use the neuromuscular blockade, the neuromuscular monitors for these patients, because one of the reasons for extubation failure is inadequate respiratory efforts. And then we have to use these monitors to say that, yes, this is the extubation point. And there are a couple of good studies in the recent past also, where they mentioned in any difficult airways, any complicated surgical procedures, the use of these monitors is very, very important to point a time for a safe extubation. You are absolutely right in that aspect.
Thank you, Shweta. If I may now ask Professor Udinita. Thank you. So I think David raised a very important point that all these things, and also Amit said a lot of things that we emphasize for the COVID guidelines are probably here to stay. And one of them is good team communication that was highlighted during the COVID time, because it was very difficult to communicate by wearing PPE. Now, what is your, we all know the importance of human non-technical skills during airway management. But even though we acknowledge that this is a problem, it's really difficult to get people at that point to react in an appropriate manner. So how do we go about, how do we go about getting people, not just the specialists like you, but other people, good at this, familiar with non-technical skills? How can we do this?
Yeah, I agree with you. This is one of the hardest things. And this is perhaps why it's the last frontier in airway management. And we keep kind of putting it to the side. In other words, something we keep working on it. We have a bad outcome. We increase the briefing and then things fade away until the next crisis. And this has been happening throughout the history of airway management. And it's, remember, one of the things that I always say, as long as we're not training the people we're working with, and that's just not anesthesia or emergency teams or ICU, but we also have to train our nurses if we're in the operating room. And as long as we don't do that, we're going to keep having the same problem, and it will be like the first case ever again every time it happens. So this is why I think this is crucial. It's not easy, but I think in the future it will be cost effective, because if people know what to do, then as I always say, well, we always use that analogy, and I don't like it, but let's just say the Formula One pit stop. Everybody knows what they have to do, and that's why they can do it in 1.82 seconds. That's the record. But that's because everybody knows what to do. Here we are, and if you're the leader, you're gathering equipment, you're dealing with your trainee, you're teaching how to get the laryngoscope to the right side, to point to the left, whatever it is, where's the suction, and things become chaotic. So I think acknowledging it and understanding that it is, in my opinion, obviously I don't have a quantification method, but in my opinion is 80% what we do in a difficult situation is the non-technical aspect. The tool that you use, 20%. But if you don't have the other part done adequately, and that's include communications, that's everything that is included, then I think we're going to be perpetuating this kind of problem.
How do you suggest we do this? With simulation-based training, or just get people to get exposed to different high-risk cases and settings? Another problem in India is, there's a kind of hierarchy, and people are often afraid, nurses are afraid to tell the doctor that perhaps they should do this, and your juniors are afraid to tell the seniors. And we saw that happen also in the Elaine Bromley case. So what do you think? Is it a combination of all this, or should we just focus on a particular aspect of training?
Well, it has to be simulation, the best method possible, because the other one is too costly. And I mean that by costly in lives, because we cannot all learn by mistakes. We cannot make all mistakes again. And we don't need another Elaine Bromley with a different name. We need to make, I always say, I will continue to make mistakes, but it will not be the same one I made last week. That's kind of the idea. And I think simulation is the best way. It is difficult because it's hard to quantitate, and it also time consuming, but I think is the best option of all the possibilities, is the best option possible.
Right.
So I think
one quick question.
I have realized that probably when we had a simulation workshop at our place in Vadodara, I realized that only anesthesiologists were involved. And in fact, now we should involve all the nursing staff, and other people should be there as a part of a simulation team. And when they learn, they should also learn simulation, not only anesthesiologists. There is a one quick question Dr. Divatia sir has asked to Dr. Brewster. Should we continue to treat bag mask ventilation and the tracheal intubation as aerosol generating pressure procedure? Yes or no? What should we do now?
I think we should still consider them to be procedures. I spoke about this, I think, in the Difficult Airway Conference a few months ago, that we should still consider them to be risky procedures. So whether they generate aerosols, they still put the clinician at close proximity to the airway. So they're still at risk of fomite, droplet, aerosol, multiple modes of transmission, which we saw from SARS, how many intubators contracted the illness. So I think that they should be undertaken with caution, and certainly we should use PPE. I don't think there is aerosol generating as what we once thought they were, but they certainly are still risky procedures.
Right. Thank you very much. Thank you to both my co-chairs. And I think in the interest of time, we'll wind up the session. Please stay back for another 15 minutes just for the valedictory function. It's an informal function. I hope Dr. Suma is here. I request Suma to please take forward the proceedings.
Thank you.
Dr. Suma Shetty, are you here?
She got disconnected.
All right, we'll just start in a minute. Our General Secretary is just logging in. Thank you so much to all of you for staying back, because I know we're running almost 25 minutes late. So it won't take more than 15 minutes, I assure you. But we cannot end without thanking everybody and also giving out prizes to our winners who are eagerly awaiting to receive, for the list of winners to be announced. We had paper and poster presentations today, yesterday and today. And we also had a very exciting quiz. So we'd just like to declare the winners and also express our gratitude to all the people who are behind running this important event. Dr. Suma, are you here? Has Dr. Suma logged in? Okay.
I think we can just call her and tell her to join.
Yeah,
she's there. She's just joining.
Wonderful, wonderful. She's here. I can see her. That's Dr. Suma Shetty, the General Secretary of All India Difficult Airway Association. Over to you, Suma. She's here.
Good evening. Welcome to you to the valedictory function. After the long sessions of the last 3 days, the deliberations and discussions going on, I think it's time to part ways. And before we part ways, we have our award sessions. We had our paper and poster presentations. We have many people who have took part in this and were part and parcel of the program. And we have them here where the awards are to be announced, and also a quiz, airway quiz, which is one of the biggest attraction in NAC, that is to be announced here. The quiz winners have already been, you already know because it was told, but then we have to announce the awards now. I welcome you all to this function, and I will have with me Dr. Rakesh Garg, who will be running the show with me. Rakesh, can we have the slides and we can invite people? We have with us Dr. Ramkumar, Dr. Pankaj, Dr. Divatya, Dr. Sheila, Dr. Apesh, Dr. Amit, Dr. Rakesh will be with me for this program, and we have our guest faculties, Dr. Bhatia sir and Dr. Rakesh Kumar from Jodhpur. Over to you, Dr. Rakesh Garg.
So we have the award ceremony here, as mentioned by Dr. Suma Madam. So we have this award ceremony, which was having papers presentation as well as we had posters presentation. So a special thanks to all the judges and the AIMS Jodhpur team who has helped us a lot for the last 2 days. Not in last 2 days, I think it was a couple of days where everybody of these judges and the coordinators from the AIMS Jodhpur team has worked a lot to look after these papers and bring them into a presentable format. So thank you, Ida, thanks to them for all their efforts. So I will request Professor Dr. Ramkumar sir to announce the results for these papers. Dr. Ramkumar sir.
I'm sorry, Rakesh, you'll have to bring up the slide because even I'm not aware who the prize winners are. Okay.
Yes.
So for session one, we had, I think, three sessions for the oral presentation. The second prize for the session one goes to Dr. Venkata Prem Kumar Sangamala from AIMS Jodhpur. a big hand to Dr. Venkata Prem Kumar. The first prize in the same session went to Dr. Karen Candice Selvin from MDM Hospital, Jodhpur, for her paper on comparison of dexmedetomidine and with ketamine for awake fiber optic intubation. Once again, let's give her a big applause. We want to ask Dr. Pankaj to announce this.
Sir, you do the honors for this session also.
Okay, sure. So session 2 on the oral presentation, the second prize went to Dr. Sharmi Makwan from Medical College, Baroda and SSG Hospital of Vadodara. Congratulations to the prize winner. And the first prize in the same session, if Rakesh can bring up the slide, as much a surprise to me as well. First prize goes to Dr. Muazzam Hassan from JNMCH AMU Aligarh. The topic on which they spoke is there on each slide. On session 3, again the oral presentation, the second prize went to Dr. Ayushi Saxena of the Jawaharlal Nehru Medical College and Hospital, AMU Aligarh. And the first prize in the same session went to Dr. Jyoti Elizabeth John of Kasturba Medical College, Manipal. Big hand to both the winners on session 3.
So thank you so much, sir, for doing the honors. May I request Professor Dr. Pankaj Kundra, sir, to do the honors for announcing the further results. Over to you, sir. Professor Dr. Pankaj Kundra, sir, please.
Thank you, Dr. Rakesh. So the session 8 oral presentation, the second prize goes to Dr. Ankit Vyas from SN Medical College and Attached Hospital, Jodhpur. Congratulations to Dr. Ankit. The first prize or the winner's prize is to Dr. Sumedha Vashisht from BDMS PGIMS Rohtak. And let's give her a big hand. Congratulations, Dr. Sumedha, for winning the first prize. Session 9 in the oral presentation, the runners-up is Shalvi Mahajan. She's from PGI Chandigarh. Congratulations, Dr. Shalvi. And the first prize goes to Dr. Pradeep from Calcutta National Medical College and Hospital, Salem. Congratulations, Dr. Pradeep. A big hand to you. Well done. Session number 10 in the oral presentation, the runners-up is Dr. Kirti Chetrapal from PGIMS Rohtak. And the first prize goes to Dr. Shivani Gupta from AMU Aligarh. Congratulations, Dr. Shivani, to win the first prize.
So thank you so much, sir. Thank you for doing the honors. So may I request Dr. Professor Pradeep Bhatia, sir, to do the honors for announcing the results of the poster. Dr. Pradeep Bhatia, sir. Dr. Professor Pradeep Bhatia, sir, to please announce the results for poster awards. I think there is some network issues with sir, so he'll be joining soon. May I request?
Yeah, I've joined. Yeah, I've joined. I've joined.
Sir, please do the honor, sir.
For the poster presentation, session 4, the first prize goes to Dr. Niti Jayesh Desai from GM ERS Medical College and Hospital, Ahmedabad. A big round of applause for Dr. Niti. And for session 5, the first prize, posters presentation, first prize goes to Suchetna Pramanik from Kidwai Memorial Institute of Oncology, Bangalore. For session 6 poster presentation, the first prize goes to Dr. V. Thakkar, Tata Memorial Hospital, Mumbai. Well done, Dr. V. Thakkar.
Thank you so much, sir. Thank you so much for doing the honors. May I request Dr. Professor J.V. Divetia to announce the further awards. Dr. Divetia, please.
So the prize for the session 7 poster presentation, Dr. Shilpa Popley from Dr. B.D. Sharma and PGIMS Rohtak. Congratulations, Dr. Shilpa. Session 11 poster presentation, first prize, Dr. Vandana Arora, again from PGIMS Rohtak.
So over to the Dr. Suma for further proceedings, please.
So, thank you. Yeah, go ahead, Suma. Yeah, if I may. Yeah, so thank you very much to all the people who facilitated this. And I want to here mention a special thanks to Dr. Rakesh Garg from All India Institute, also Dr. Zulfikar and Dr. Jason from Tata Memorial Hospital, Dr. Rakesh Kumar, Dr. Bharat Paliwal, and Dr. Sadiq Mohammed, all of whom helped to facilitate the paper and the poster sessions over the last few days, because I know it's been a lot of work, and it's they have been after this for several days to get all this organized. And congratulations again to the prize winners and to all the judges who facilitated this event. Now we have the prize for the quiz, and I see Dr. Is David here and Felipe. It would be great if you could do the honors by announcing the names of the prize winners for the quiz. Rakesh, if you could just show the slide again. Is David here? Okay, then perhaps Professor Felipe, you could just call out the runner-up. Each team had 3 members in their team. So we have the runner-up and then we have the quiz winner.
Well, before I do that, I would like to thank everyone again for wonderful organization, amazing meeting, and for me personally, nice to be here. And for the winners, the runner-up team, I hope I don't butcher the pronunciation, but basically I will. But it will be with humility. It will be the runner-up team is Drs. Deepshanshu Dang, Pallavi Sahu, and Somya Goel from IIMS Jodhpur. So that's the runners-up.
And the winners are?
The winners are Senthil Kumaran, Rakup Prasad, and Revati Sashi Nair from Pigmer Chandigarh. And once again, I would like to apologize for the butchering of this. Was not rehearsed. Otherwise, I would have actually been asked for. That will be a human factor thing.
Right.
So think about that.
Thank you so much for doing this at such a short notice as a special request. We are really grateful to all the faculty who participated over the last few days, all the delegates who took time out in these difficult times. And we would have really liked to be physically in Jodhpur. Jodhpur is a beautiful city in Rajasthan, and be there physically and experience the hospitality of our organizing team. We are very grateful to the organizing committee for the hard work over the last 1 year to make this meeting a big success. I would like Professor Bhatia, who is the organizing chairperson, and then Dr. Rakesh Kumar to say a few words. They are the organizing chairman and the organizing secretary of the NAC 2021.
Yeah, I would like to also say
Bhatia.
some few words if
Yes,
possible.
yes. Professor Bhatia, please.
Well, thanks to the organization, IDA, for posing faith with us and trusting us in difficult times to organize this conference. It is real difficult time. To get the sponsors for a virtual platform is not easy, because to convince them that they will get worth of their money, it's not easy. And to rope in good speakers, of course, IDA did a tremendous job for that. And first 1,000 free registrations were a big incentive for the residents, the junior doctors, and it was an overwhelming response particularly for the workshop. So it was very well designed scientifically, very well executed, and for all these things, I wholeheartedly thank to the organization, the scientific team, Sheila, and everyone associated for. Of course, we had the manpower. They worked hard for a very long time. For last at least 20 days, they were working very hard to make it happen properly. But then without your support, it would not have been possible. But
Thank you
yes,
so
we are
much.
looking forward. But we are looking forward for a physical conference in future also.
Thank you so much, Dr. Rakesh Kumar. He's been the silent man behind the scenes, coordinating everything, and he's been facing all the brickbats from the IDA Central, trying to arrange everything, and difficult, challenging during, everything when it's virtually. So, Dr. Rakesh Kumar.
Ma'am, thank you. Yeah, good evening. Yeah, on the behalf of organizing committee, I would like to thank Dr. Sheila Mantra, President IDA, and Dr. Sumalata Sethi to giving opportunity to host this NAC 2021. So in very short notice, it was difficult to us, but we try our hard to make this successful. And I would like to sincerely thank to all office bearer of IDA, all past president, vice president, GC members for their support. And my sincere thanks to all the faculties who share their experience and all delegates to register and.
Right. Thank you very much. We are really grateful. Do convey our congratulations and thanks on behalf of the IDA Executive Committee to the entire local organizing team. I would like to also mention here that the quiz today was really excellent. It's a very popular event at NAC, and it just gets better and better each year. And I really wish to sincerely thank the quiz masters, Dr. Shripad Mendele, Dr. Murli, Dr. Mrityunjay, and Dr. Rakesh Kumar, who really, made this an excellent event, very popular event. And I'm sure, congratulations, of course, to the winners, but even to those who did not win and enthusiastically participated in this, because this was a program that was very well appreciated by all the delegates. I'd just like a word from Professor Ram Kumar, the editor of our journal, Airway. If you could say a few words, followed by Dr. Divatia and then Dr. Pankaj Kumar.
Yes,
Ram Kumar.
I think this is our second virtual meeting in succession, and I think we have literally set the virtual bar higher this year. I think we're doing better and better, and thanks to all the speakers. I think it's a very well thought out program, and we may have a good plan, but as many speakers said, it's all in the execution. And just as in airway management, you can have a plan that can go haywire. I think it's very important that you have a plan of action, get the right people into the act, and then make sure that everything goes well. And I think it's been a joint effort of a huge team. And thank you very much. I mean, it was an amazing experience to be part of this conference.
Thank you, Professor Ram Kumar. And we are very grateful to Professor Ram Kumar, the editor of our journal Airway, because all the abstracts all the papers and posters that were presented at this meeting will be published. The abstracts will be published in our journal, and we are very grateful to you for that. I now request Professor Divatia, my colleague, my boss, and also the past president of IDA, who will now be going out of the executive committee, to please say a few words. Professor Divatia.
So thank you, Dr. Sheila. So it's been an amazing meeting. Of course, we have to thank IDA for organizing this in very difficult circumstances. Thanks to Dr. Bhatia, Dr. Rakesh Kumar, and the team at AIIMS, Jodhpur, for organizing and for the flawless execution of the program. If there were glitches, only you know about them. We didn't see anything. It was fabulous. So thank you very much for that experience.
Thank you, Dr.
Thank IDA for this amazing journey that has been there for the past so many years. And of course, I will not be on the committee, but I'm of course going to be there with IDA all the time. And I wish the new team all the very best. I think Dr. Sheila and her current team have taken IDA to a great new level. And I wish the new team, Dr. Pankaj Kundra, leading as president, all the very best. Yeah.
Thank you so much, Dr. Divatia. I request the incoming president, who's going to be taking over after me, Dr. Pankaj Kundra, to please say a few words.
Thank you, Dr. Sheila, Dr. Divatia, and Dr. Ram Kumar. It's been a privilege to be a part of the IDA family. I think we have grown, and we have grown also in the context of content and the way the scientific sessions have been conducted. I really thank the organizers of NAC 2020, Dr. Bhatia and Dr. Rakesh Kumar and their team, from AIIMS Jodhpur to have made this such a successful virtual event, and also AIDA members and the executive committee, who has done a fabulous job to back them up to conduct this meeting in a short time. The scientific content was excellent, and as we look forward to 2022, I'm sure the branch at Bangalore would do equal honors, and we look forward to a physical meeting to happen in Bangalore next time. Thank you, all of you, and we wish everything goes well. Thank you, Dr. Sheila. Namaskar from us.
Thank you so much. Professor Mohit wanted to say something. Over to you, Professor Mohit.
Yeah, at the outset, I must congratulate the team Jodhpur, doing an excellent job. We did good, but they did the best. And I think Bangalore will be doing the better. I mean, they will be doing much better than what we have done. And that will be something which is, offline. I mean, we live conference. So naturally, it will always have a feel. We'll get the touch of it, what conferences are basically.
Yeah,
at the same time, I would also, thank the organizers and especially the headquarters, AIDA headquarters and the organizing committee for giving me the scope and opportunity to deliver my thoughts in the oration. I'm really thankful to all of you. Thank you so much.
Thank you. Dr. Rakesh Garg, our Vice President, if you would like to say something, a few words. He has been really the backbone behind arranging this meeting and has helped me tremendously in a lot of activity. Dr. Rakesh.
Thank you so much, ma'am, and thank you, AIDA, and thank you the whole organizing team for giving this opportunity. It was a wonderful show, and I sincere thanks to all the team members, even this to be a part of it. So thank you so much.
Dr. Amit and Dr. Apex, if you are here, if you'd just like to say a few words quickly.
Yeah, it was really an amazing experience, excellent scientific session.
I think we should congratulate the Jodhpur team and back ourselves as an AIDA executive team for doing good job. This was a wonderful meeting, and we hope that we can continue. The new team can continue this work in the future. Thank you all.
So,
it was really
thank you,
it was
everybody.
really an amazing experience.
Right.
Absolutely finest execution and excellent scientific content. Thank you,
Thank
team
you so much,
Thank you, team AIDA.
Dr. Amit and Apex. And on behalf of the entire AIDA Executive Committee, I wish to thank all the international faculty, the national faculty, the local faculty, and the local organizing committee, all the delegates. And now I will hand over before I give my concluding comments to my colleague, my dear friend, and the person who supported me throughout, Dr. Sumalata Shetty, the General Secretary of AIDA, to say a few words.
Thank you, Sheila. It has been a great honor to see AIDA grow from the small city of Mangalore to the international platform. An opportunity given, I was in the right place at the right time. That's all happened. I'm so very happy for the opportunity that I got, and I thank all the executive committee members and my close colleagues in AIDA, my family members, for having supported me throughout this journey. Thank you, one and all.
Thank you so much.
Sheila, we could have given a standing ovation to both of you, but unfortunately, we cannot give it now.
Thank you very much.
You have to do.
Let's all give a big
standing. We can give a clap. Yeah, great clap. Yes, sir.
Big clap to AIDA. Thank you very much, Dr. Felipe, for staying till the very end of the program. I wish you all the very best. Stay safe and see you all in Bengaluru next year for NAC 2022. Thank you very much.
Before we discuss, we will have a national anthem.
Yeah,
Right.
Before this, that's true, 100%. So let's stand up.
Okay, who is reading it?
Mana Adinayak
Jaya Mana Adinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Uttara गौडवङ्गा विन्ध्य हिमाचल यमुना गङ्गा उच्चल जलधितरङ्गा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, everybody, and have a good night. Good day. Bye.
Bye.